Samir, can you check? Okay. Good morning, everybody, and good evening to the rest of the world. And I am sure many from all over the world are logged in. And we are at Nair Medical College. Thanks to Professor Naina and the Dean for giving us this opportunity to do the CME here. And thanks to the Maharashtra Medical Council for giving 2 CME credits. And I request Dr. Chaya Shinde to chair the session, and Dr. Shruti Shirvalkar to co-chair, and Dr. Jaydeep to moderate, and Sneha is still not reached, and Mansi to take over as the rapporteur. So the idea of encouraging Mansi, and we also have volunteers from Khalsa College to promote the CME for the doctors who are going to attend. So can I request Chaya Madam to start? Madam, you can take the chair. So I am Professor Dr. S. Natarajan, also the Chief of the Aditya Jyotaya Hospital and President of Asia Pacific Ophthalmic Trauma Society and past President of Ocular Trauma Society of India, where and we have Professor Gangadhar Sundar as our chief guest for the CME, and both of our endeavor is to promote repair of eye injuries so meticulously, not only to shave the globe, but also to restore vision. And apart from that, we want to do advocacy to prevent ophthalmic trauma, because the injury produces a lot of problems to the child or the person, and also loss of working time, and if he is a breadwinner, even loss of income. So with this, can I request Dr. Chaya to... Dr. Chaya, you have a more free floating mic there? Madam? Samir, ek mic dena, madam ko. And Mansi, you can sit with madam. Mansi, you can go with madam, no? Go in that side and sit, no? So that... but you can go and help the next speaker. And timer, 9 minutes. So we are, since the people from all over the world will be watching, apart from the people who are attending, we are going to stick to the time. At the end of 9 minutes, there will be a bell. So can I have a Khalsa College volunteer to come so that you don't know the speaker? Whoever is the speaker, whatever time allotted, 1 minute before you will give a warning bell, and at the end of 10 minutes, the talk has to be concluded, and the next speaker will start. Thank you. Thank you, madam.
Good morning to all. I welcome Dr. Natarajan, Dr. Gangadhar, Dr. Naina Puddar, Dr. Shruti, Dr. Jaydeep, and all students and participants and the audience. I thank all the organizers and the technical team also. We will start with the first session. Yeah. So, can we start with the first session? Yes. So, I welcome Dr. Jaydeep Walinskar. He has 15 years of experience. He's a seasoned vitreoretinal surgeon, and he has been trained under Dr. Natarajan in Aditya Jyotaya Hospital. He has done his fellowships in Sankara Nethralaya, and after that, he was for 6 years, he continued to give his services at Sankara Nethralaya. Presently, he has joined Sri Ramakrishna Nethralaya, and he is working in Chembur, Thane, Vashi, multiple places. He has keen interest in research and academics, and has presented multiple papers in national and international conferences. Dr. Jaydeep, can we have an overview of posterior segment trauma from you?
Good morning, everyone. At the outset, I would like to have my heartfelt gratitude towards Dr. Natarajan sir for inviting me to be a part of this unique and excellent CME on trauma and adnexal trauma. So I am a posterior segment surgeon, so I'll be giving an overview of the trauma as well as posterior segment trauma to start off so that we can have some perspective towards management of trauma as a whole. So let me start with posterior segment trauma. The overview includes an introduction to the ocular and adnexal trauma, clinical evaluation, the individual entities which include closed lobe injuries, lens dislocations, vitreous hemorrhage, commercial retinae. Then there are retinal tears, avulsion, vitreous-based retinal detachments, macular holes. These are all a part of posterior segment trauma. We have open globe injuries which affect the posterior segment like intraocular foreign bodies, perforating injuries which include retinal detachments, choroidal detachments, and posterior lacerations which cannot be reached from the anterior side, vitreous hemorrhages, and so on and so forth. So just to give a brief, initially we were using the Birmingham terminal system, which was quite useful system for classifying the ocular trauma and then prognosticating the same, and then triaging the patients to management. So this was being used for many years and had many merits, but recently we have come up with the iGate system, which has some advantages over this classification. So the basic overhaul of terminology from the beds to the iGates was done a few years back, where the globe and adnexal trauma was clubbed together, which was not included in the beds classification, and it basically added upon the beds classification and gave us a perspective into how to classify some of the injuries where the adnexal wounds are also involved, and what are the mechanisms of injuries which was not classified in the beds classification, like sharp wound injuries, blunt injuries, mixed injuries and foreign bodies, bites and stings and burns. So these were not included in the beds classification. Also severe adnexal injuries like canacular and nasolacrimal duct damage or injuries were not initially included. So what was done here was some addition to the zones of trauma which were present in the beds classification. So I'm sure we'll have the classification of ocular trauma being discussed by other speakers coming after me. So I'm just giving an overview of what we are about to hear. So the incidence of ocular trauma in India, as far as some large-scale studies are concerned, is about 1 to 5%, which is a large population when it comes to the Indian subcontinent. So although we don't give ocular trauma so much of weightage when it comes to management of eye related diseases, the ocular trauma burden in India is very significant and mostly underreported in the interiors of India. So what we need to do when we have a patient of ocular trauma is proper evaluation. The initial step is a triage, where we need to triage basically means to differentiate between any sight-threatening injuries and life-threatening injury. So any trauma is usually associated not only with isolated eye injuries, it might be associated with any other injuries to the body, and especially when it comes to the eye, it can be head injuries, face and adnexal injuries. So these are something which can be sight-threatening as well as life-threatening. So first we need to assess, and then we need to decide whether the patient first needs treatment for other injuries which are more of life-threatening kind of injuries before the eye is being touched. The second thing is any medico-legal aspect. So we need to make sure that if there is a medico-legal aspect involved, we document it, and then we need to make sure that we inform the appropriate authorities and take it forward. In ocular injuries, when there is isolated ocular injuries, we need to decide which ones are emergencies. So emergencies are basically open globe injuries, lacerations, which need immediate repair. The second ones are intraocular foreign bodies, which are considered as ocular injuries. And third one is something like an endophthalmitis, which is an infection, severe infection of the eye, which needs urgent injuries. The other injuries can be triaged to be seen by appropriate subspecialties in their routine OPDs. So metacular systemic history, informed consent, medico-legal considerations, the current systemic conditions, medications, or last oral intake, which is also very important if you want to take up the patient for a emergency surgery, tetanus vaccination, these are all things which one needs to immediately assess while you are treating ocular trauma. The circumstances of leading to the injury, the site of injury, timing of the injury, place of injury, these are all very important. If there is a possibility of an intraocular foreign body, then the composition of the intraocular foreign body is something which we need to ascertain from the patient and the attenders. Any prior ocular surgeries, any pre-injury vision which is available, which can be very useful, because sometimes the vision in a particular eye which is traumatized might be quite poor. Patients who are already blind in one eye tend to get injured in that eye very, very frequently. So that is also important. Status of the other eye, that's also something which we need to do. So ocular examination involves all these things: periorbital injury assessment, intraocular foreign body assessment, the vision, which is very important, optic nerve functions, anterior segment evaluation, intraocular pressures, and then finally the posterior segment evaluation. So once we have done with that, we have imaging techniques like ultrasound. So I will not go into the details of these. This is very important when the media is hazy. So we can detect retinal detachments, choroidal detachments, intraocular foreign bodies, posterior globe dehiscence, and dislocated lenses. So these are all things which can be assessed with an ultrasound. A computed tomography is very important when it comes to intraocular foreign bodies which are magnetic. Any fractures, adnexal fractures. X-rays were being done initially wherever CT scan is not available. They can be used, but they are more of historical value now. MRI scan is important whenever there is a non-metallic foreign body involved, but make sure that a metallic foreign body is ruled out before you go for an MRI. When it comes to posterior segment, OCT scan is again very important when it comes to diagnosing Berlin's edema, a macular hole, pre-retinal or submacular hemorrhage, retinal detachments, the posterior pole, and so on. UBM can be used for dislocated lens or any trauma around the ciliary body or iris tissue, iris root. So this is something which is useful for looking into that area. Electrophysiological tests can be used for assessing the optic nerve function, because if there is no PLI, especially in a child, you need to do a VEP. ERG tests for intraocular long-standing foreign bodies. So these are something which can be done. So apart from all this, you need to have a good history illustration, thorough examination, painless and ophthalmic examination, use of imaging technologies, and all this can lead to management of the trauma in the long term well. So I'll skip through the details of these management protocols. I will go directly to the concluding statement, because I think these are going to be covered by individual speakers. So what one needs to do is also do a prophylaxis. So patients, you need to counsel patients who have high myopia, one-eyed patients, patients who have collagen vascular disorders, or who are prone to professions where ocular trauma is important, to wear protective glasses, protective eyewear, and that is something which can prevent ocular trauma. So with that, I'll end my talk. Thank you very much for hearing me.
Thank you, Dr. Jaideep, for wonderful presentation and overview, which included almost every aspect of trauma, and especially posterior segment. We'll take the questions later on. May I invite Dr. Shruti Shirwadkar for her presentation?
Thank you.
Classification of ocular trauma. Dr. Shruti is Associate Professor in Lokmanya Tilak Municipal Medical College and General Hospital, Sion, Mumbai. She has keen interest in pediatric ophthalmology. She has completed her fellowships in retina and pediatric ophthalmology also. Dr. Shruti.
Thank you, ma'am. So, very good morning, everyone. I am Dr. Shruti Shirwadkar, Associate Professor at LTMG. And firstly, I would like to thank MOS and Dr. Natarajan sir and his team for giving me this opportunity to present. So, my topic would be classification of ocular trauma. Few of the things has been covered by Dr. Jaideep sir. So trauma basically can be defined by dictionary meaning as a deeply distressing or a disturbing experience. It is a serious injury or a shock to the body as far from violence or an accident. It can be defined as an event or situation that causes great distress and disruption. So though our eye has been protected from direct injury by the lids, eyelashes and the protecting margins of the orbit, nevertheless it can be injured in variety of ways by chemicals or heat, radiation or by mechanical trauma. So basically the eye injuries are serious ocular incidents that constitute around 10 to 15% of all the ophthalmic diseases, with a worldwide incidence of more than 55 million cases per year. So it is number one ocular emergency. It can lead to blindness, monocular or binocular, irrespective of the age, sex and geographical status. Males and young age group people are seen to be more affected because of this. Efficient referral is expected from the professional, and every person should know about the importance of quick response to an ocular injury. And prophylactic measures has to be taken, always better than the management. So coming to the first part, that is the etiological classification. So according to the type of injury, like it could be accidental, it could be self-inflicted. In some cases, the patient might be under some psychological condition because of which he might self-induce the injuries. It could be occupational, like in farmers, there could be injury with the vegetative matter. So then the second classification we can classify according to the nature of injury, that is a physical or chemical trauma. Again, in physical trauma, it could be a perforating injury, it could be a non-perforating injury or a blunt trauma. Chemical injury could be because of the acid, alkali or dyes. Thermal trauma could be because of the excessive heat or cold. There could be radiation trauma because of the ionizing radiations or ultraviolet rays or laser burns, or it could be miscellaneous. Based on the primary evaluation, mechanical trauma can be classified as open globe injuries, that is, it includes a full thickness defect in the eyeball, and it could be a closed globe injuries, the injuries without full thickness of the eyeball. We have already seen Buckingham's eye trauma terminology system. The Bates system, it differentiates the injuries into basically a closed globe injury and an open globe injury. So closed globe injuries where there is no perforation or the eyeball coats are intact, but there might be contusion, and the second type it can be differentiated as a lamellar laceration. Then is the open globe injury where the eyeball coat is disrupted or it is not intact. So in that you can subdivide it into rupture and laceration. Laceration is again divided into penetrating injury where there is only one entry point. It can be a perforating injury when there is one entry point and another exit point, and there could be a retained intraocular foreign body. So it defines, the Bates classification defines the rupture is a full thickness wound caused by blunt trauma, laceration is a full thickness injury caused by sharp object, penetration is caused by single laceration, and perforation by one entry and one exit. Then there is International Society for Ocular Trauma classification for open globe injuries, which consists of 4 parts, that is type of injury, the pupil, the grade of injury and the zones of injury. So types of injury are the same, like rupture, it could be a penetrating intraocular foreign body, perforating injuries or a mixed mechanism. You have to check the pupil, that is pupil positive is if there is a relative afferent pupillary defect, that is termed as positive. If there is no relative afferent pupillary defect, it is termed as negative. Grades of injury depends on the initial visual acuity. That is, if it is more than 20/40, it is grade 1. If it is more than between 20/50 to 20/100, it is termed as grade 2. Between 1900 to 5/12, 200, it is grade 3. Grade 4 is 4/200 to PLPR, that is grade 4, and no PL is grade 5. Zones of injury. For open globe injury, it includes, if it is only involving the cornea and the limbus, it is termed in zone 1. If it exceeds beyond this zone 1 to the 5 mm of the sclera, that is zone 2, and if it goes beyond 5 mm of sclera posterior to that, it is termed under zone 3. There is another system of scoring, that is ocular trauma score. Basically, we give raw points for that. So it takes into consideration the initial visual acuity. So suppose the initial visual acuity is no PL, then we give the score of 60. If it is PLPR or hand movements, then it is 70. If it is between 1/200 to 19/200, it is 80. Beyond that, it is given the score of 90 to 100. So the first initial visual acuity is taken into consideration, and in that you have to subtract the score according to the injury which has happened. So like if there is a relative afferent pupillary defect, you can subtract -20. If there is a rupture of the globe, then -12. If it is associated with retinal detachment, -11. Lens damage, then -5, and so on. There was original OTS was also there, but which did not include the zones of location of the injury, and it did not include the lens damage and vitreous hemorrhage. Then there is this another classification, which is a general classification of all the ocular trauma, which takes into consideration all the points like local, whether it is associated with other systemic involvement or environmental. So again in local, it includes non-mechanical or mechanical, which we have already seen, and so it may be associated with other systemic conditions, with maybe with head injury or with face injuries, or multiple injuries may include fractures of the bones or polytrauma. It could be environmental like congenital, industrial, recreational, or road traffic accidents, or criminal. So this is a general classification. This is again a zonal classification of the injuries. So we have seen in open globe injury, the first zone includes only the cornea and the limbus. From limbus to 5 mm is zone 2. Zone 3 it can be again further divided into 3A and 3B. So in that 5 to 8 mm posterior to the limbus is zone 3A. Zone 3B is more than 8 mm posterior to the limbus. In closed globe injury, the zone 1 includes external injuries like injury to the conjunctiva, cornea, and sclera. Zone 2 includes injury to the internal anterior segments like lens, zonules, and pars plicata, but not beyond that. Zone 3 includes posterior segment trauma, posterior to the posterior capsule of the lens, and the pars plana. This we have already seen in other, because there is a lot of overlapping on all these classifications. So in closed globe injury classification, we can include a type of injuries, then the grading according to the visual acuity, then there is whether there is pupil involvement or not, that is RAPD is there or not, and then the zones. So coming to the individual entity, leads again can be involved with partial thickness or full thickness tear. Their orbital fractures has to be again classified as a blowout fracture or a pure fracture, or according to the anatomy, whether it is involving roof or floor or middle wall or the lateral wall. Then conjunctiva can be, you can evaluate with whether there is a conjunctival foreign body or a tear. Cornea, whether a full thickness tear or a partial thickness tear. Hyphema can be again graded into grade 5s, that is microhyphema is grade 0, grade 1 is less than 1/3 of the anterior chamber. Grade 2 is 1/3 to 1/2 of the anterior chamber is filled with blood, then it is termed as grade 2. Grade 3 is more than half. Grade 4 is total anterior chamber is filled with the blood. And 8-ball hyphema, that is when the anterior chamber is filled with dark brown blood, that is 8-ball hyphema. Sclera, again scleral injuries can be divided into full thickness and partial thickness. Then iris and the lens injuries can be divided into depending on the location or the mode of injury, that is whether there is a sphincter tear or iridodialysis, iris foreign bodies, traumatic cataract is there or not, with or without anterior lens capsular breach. There is a chemical injuries classification, that is open hall classification, which depends on the corneal involvement. That if there is epithelial damage and no limbal ischemia, then it is grade 1. When there is corneal haze but iris details are seen, then it is grade 2. Grade 3 is when total epithelial loss with haze that obscures the iris details, and it is the limbal ischemia involving 1/3 to half of the limba. Then grade 4 is with poor prognosis with corneal opacity with iris and pupil obscurations. So basically, I will not go into detail, but these are the anterior segment complications of the blunt trauma. Then there are 7 rings of blunt trauma to the eye, which includes the part which are circumferential anterior to the equator, which includes the iris, peripheral iris, anterior ciliary body, then posterior ciliary body, the trabecular meshwork, lens zonules, and the retina. There is classification which includes the intraocular foreign body. It could be toxic, inert, or a metallic, non-metallic foreign bodies. We can classify according to the location of the intraocular foreign bodies. The primary evaluation, the assessment is very important, not only of the globe but overall systemically, because there could be certain conditions which are harmful or deteriorating for life. Threatening conditions could be there, and urgent referral to the multidisciplinary system or a special this thing is very important. Then a proper documentation with or without photographs, if possible, should be done. We should always do other investigations whenever possible, like X-ray, orbit, or CT scan, MRI. MRI should not be done in metallic foreign bodies. General principles of repair: clean the wound, then the injection TT should be given. If not given, immunize properly before. Careful handling of the tissues and the anatomy should be done. The closure should be done in the layers, and anesthesia should be given properly under local or general as possible. So my take home message would be a proper evaluation and management is important, and we need to classify the diseases, because then we can give a prognostic factor, or we can give a prognosis to the patient, and for us also to how to manage the patients. Thank you very much for listening to me.
Thank you, Dr. Shruti, for giving us detailed classification. And this is a beginning point from where we can go ahead and go into management. So now I invite Professor Dr. Chaya Shinde for giving her talk. She is professor and head of department at Lokmanya Tilak Medical College, Sion Hospital, and has been teacher for many postgraduate students for more than last 20 years, and would like her to share her experience. She is going to be speaking about corneal lacerations and share her insights into the management of the same. Thank you, ma'am.
Thank you for the kind words, Dr. Jaideep. So corneal laceration is very important because cornea is the most important part of the eye, which will allow the light to go inside the eye. Etiology: any trauma can cause corneal laceration or rupture of the previous ocular surgery wound, which can be cataract surgery, keratoplasty, or trabeculectomy. It can be caused due to industrial accidents like projectile metallic or non-metallic foreign bodies, glass fragments, nails, or sharp instruments. Road traffic accidents, which are very common, these patients come to our hospital, as our hospital is the first hospital on the highway. Home accidents can cause corneal lacerations, and children can get injured due to sharp toys. Assault due to knives can cause corneal lacerations. This is a patient who had an injury with a wire. In history, we have to ask important points like diminished vision, redness, pain, and watering. Patient will present to you with diminished vision or pain. It will be severe pain, and they will come to you very soon. Within 4 to 6 hours, they will reach the hospital. Foreign body entering at high speed, whether it was metal on metal hammering, so there will be foreign body may be there, or intraocular foreign body may be there. And history of past ocular surgery is important, as there may be rupture of the previous wounds. When you examine these patients, we have to examine very gently without causing any pressure on the eye. Otherwise, the intraocular contents may extrude out. And detailed examination can be deferred to do on the OT table only. Intraocular pressure is reduced in these patients. Diagnosis is very challenging, particularly in cases of severe patient discomfort or with an unstable or obtunded patient, drowsy patient. Sometimes they might have taken alcohol and the examination is very difficult. Thorough initial examination should be tried though, in which you have to look for visual acuity, pupillary examination, and slit lamp evaluation is a must. Fellow eye should also be examined carefully to rule out bilateral injury. In road traffic accidents, these are common. Investigation CT scan to rule out intraocular foreign bodies, assessment of the globe shape, and potential locations of the globe injury. Where are the locations? Orbital fracture has to be ruled out, and measurement of IOP is deferred when a full thickness globe injury is present or suspected. A negative Seidels test is helpful in assessing for a full thickness corneal laceration. We have to look for the carefully at the wound to find out the extent, site, whether it is perpendicular or shelled areas of laceration are present. Anterior segment OCT, when available, should be utilized to assess the depth of the lacerations and monitoring healing over the time. Management should be prompt. Thorough wound evaluation should be done, and wound closure should be planned as soon as possible to reduce the risk of endophthalmitis, avoid tissue necrosis, and decrease patient discomfort. Deep lacerations, even if not full thickness, can cause significant astigmatism if left untreated. Repair of lacerations should generally be performed within 24 hours of the initial trauma. So patient, immediately when you see the patient, you have to tell that not to eat anything. You may need to give sedation to the patient. Protective heart shield should be given to prevent the further injury, and broad spectrum antibiotics to be started by topical route where indicated, intravitreal injections on the table, systemic antibiotics to be started, and depending on the extent and nature of the injury, you can decide on the antibiotic. Antiemetic and analgesic medications to give to reduce further pressure on the globe. What are the principles of surgical management? General anesthesia maximizes the patient comfort and minimizes potential tissue extrusion through the wound, which can occur with retrobulbar or peribulbar blocks. So you have to keep anesthetist available. Intravenous mannitol 20% 1 gram per kg IV to reduce the tissue extrusion through an open wound. Wound is thoroughly evaluated and necrotic tissues are excised. Anterior chamber should be reformed with and maintained with air, saline or cohesive viscoelastic. A well-pressurized anterior chamber can minimize creeping of the intraocular tissue in the wound space prior to or during the closure. 10-0 nylon suture should be used on a fine spatula surgical needle, which should be 3/8 circle. Depth usually not full thickness, 80 to 90% depth to avoid creating a conduit for intraocular microbial infection. Suture depth less than 80% can cause the wound to gape posteriorly. Suture passage should be symmetric on each side of the wound, and when a suture is passed through the cornea, the needle must enter perpendicular to the corneal surface and should be passed in a single throw to avoid multiple entries. In this diagram, equal bite should be, it shows that equal bite should be taken on both the sides. If it is, the depth is 100%, then the infection will enter inside. If it is less than 80%, then posteriorly gape will be there. And in this diagram, it is shown that unequal bites are there. So the apposition is not good. This is again malapposition, and even this diagram is showing malapposition. See, the unequal bites are there. A needle with a small radius of curvature resulting in shorter and deeper passes can be used centrally and may reduce astigmatism and minimize visually significant scarring. A needle with a larger radius of curvature that results in longer, more shallow passes can be used peripherally to flatten the corneal periphery and subsequently steepen the central cornea. When possible, avoid sutures entering the pupil area in order to minimize vision-threatening scarring in the central area. All suture knots should be trimmed short and superficially buried in the stroma away from pupil to maintain the structural integrity, while also allowing for easy removal if necessary. Exposed corneal knots cause significant patient discomfort and require coverage with a bandage contact lens. The goal of any laceration repair, regardless of depth or shape, is to create a watertight wound closure. Minimal scarring and reconstruction of the native corneal contour should be attempted. Management depends on extent and depth of the laceration. If it is a partial thickness laceration, soft bandage contact lens with or without tissue adhesive can also help you. Topical antibiotics should be given in all the cases, and deeper lacerations require suture repair. If it is a large shelled partial thickness wound, suture closure is needed for realignment. This is a partial thickness laceration. Suture should be tightened enough to avoid a leaky wound. Astigmatism resulting from over-tightening can be relaxed with suture removal in postoperative period. Close examination of the wound integrity with fluorescein can be performed to ensure an adequate watertight seal prior to completion of the case. Full thickness lacerations less than 2 mm without tissue incarceration with well-opposed wound edges, pressure patch and bandage contact lens may be sufficient. You have to give aqueous suppressants and tissue adhesives such as cyanoacrylate or fibrin glue. This is a tear showing iris prolapse. Definitive suture closure option should be always considered. Full thickness injuries carry a higher risk of endophthalmitis and require prophylactic IV antibiotics. Cefotaxime 1 gram IV BD or less than 12 years of age patient 50 to 200 milligram per kg per day in divided doses. Gentamicin 3 to 5 milligrams per kg per day and metronidazole 35 to 50 milligram per kg per day. In severe cases or contaminated cases or when the patient presents later than 6 hours, vancomycin 1 gram every 12 hours or ceftazidime 1 gram IV every 8 hours should be considered. This is a full thickness laceration more than 2 millimeter which will require sutures. In linear laceration, sutures should start at the midpoint of the laceration and in the resulting half should be bisected. When there are shaved and perpendicular portion should be closed first. When there is linear oblique laceration, suture is passed in equal lengths from the posterior aspect of the wound to avoid wound override. This may create irregular anterior appearance. However, the posterior aspect should be closed properly. In stellate lacerations, it is most challenging to repair. The linear portions can be closed separately, which allows the apex to self-heal. Horizontal matrix suture can be placed at the apex or pulse string suture should be utilized. This is showing the stellate laceration and the linear wound should be closed. When there is a corneoscleral lacerations, initial 8 or 9-0 nylon should be placed at the limbus to properly restore the alignment of the cornea and sclera, followed by the corneal suturing, followed by the scleral portion should be done. When there is tissue loss, donor cornea or sclera can be used to fill the defect. Amniotic membrane is a good healing material which will help us, and in severe cases with large wounds, penetrating keratoplasty may be required. This is a big wound is there, cornea and sclera is involved, so still it was possible to suture it without any graft. Post-operative care, topical antibiotics, steroids and strong cycloplegia, strict protective precautions, and timing of suture removal is based on patient age, size of the defect and amount of induced refractive change. It may be required to do in steps. Rigid gas permeable lenses, hybrid contact lenses or scleral lenses are non-invasive options to increase the patient vision and comfort. We have to look for complications like endophthalmitis. It can be 0.9% to 12%, infectious keratitis, retained intraocular foreign bodies, loose or broken sutures, infections, patient in discomfort and induced astigmatism. Permanent vision loss for corneal scarring and sympathetic ophthalmia which may occur even years later, 30 years later also it can occur. So these are some cases which we had and which we could manage them successfully. This was a patient with a glass injury with uveal tissue prolapse. Thank you.
Thank you so much, ma'am, for giving us a very comprehensive and detailed overview about corneal lacerations and its management. The next speaker is Dr. Nishikant Burse, sir. He's not available. So I invite Dr. Sneha Makhija to give her talk. Dr. Sneha is a cornea and anterior segment specialist with a fellowship in ocular surface from Shankar Netralaya. And she's currently working as a consultant at Kenya Eye Hospital with special interest in ocular surface diseases and healthcare technology and healthcare administration. I invite her to give her talk on chemical injuries and its management.
At the outset, I'd like to thank Natarajan sir for this opportunity. Hello and good morning everyone. Chemical injuries comes under BET's classification as a separate entity. It's quite extensive, so I'll try to take you as quickly through it as possible in the time that I have. Quickly diving into the alkali and acid injuries, very commonly seen alkalis are ammonium hydroxide, sodium hydroxide, potassium hydroxide, magnesium hydroxide and calcium hydroxide. So all the hydroxides, these are more severe in nature and more common in nature also. Coming to acid injuries, sulfuric acid, commonly seen in battery acid, sulfurous acid, hydrofluoric acid, acetic acid, hydrochloric acid and chromic acid are commonly seen in household products. Coming to the pathogenesis of the chemical injuries, alkali versus acid. Alkali causes saponification of cell membrane fatty acids by the hydroxyl ion, which further causes stromal collagen degradation, secretion of proteolytic enzymes. This is rapid and deep penetration of the chemical, and so it's a more severe injury and causes injury to deeper tissues also. Coming to acid injuries, the hydrogen ion damages the surface. Anion will cause protein denaturation, precipitation and coagulation of the protein. So the barrier is formed and further penetration is prevented. The severity of the injury will depend on several factors like the concentration and pH of solution, extent of ocular surface exposure, the duration, the energy level of the chemical reaction that is produced, and specific conditions under which the injury occurs also. So what happens after a chemical injury? There is necrosis of corneal and conjunctival epithelium, also disruption and occlusion of limbal vasculature. So both of these together will cause loss of limbal stem cells. Conjunctivalization eventually and vascularization of the cornea takes place. There's a persistent epithelial defect and sterile ulceration is seen, and eventually we see an opaque vascular cornea. The symptoms commonly that the patient will present with the classical history of an exposure to a chemical, along with pain, redness, watering, with or without diminution of vision and inability to tolerate natural light. The clinical course is divided into 4 stages. Immediate phase is day 0, acute phase, early repair phase, and late repair phase. Coming to the immediate phase, it's as soon as the chemical touches the surface. The prognosis, like I said, depends on the total area of the epithelial defect, extent of limbal ischemia, evidence of increase in intraocular pressure, and loss of lens clarity. Acute phase is the initial 7 days of the injury. Re-establishing the superficial protective layer of the corneal epithelium is of utmost importance in this phase. Significant inflammatory mechanisms begin to evolve on the ocular surface and inside the eye, and there's a bimodal rise in IOP seen during this phase. The early reparative phase is between the 8th and 20th day. Transition period of ocular, this is a transition period of ocular healing because there's a start of chronic inflammation. Corneal ulceration tends to occur at this stage, and that's attributed to the action of enzymes which are released like collagenase and metalloproteinase. Late reparative phase is after 3 weeks. Completion of healing with good visual prognosis in grade 1 and 2 is seen, and complications are expected in grade 3 and 4. The potential sequelae that we see eventually in the lids, there's entropion, ectropion, lag ophthalmos, posterior displacement, trichiasis, ocular structure, there is dry eye, loss of goblet cells, the entire conjunctiva cornea is affected. So there is ulceration, there can be a melt, opacity, scarring, neovascularization of the cornea. The surface, like I said, dryness, inflammation, limbal stem cell deficiency is commonly seen, and symblepharon. Intraocular pressure could rise, giving a resultant secondary glaucoma. Intraocular structures can also be affected. There can be iris ischemia, fixed dilated pupil, ciliary body shutdown, cataract, or even retinal detachment, and eventually phthisis. So these are some of the pictures that we see in the sequelae of chemical injuries. You can see a persistent epithelial defect, severe dry eye, phthisis eventually. Coming to the management. So the initial evaluation or the first aid that we see when there's an acute corneal injury, you first take the history. You check the gross visual acuity. Even before taking the visual acuity, it's very important to go ahead and do a copious irrigation of the surface. An eyelid speculum or even a Morgan's lens can be used. You double invert the eyelid and also clean everything in the upper tarsal conjunctiva. A universal pH indicator can be used to note the end point of the irrigation, or it's best to at least do 500 ml of irrigation. If there's a contact lens in the eye, try to remove it. So the agents used for irrigation are ringalactin, balanced salt solution, normal saline even, but most commonly used irrigation solution at the site of injury is tap water. This is a Morgan lens instruction chart. This is how the lens is inserted. All of this can only be done in a hospital setting. It cannot be done at the site of injury, obviously. So taking the history and examination is very important. Important to understand the mechanism, the chemical that caused the injury, the duration of exposure, whether a irrigating wash was given locally or not, and whether any eye protection was used when the injury occurred. You examine the entire eye thoroughly and you grade the injury based on, there are several classification systems. So this is the Roper Hall classification which prognosticates the injury. It's based on the epithelial loss and the limbal ischemia. There are 4 stages in the Roper Hall classification. Dua's classification went ahead and also introduced clock hours of limbal involvement, conjunctival involvement also. There's an EPICS classification by the SN group in Chennai. Dr. Geeta Iyer and Dr. Bhaskar Srinivasan have come up with it. So EPICS also takes into consideration not just the epithelial defect and the limbal ischemia, but also the intraocular pressure, gradings of the various ischemia seen, and the exposure that was seen by the chemical injury, that insult. All of this under Roper Hall comes in grade 6. But based on EPICS, you can differentiate it into various classification systems. As you can see, all the involvement here is in a varying scale. But all of this comes into grade 6 in Roper Hall. Coming to the acute phase management, the goals are to re-establish and maintain intact and healthy corneal epithelium as soon as possible, balance between collagen synthesis and collagenolisis, and minimizing the adverse sequelae. So antibiotics are given to prevent any superadded infections, cycloplegics for pain relief, anti-glaucoma medications in case there's an acute IOP rise or long-term IOP rise. Steroid is a double-edged sword when it comes to chemical injuries, but it's very important to give it in the first 2 weeks from the time of injury. It causes inflammatory cell suppression, and collagenase inhibition is what we want, but it suppresses keratocyte migration and collagen suppression. So as I said, it's a double-edged sword. You have to give it in the first 14 days at least, and then if there is corneal ulceration, you can switch to something called 1% medroxyprogesterone. After 14 days, if you feel like there's a ulcer still in the eye, you can switch to this. Also, preservative-free lubricants, copious 1-hourly lubricants, and autologous serum is also given. The goal again is to re-epithelize the surface. Ascorbates and citrate are several other management strategies, and tetracyclines. Some other options that we also have for epithelial regeneration are anti-VEGFs given topically, and bandage contact lens can be given along with cyanoacrylate glue if there is any thinning in the particular area. This is just a flow chart that I've come up with. Acute ocular chemical injury, you immediately irrigate and assess, you prognosticate the injury, give topical corticosteroids, promote re-epithelization, whether that's lubricants or any other modality that you use, prevention of infection, prevention of stromal breakdown. Coming to early surgical options, debriding the necrotic tissue is very important to allow re-epithelization. Prevent symlephron formation by, you can use a symlephron ring also if you're suspecting a symlephron. A tenonplasty in the early stages always helps. If there's extensive limbal ischemia, you bring in the tenons, vascularized tenons tissue to the limbus so that there's enough vascularization there. I'll just quickly go through it. Intermediately, you can also do amniotic membrane transplant. There is something called Prochera, in which there's a ring and in the center there's an amniotic membrane. It's like a contact lens you can just directly place in the eye in the OPD. Comet is cultivated oral mucosal epithelial cell transplantation and tissue adhesives like cyanoacrylate along with BCL. In the long run, conjunctival transplantation, limbal stem cell transplantation, these are all for limbal stem cell deficiency. In limbal stem cell transplantation, you can do CLAO, CLET, living related CLAL or KLAL. So cultivated limbal epithelial transplantation is where you harvest the limbal stem cells, you cultivate it in a lab and then transplant it into the diseased cornea. Simple limbal epithelial transplantation, which is, I'll just quickly take 2 extra minutes. Corneal transplantation in severe thinning, large desmatoceles is important. You can also put in limbal stem cells at that time, DALC, to save the desmats. In the end stage, keratoprosthesis, if both eyes are involved, or if there are multiple failed grafts, keratoprosthesis is a good option, whether it's Boston or modified MOKP. Evisceration or enucleation, if there's nothing left and there's a painful blind eye, you might have to go ahead and do that. Glaucoma surgery is also required if there is any raise in intraocular pressures. This is the management of the chronic phase. Most of the things were taken from Krashma. Thank you.
Thank you, Dr. Sneha, for nice presentation. Thanks for giving us an overview of chemical injuries. So right now I'll like to call upon Dr. Salma Sabani. She's done fellowship in comprehensive ophthalmology and pediatric ophthalmology from SNC Chitrakoot. She's currently practicing as an assistant professor at TNMC Nair Medical College.
A very good morning to one and all present here. At the outset, I would like to thank sir for the opportunity given. So I'll be speaking on pediatric ocular trauma. So why is it important to know about pediatric ocular trauma? Ocular trauma is an important cause of ocular morbidity and monocular blindness in children. Eye trauma constitutes 7% of all bodily injuries and 15% of all eye diseases. Objects causing injury in children are fingernails of the parents, sharp objects, toys, tree branches, pencils, or stones. Coming to the classification, it can be either an open globe injury, a closed globe injury, adnexal injury, or a chemical injury. So it is important for us to know why is pediatric trauma different from that in adults. Many a times, we may not be able to get a proper history. It's often difficult to determine how the trauma occurred. We may need to rely on observation. Child may not be aware of the reduction in the visual acuity. Examination is difficult in these patients, and often they may require examination under anesthesia. Diagnostic delay increases the risk of endophthalmitis in these patients. So it's important to ask for a thorough history, object of injury, whether it was sharp or blunt, where did the trauma occur, the time of injury, and also medico-legal issues. At the initial presentation, we should make an attempt to look for an age-appropriate visual acuity, check for the presence of RAPD, intraocular pressure, extraocular movements, and orbital fracture. A thorough slit lamp examination should be done to look for an anterior segment. Serious tests should be done when required. We should look for the presence of foreign body. A dilated posterior segment examination should be done. EUA should be done wherever required. So what is the role of imaging in these patients? USG and imaging should be deferred in cases of open globe injury. CT scan should be done to rule out any intraocular foreign body or orbital fracture. MRI should be done only after ruling out metallic foreign body, especially in cases of low-density foreign bodies like wooden or vegetable matter. Management, keep the child nil by mouth, especially in cases of open globe injury. Start appropriate systemic antibiotics, analgesics as and when required. Tetanus vaccination as per age. Counseling plays a very important role. Guarded visual prognosis consent should be taken. The parent or the guardian should be explained that the child might need more than one surgeries and the need of multiple repeated anesthesia. Amblyopia management plays a very important role in treating these patients. So similar to the ocular trauma score in adults, we have the pediatric ocular trauma score in children because it is difficult to test the visual acuity and the afferent pupil defect in children. So this score predicts the visual acuity based on various preoperative known risk factors. Higher points means better prognosis. So I'll be discussing a few cases from our OPD. So we had this 9-year-old girl who presented with a history of trauma with glass in the left eye 1 day back. She presented with a best corrected visual acuity of 6.6 in both eyes. On examination, we noted that there was a lower lid full thickness tear medial to the canaliculus. So we planned a lower lid left eye canalicular repair with a minimonoca stent with lid suturing. These are the pre and the post-op pictures of the same patient. Another case, there was a 6-year-old boy who presented to our OPD with history of pen to the left eye 1 day back. On examination, there was a sclerocorneal tear with the iris prolapse and hyphema which was present. BCVA was counting fingers 1 meters. So in these cases, it is very important to do a thorough peritomy to look for the posterior extent of the wound and also to look for any associated foreign body which is present in the wound. So we did a sclerocorneal tear repair with an anterior chamber wash for this patient, and these are the pre and the post-op pictures of the same. One more case, we had this 6-year-old male who presented with a history of blunt trauma in the left eye with wood 2 days back. Intraocular pressure was normal. cornea was clear. On examination, we could see this anterior lens capsule which had ruptured, and there was a traumatic cataract which was present. B scan done for this patient was normal. We planned a lens matter aspiration for this patient with implantation of intraocular lens. So this is the intraop picture. After aspirating the lens matter, we could see this fibrosed anterior lens capsule and a PC plaque which was present. Intraocular lens was placed in the bag. As this fibrosed anterior lens capsule was in the visual axis, that was trimmed. Posterior curvilinear capsular excess was done. And this is the post-op picture of the same. Another case, we had this 2-year-old girl who presented to our OPD with history of injury to the right eye with incense stick 4 hours back. On examination, we could see this epithelial defect which was present in the right eye, which was then treated with topical antibiotics, lubricants, cycloplegics, and oral analgesics. One more case, an 18-year-old male, he presented to our OPD with history of gradual diminution of vision in the right eye since few months. He said there was no history of trauma though, but on examination, we could see this corneal scar and a corresponding iris defect which was present. So in these cases, wherever there is an iris defect corresponding to corneal scar, this should raise a suspicion of an intraocular foreign body. The patient was dilated and there was this intralenticular foreign body which was seen. B scan was done to confirm the same. The posterior segment looked normal, retina was on. There was this intralenticular foreign body which was present. There was no PC defect which was present. So cataract extraction with IOL implantation was planned, and this was the 1 by 0.2 mm metallic foreign body which was removed, intralenticular, and this is the post-op picture of the same patient. So as a pediatric ophthalmologist, it is very important to educate the parents, to tell them that everything their child plays is not a toy, to be aware of the dangerous article. Protective glasses plays a very important role, especially in one-eyed kids. Taking such simple steps can make a huge difference. Thank you.
Thank you, Dr. Salma, for giving us an excellent talk on pediatric ocular trauma. Now I invite Dr. Uday for giving his talk on traumatic endophthalmitis. Dr. Uday is a consultant at Aditya Jyot Eye Hospital. He is a vitreoretina and uvea specialist. He has done his post-graduation from PGI Chandigarh as well as his MCH in vitreoretinal surgery from PGI Chandigarh, and after that he's been there for a year, following which he's come and joined Aditya Jyot Eye Hospital. So I would like him to give his talk on traumatic endophthalmitis.
So good morning everyone. At the outset I'd like to thank Natarajan sir as well as MOS for giving me this opportunity. So I'll be slightly different from the other speakers. I'll just give a brief introduction about traumatic endophthalmitis and discuss 3 surgical videos of different case scenarios and how it has to be tackled on a very case-to-case basis, because the general dictum is trauma is traumatic for the patient, for the surgeon, for the family members, everyone. So infective endophthalmitis post-trauma corresponds to about 30% of all endophthalmitis cases, and the incidence is up to 17% post a penetrating injury. There are many risk factors, including the extremes of age. They're more common in the pediatric age group and in age group above the age of 50. The presence of an intraocular foreign body makes the risk of endophthalmitis twice as much as without a foreign body, and more so if the foreign body is organic in nature, like a wooden injury. Presence of an infected wound like a wound abscess is again at a higher risk of endophthalmitis. A lens capsular rupture and a delayed repair of more than 24 hours after the injury puts a higher risk of endophthalmitis. The most common, as in case of any endophthalmitis, is actually gram-positive, including gram-positive cocci. But there's a much higher incidence of gram-negative, fungal, as well as polymicrobial as compared to post-operative endophthalmitis. After gram-positive cocci, the second most common is actually gram-positive bacilli, which are bacillus species, which are usually associated with organic foreign bodies and have a very poor prognosis. So management of post-traumatic endophthalmitis is very different from post-cataract surgery or post-procedural endophthalmitis, because there are no guidelines. The endophthalmitis vitrectomy study, which gave us guidelines for management of endophthalmitis, did not include post-traumatic ENDOF. They included only bacterial ENDOF. So they gave typical guidelines of giving initially intravitreal antibiotics followed by vitrectomy, but those don't stand true for post-traumatic endophthalmitis. The diagnosis usually clinical. You have to do a USG B scan as well to rule out a foreign body, to rule out retinal detachment, to rule out choroidals, both serious and hemorrhagic, which can occur because of the trauma. You have to suspect foreign bodies, especially organic. Organic foreign bodies are not usually picked up on your usual imaging like an X-ray or a CT scan. So a good B scan, or if you've ruled out a metallic foreign body, you might also want to go in for an MRI for the same. The prognosis is usually poor because the entire intraocular tissue is necrotic. So counseling these patients is extremely important, and like I said, there are no clear-cut guidelines of the management. Regarding prophylaxis, as ma'am mentioned, yes, giving IV antibiotics is very important. Back in PGI, when we would manage open lobe injuries, our dictum was in every case of trauma where we are suspecting endophthalmitis, take a vitreous biopsy either with a cutter or with a 26 gauge needle and give intravitreal vancomycin and ceftazidime. If it's a child, always suspect wooden injury, presume it could be bacillus and anaerobes as well, so also give intravitreal clindamycin. So I'll be coming to a few surgical cases with which we managed. So can the video be open, please? So I'll be going through 3 cases. So this was the first case, which was actually one of the first cases I operated during my training. And this was an 8-year-old child who came during COVID time, during the entire pandemic where everybody was restarting playing with bows and arrows after Ramayan came back on TV. So there was this central corneal laceration, which also had a wound infiltrate. The lens was cataractus. You can see the hypopyon, and there was endophthalmitis frank. The same day, we took up the patient for a single sitting open lobe injury repair and a vitrectomy. We did a single suture was enough to take care of it. Very important that the suture does not pass through the infiltrate. It has to go from clear cornea to clear cornea. After doing a single suture repair, an anterior chamber maintainer was inserted and a lensectomy was done. In these cases, when you're planning a lensectomy, you can easily put your trocar cannula intralenticular, so it makes your lensectomy much easier. Don't worry about leaving the patient aphakic. You can always go back later and do a secondary IOL. So after doing a thorough lensectomy, removing all the cortical matter, once we could visualize the vitreous cavity clearly, we went in with the 3-port plasma vitrectomy. In these cases, it's usually recommended not to leave an anterior capsular rim intact because that can contract and cause retinal detachment later on. So once the lensectomy was done, you go ahead with a vitrectomy. The infective exudates in the core vitreous were removed. As you can see, there's a lot of traction because the vacuum is being controlled by the assistant. In endophthalmitis, always remember less is more. You don't need to be very aggressive. You don't need to always detach the hyaloid. You don't need to do a complete base dissection. The idea of doing a vitrectomy in these cases is very clear. It's to debulk the vitreous, to get a sample for appropriate microbiological evaluation, and to create space for your intravitreal antibiotics to work. So the idea of doing a vitrectomy is just to do a core. You can see a small semblance of the disc and the posterior pole. So I decided to do a little more vitrectomy so I could see the retinal vessels much more. And after that, the ports were sutured. The anterior chamber wound was hydrated. And we also gave intrastromal Vigamox for this patient. And she did very well. She was 6'6" at the end of 1 year with a secondary IOL. So the second case is actually a more interesting case. This patient actually came with a history of just white reflex since a month. There was no history of trauma, but when we took this patient up under GA, you can see this small self-sealed corneal laceration. As you look at this lens is actually more yellow than white. So this tells you that this is not just endophthalmitis, this is also a lens abscess. So this patient was actually quite lucky because the majority of the inflammation was in the lens, so that caused a lot of NVI. We had to put anterior chamber iris hooks. There was a lot of bleeding. After clearing the bleeding, we managed to do a lensectomy. Again, the same mechanism. You go in, you make the trocar intralenticular, do a lensectomy, clear as much of the lens of the abscess as you can. In these cases, once you know that it is a lens abscess, it might also be good to take a sample from the lens as well, because taking an adequate and an appropriate microbiological sample is extremely important to have a high microbiological yield. Once the central lens was cleared, so I could visualize behind, I just wanted to be doubly sure that the retina is okay. Even though the B scan told me that the retina was attached, it's better to be safe than sorry. So went in, took a sample of the vitreous, completed my lensectomy, and ultimately just gave intravitreal antibiotics and came out. Here you can see the disc is slightly pale, but yes, the retina is well attached. This patient was about 636 at 3 months. Now the third case is actually one of the most complicated cases which you will ever have to handle with a traumatic endophthalmitis, which is endophthalmitis with a foreign body. Thankfully, this patient did not have a retinal detachment, but in all such cases, especially when you're a beginner, it's always good to place a belt buckle, because you will never be able to dissect the vitreous base completely. Even if there is no retinal detachment, there are always chances of developing a detachment later on. So having a belt buckle will always secure you in the future. Again, there is endophthalmitis in place. So you go in, do a lensectomy. Don't place an IOL in the primary sitting because these are infected eyes. Once you remove the cortical matter, you go behind. You can see the vitreous exudates. Some amount of cortical matter has dropped behind. You do the lensectomy, and based on your B scan, it's very important to localize where the foreign body is, because sometimes the eyes are full of muck, you cannot try to keep fishing inside. So once you see this foreign body which is present inferior nasally, luckily the hyaloid was attached, you can just trim the foreign body, tease it off from its skirt, and use the posterior hyaloid as a level above which the foreign body can be placed. You don't need to detach the hyaloid initially, you don't need to put PFCL initially. Use a magnet, get the foreign body into the anterior chamber, and get the foreign body out through a clear corneal wound. Once the foreign body is secured, most of your surgery is done. You can go in, very gently try to detach the hyaloid. You don't need to be too aggressive. Keeping high vacuum can cause retinal breaks and can cause more harm than good. Once this is done, you can just do a vitrectomy. As you can see, the capsule around the foreign body has been removed. There is no retinal break. So if there's no break, you don't need to do a laser. You don't need to put in a tamponade. You just do as much vitrectomy as you can safely. And here you can see the disc is visible. The media is hazy, yes, because of the loose exudates. You don't need to chase everything. Majority of your work is done once you remove the foreign body, because that is the source of the infection. Once the infection is taken care of, the eyes should do well. So after doing as much vitrectomy as I felt I could safely, just close the wounds, give intravitreal antibiotics, and come out. These eyes do extremely well, and even if they do detach later on, you can always go in later and do a secondary sitting for a retinal detachment, because by that time the inflammation is taken care of, the retina is not so necrotic. So these eyes will ultimately do much better with the secondary sitting retinal detachment surgery also, if ever it occurs. So thank you so much for your patient learning, and back to Dr. Jyoti.
Thank you, Dr. Uday, for your wonderful presentation and also showing the videos about the surgeries. May I invite Dr. Twinkle Choksi? She has completed her MD from AIMS, Delhi. She is a specialist in cornea services and she is managing the cornea patients in Nair Hospital. Dr. Twinkle, your presentation is anterior segment restoration after ocular trauma.
That's okay. At the outset, I would like to thank the MOS, Dr. Naina Poddar, HOD Ophthalmology, and Dr. Natarajan Aditya Jo, the Kamala Sundaram Foundation, for giving me the opportunity to present on corneal trauma. It's not working. So whenever we, whatever speciality we may be, but we always come across patients with corneal trauma. So it's important to know whether it's a sharp or a blunt trauma. Because the collateral damage with blunt trauma most of the times is more as compared to the sharp trauma, whether it's an inorganic or organic material. So if it's an inorganic material like glass or something, then the chances of infection are less, vis-a-vis when it's a fungal or a tree bark or something like that, then there is a chance of infection. And we should always start the patient with prophylactic antibiotics by rule. Whenever we get some kind of a foreign body or a debris or eyelash or something, it's important to take it out from the wound and send it for a culture, because in case if we encounter endophthalmitis later, then that would always help us. So tetanus immunization is must. In case the patient is not, then we can give a booster. Whenever required, we must generally use a topical anesthetic to see how much is the extent of corneal laceration, involvement of sclera, lens, iris, etc. And gentle B scan can be done only if we are suspecting endophthalmitis in the first place, so that whether to give intravitreal antibiotics or not while doing a corneal laceration repair is that is clear. So, so this was a patient who presented to us 3 days after an injury with bow and arrow. This was a child, and as we can see, this thing is the tear is reaching the limbus. So in such cases, it's always important to go ahead with a peritomy and look for the scleral extension and repair it whenever it is there. Sorry. So this is after the trauma. When we cleared the hyphema, we saw that there was a cataractus lens. You may or may not extract the cataractus lens in the first go, because if you plan to do that, then you may encounter vitreous and PC rupture and stuff like that. So if the AC is formed after the surgery, then it's a good idea to just leave the cataract back and then do a secondary cataract surgery with an IOL and a good visual rehabilitation. So when we are dealing with the principles of corneal suturing, it's important to first determine whether the patient requires repair or not. So you have to draw, so you have to first find out what are the ends of the tear, and then draw an imaginary line. Okay? Now this line would be an hinge. And this is the anterior point of entry of the trauma, and this is the posterior edge. So whenever this hinge is falling in between the anterior and the posterior edge of trauma, you may not repair it if the seal is negative. However, if the anterior and posterior both are outside, the hinge is outside this anterior and posterior point of entry of the trauma, then by rule you must repair it. Whenever you're not sure what is the point of exit, then you may do an anterior segment OCT to find out whether it's lamellar or full thickness, and lamellar ones can be actually spared. They generally heal very well with good post-operative vision without any astigmatism. Yeah, so this is a typical the trauma in which we see that when we draw a line which is sort of an hinge, we see that this is the anterior entry and this is the posterior, and the hinge is outside the trauma with a seal positive profusely, and then we need to suture such wounds. Now again, the second question is that whether you need to suture from periphery or center. So it's a good idea to start suturing from the periphery. It's because when we look at the center, both the edges are quite away and quite apart from each other. And even if a little bit of misalignment of half a millimeter would cause sort of fish mouthing at the ends. So it's a good idea to start suturing from the periphery and then go to the center, except if you are dealing with a tri-radiate wound. Yeah, so this slide also says the same. that start from the extremities and go towards the middle. So now this is how corneal laceration repair should not be done, in which probably the surgeon has started from the center and gone to the periphery. We look at the misalignment. At the end is that here the limbus is not aligned in both the parts. Again, though the sutures are more or less perpendicular to the wound edge, but still the bites on both the sides are not equal. It's also important that when we are burying the suture should not be burying in the suture wound. It should be buried on either side but not in the wound, because if it's in the wound and whenever you try to remove it, it will either rip open from the inside, which is the desmet, or the whole thing may just rip open while you're removing the suture. Yeah, so how far should the sutures be? So of course we all know that the sutures should be smaller in the center and they should be a little longer in the periphery. Now when they're smaller, you must also make sure that this is the length of the suture. Okay, so the length of this suture should be almost equal to the space in between two sutures. Now if the length of suture is short and the space in between two sutures is longer than that, then it's going to fish mouth and open again. So there will be wound leak and you might need to put one more suture in the middle. So it's a good idea to keep an imaginary distance in between the suture and the length of the suture and accordingly go ahead. So when we are dealing with a straight wound, it's quite obvious that we are going to be around 80 to 90% depth and equidistant sutures on both the sides. But what do we do if there is a shelving? So whenever there is a shelving, there is a possibility of the both the edges being not being aligned, or there is overlapping, or there is undermining. So always keep the distance longer at the undermining edge, shorter at the overlying edge, and go to around 80% depth. Now if you're going to 90% depth or more than that, then again there is a possibility of you get some desmet folds around the suture line. So you should avoid full thickness suturing. Yeah, so this is, excuse me for poor quality video, because this was done almost 10 years back, actually when I was working at Aditya Jyot. There is this tri-radiate laceration, and this patient presented around say 5 to 6 days after that. You look at the corneal edema at the edges and the epithelialization which is formed over this wound line. So all this debris have to be removed, cleaned properly, and the sample should not be discarded. It should be sent for culture. And then in this case, we start with suturing at the center. This is the only case like when you have something like a triradiate or a cruciate, that you start with the center for better alignment. And you take a purse string suture. So from the first, you go to the second leaf. From the second leaf, you go to the third leaf. Also, you make sure that the distance from the center to the bite should be equidistant in all the 3 leaflets. And then from the third to the first back again. And then take a 3-1-1 knot. I prefer to take 3-1-1 knot, especially in corneal tears, because it's easier for me to bury and I don't want sutures to be breaking again and again. So this is how it approximates well, and then we can go ahead with normal corneal tears, like a few sutures over here, there, and then we are done. Yeah, so it's always very important to keep the sutures on much tighter side looking at the corneal edema, because the corneal edema will decrease in the next 2 to 3 days, and then we just end up with loose sutures. So this is a video of how a typical 4th-row pupilloplasty would go. I think there is, when I was preparing for the slide, I didn't know that somebody was going to already take a lecture on 4th-row pupilloplasty. So if we are short of time, I can run through this. In this, there is a traumatic mydriasis, and patient keeps complaining of glare all the time. Though we did a cataract extraction with IOL, but still the patient was not very happy. So you go from one end and then through the proximal iris, and then take a little bite through the distal iris. If you want, you can just take help of microforceps. Grab so either you can take help of a microforceps or a 26 gauge needle. to guide in the 9-0 or 10-0 Prolene suture, whatever you're comfortable with, and take the whole thing out. First the needle and then the suture, and then you take a Sinski hook, take the here, pull the suture which is there over here before the first bite, pull it out completely, cut the needle from the suture from the distal end, give 4 throws and then pull it. So the knot will sort of slip inside the AC. Yeah, so I think I'll skip because of short of time. Somebody is going to take this. I'll just show this the last thing, how it goes into place. Yeah. And then now the suture is taken here, and then after that we're doing the pupilloplasty. So this is another patient in which we did traumatic cataract extraction with an iridodialysis repair. Now because of short of time I'm going to skip this video. And finally this is how the lens is inserted and how the eye looks like after an iridodialysis repair. So if you are doing 4-throw pupilloplasty, iridodialysis repair is very similar to that, and it would not be a problem. Yeah, this was another interesting case. It was a child who came to us with this tree bark which is lamellar, which is sort of penetrated into the cornea in a lamellar fashion, which is not so then we made another incision from here and pushed it, so the whole thing came out and then formed the AC. Okay, so sorry, I'm not very. Thank you for your patient listening. Thank you, Dr. Naina Poddar, for giving me the opportunity. Dr. Anuja for sending me patients, and helping my residents for helping me out with the editing of the video. Thank you very much.
Thank you, Dr. Twinkle, for your wonderful presentation. Dr. Nishikant is not here. Dr. Sujata, she's also not here. So, any questions from the audience? Yeah. Sir, we'd like to have your comments on the first session and your guidance.
Not at all. No, thank you. Thanks for first inviting me to be here. I'm coming here after so many years. I still remember the late night rounds we used to do in streets of Mumbai, eating Mumbai's chaat food. Dr. Natarajan promised me that, but he's instead giving me a treat on Ocular Adnexal Trauma Symposium here. No, I just wanted to compliment all the speakers over here who gave a beautiful talk. Trauma is something which usually does not even find a slot in most conferences. This is retina, glaucoma, peds, plastics, or is snuck into the program somewhere else and never gets its due attention. And the talk tomorrow, we are talking about how trauma is actually an orphan child of ophthalmology. Belongs to nobody and belongs to everybody at the same time. And when a child does not belong to anybody, it gets neglected. And I'm so happy to see all the youngsters giving wonderful talks. I particularly relish the talks by some of you who are showing case-based presentations, because I always believe there's textbook which you learn for passing examinations, and then there's real world. The real world does not read the textbooks. I always say patients never read your textbook and say, I should have a laceration this way, I should have a fracture this way, I should have a retinal detachment based on the Linkoff's rules right over here. The real world retinal detachment is completely very different. And I think whenever you discuss case-based presentations, that is very good. The third thing is, for the first time, I'm now starting to see all presentations with classifications. In the past, people were just managing diseases, and the classification again was for a theoretical purpose, but we now know the classification and scoring is for prognostic purposes. I think that's very important, because if your patient had only a 5% chance of reasonable visual recovery, is it really worth the effort, Dr. Salma? Is it 5%? Is it really worth the effort? Or 1%?
Yes.
Yes. Simple answer is yes. So,
I said I'm speaking on 30 minutes on that.
so we all think that, put that guarded prognosis. Somebody wrote a consent over there saying the consent for guarded prognosis to be taken. I think you mentioned that as well. The guarded prognosis consent is very important, but we were using that as an excuse to do a bad job for the patients. Anyway, we explained it, bad prognosis for this patient, give it to the junior most person, and sometimes junior most person is unsupervised, and then a bad outcome is acceptable. So the consent is for medical legal purposes, but these are situations where the senior most person with the maximum technology, having the junior most person coming and watching and assisting and scrubbing is probably the most important thing. So compliments and all these things. The only last comment I will probably make is, how many of you are members of the Ocular Trauma Society of India? 1, 2, 3. See, so many youngsters in the room. And what, is it what, 25 or 40% of Indian population is youngsters? 35% of population is youngsters. So you guys form a significant group. It's you guys who should be joining these societies. 65%. Yeah, so majority. So you guys are the ones actually, rather than the seniors like us, you guys should be the members of the various societies. And of course, start off with the Maharashtra Society or Mumbai Society, then next the Maharashtra Society, then the Indian Society, and we are the largest populous nations in the world, and we have the maximum competent surgeons, but we also have the maximum diseases and pathology. So the youngsters should be joining the society, initially learning from the masters, and eventually become the masters on your own. So those are the few comments I would make for the youngsters. Great presentations, join your societies, form a camaraderie. Don't think cornea is far away from the retina. I like your talk when you said cornea is the most important structure of the eye. Dr. Natarajan, would you agree with that? She said cornea is the most important structure of the eye. So that's a passion that tells you, if I'm a cornea specialist, I should give the best to the cornea. As a retina specialist, he should think he should give the best to the cornea. Dr. Chavan, who's a world-renowned expert, he's the only guy who, even after the eye is gone, can give life to the patient. So each one should be passionate about what you do, and when we all come together, we serve our patients better. Thank you.
Actually, Dr. Gulapalli Rao got the award in '88, I think, in All India in Bombay only. And that time he used to tell me, hey, you retina guys carry the visual chart in the hand. Can you see like that? And now I tell him, you are a cornea surgeon, we see through you. So anyhow, any Jaideep, any comments? And Sneha is also, I'm happy, Aditya product. She's into a lot of writing and what is that, eye handbook. Sneha, you can tell about eye handbook, no? Which has, probably Ganga has not gone through it.
So in continuation to the grading that you were, the classification that you were, there's a eye grader that we have on this eye handbook app. I work as an innovation strategist and editor with them. Eye handbook used to be AO's official app initially. So we are introducing a lot of grading systems. There's a separate eye grader on the app. Because chemical injuries was my topic, chemical injuries, there's a vast classification system, and not every system is able to cover and prognosticate, especially the severe injuries, because medicine has evolved, and because now we have treatment options and limbal stem cell related treatment options. There are many grade 6s which are not that poor prognosis anymore, even though on presentation they look really bad. In fact, 2 patients who present with 360 degrees limbal ischemia can behave differently. So there's a lot, even though it's like a topic which we've always covered, we've seen this, there's so much evolving in these topics, and a lot lies in the fact that the classification system is still evolving. So that's one point you also brought up, I think, and it really helps to have a grading system in your hand. So the app is trying to contribute to that also. It's in development right now. It should be out by next month.
Thank you, Sneha. May we have a group photo for this session? Natarajan sir and Gangadhar sir. Can we have a group photo for this session?
Yes,
Please
definitely.
join
I
us
think
for
every
group
session
photo.
we have a group photo.
Yes.
And then, is the coffee ready? Ready? Okay, coffee is ready. We'll have a group photograph and coffee.
I thank co-chairman
11.
Dr. Shruti and my moderators.
So I thank Dr.
Jaideep
Chaya
and
Shinde
Sneha.
and the team for chairing,
Thanks.
and my team also for. So all the speakers can come, all the speakers and all the moderators. All right. You are giving the certificates to them? Yeah. Madam, Chaya Madam, Gangadhar will give the certificates to the chairs and the speakers. Come, announce, no? For whom? I will give that. Gangadhar will give that. Today, we will just announce. Maybe for you I announce.
So Dr. Jaideep, please.
We request Dr. Gangadhar sir to issue the certificates. Dr. Jaideep.
Dr. Shruti Shirvalkar. Dr. Chaya Shinde, ma'am. Dr. Sneha. Dr. Salma. Dr. Twinkle, please. And I'll take the last one.
will have a short tea break for 20 minutes and then another session will start.
Joseph, can you get my laptop? I want to check my connection. Hey, Ganga, we'll check our presentation. Can somebody help in connection? Laptop for the next session. Hey, मेरे पास है समीर. समीर इधर है. समीर, डायरेक्ट कनेक्ट करेगा? डायरेक्ट कनेक्ट करेगा? नहीं, फर्स्ट टॉक. फर्स्ट वन ऋतिका दलाल करिश्मा वगैरह. सो ये ऐसे इसके ऊपर रखेगा, बंद कर सकते हैं. हाँ, करो. नहीं, ऐसे रख सकते हैं. चेक करने SNEC, I'll take you so we celebrate the 10th anniversary, 20th anniversary. Now 25th I am trying to negotiate with them. आज है email मेरे okay. One minute. And then Ganga, this is working. No, yours is working.
Right, nice to meet you. I think I met you.
No, it's working. So,
Okay. So,
anyway, first presentation is not ours.
it's just one of the videos. I just want to make sure.
Yeah,
it works.
correct.
As long as the video works, and so.
समीर समीर ये निकाल कर ना ये पहले नहीं बिकॉज फर्स्ट डाउन समझ
Good morning, everyone. It's my pleasure to introduce and invite नहीं पहला ये बोलने के लिए बोला उन्होंने कि तो फिर उसके बाद बोलती हूँ डॉक्टर नैना को हेलो
हैंड वाला दे दो.
तो ऑलरेडी वो स्टेज पे आ
चारों लोगों का वेलकम करना पड़ेगा.
ये ऑलरेडी आ गए हैं
हाँ, तो you have to welcome them. Okay, just say, it's my pleasure. Welcome back, everyone. It's my pleasure to welcome our chairman, Dr. Naina Poddar, co-chairman, Dr. Dharmesh, moderator this, and I would further give this to Dr. Naina Poddar.
आप ही बोल रहे हो मैम
नहीं 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 नहीं.
Yes, yeah. Hello. Good morning, everyone. I'll pleasure and introduce and invite. It's my pleasure to introduce and welcome Dr. Naina Poddar. This is the chairman of this session 2. Dr. Naina Poddar is a professor and HOD of Ophthalmology Department in the Nair Hospital. And she is MS, DNB, MN, AMS, and FAICO, Pediatric Ophthalmology and Strabismus. So, I'll welcome to Dr. Dharmesh Kar. This is the co-chairman of the session 2. He is MBBS DNB ophthalmologist. I'll welcome moderator Dr. Karishma Wadia. She is medical director and chief surgeon in Jehan Eye Clinic. And Dr. Yash Parmar, co-moderator, MBBS DNB FICO, FVRS, assistant professor. Yes.
Thank you, Manasvi. Let's start this session with the first speaker, Dr. Karishma Wadia, who is a MBBS DNB fellowship in cornea. Presently, she is the secretary of Bombay Ophthalmic Association and medical director and chief surgeon at the Jahan Eye Clinic, Mumbai. She has presented immensely in various platforms as well as done multiple publications, and she has also got many prizes for free papers in the cornea as well as in BOA and Karnataka Ophthalmic Society. Welcome, Dr. Karishma.
Thank you, Dr. Naina. I'd like to thank Dr. Naina and Dr. Natarajan for this opportunity. And without wasting any time, let's begin our talk. It's a panel discussion with my colleague, Dr. Ritika. I take great pride in presenting with her because we did our post-graduation together. So let's start discussing about post-operative dry eye. Now, typically when we talk about dry eye, the first thing that comes to your mind is, the patient who comes into your OPD doing kit-pit, saying that, oh, my eyes are pricking, burning, watering. But dry eye doesn't have to be restricted to that or restricted to your cataracts or LASIK. So actually, in the causes of post-operative dry eye, there could be non-ocular related dry eye. So it can be related to accidental trauma like fractures, orbital fractures, accidents where you have been operated even for the brain. So neurosurgery may have been done. The medications that may be given to these patients, it can be post-elective eye surgery like cataracts and LASIK, and it can also be related to various systemic medications given for other indications. So if you actually see, there are multiple studies. This is a study, Taiwanese-based study, which shows that the risk of dry eye in patients with orbital fracture is very significant. And it showed that the patients who had orbital roof fracture were the ones who very commonly experienced dry eye. So you don't have to think typically, cataract and LASIK. There can be dry eye associated with any other trauma as well. There are also dry eye after brain surgery issues. Why does this happen? First of all, because your autonomic nervous system gets damaged, so it leads to a decrease in tear production. Second, the brain stem itself gets damaged, so this can lead to reduced blink rate. It can affect your regulation of inflammation, because of which pro-inflammatory cytokines are released. And systemic medications given for such patients like anticholinergics, anti-epileptics, all of these cause or exacerbate dry eye. So dry eye is more than what you may see in your routine ophthalmic OPD. You have to keep it in mind even for other specialties. Now, when we focus on our ocular perioperative causes of dry eye, we can always divide them further into preoperative, intraoperative, as well as postoperative causes. But if you look at what are the iatrogenic causes of ocular dry eye, everything can cause dry eye. Any surgery you go in for, any ophthalmic surgery, whether it is cataract, LASIK, glaucoma surgery, chemical burns, lid surgery because of lid lacerations, anything is going to affect your ocular surface. And anything that affects your ocular surface is ultimately going to cause dry eye. So the most common concern in that is dry eye being your concern in post-cataract patients. And why is that? Because that's the most frequently seen thing in our OPD, cataract. So what happens exactly is that cataract induces dry eye symptoms if they are not there, and it exacerbates if they are already pre-existing symptoms. And what are the types, or rather what are the factors that cause dry eye in such patients? It could be the type of procedure based on the type of incision that you're taking, the type of ophthalmic solution that you're using, the type of medications that you're using intraoperatively, postoperatively. It can lead to epithelial toxicity if you're using something that's not very friendly with the ocular surface, coexistent systemic disorders, and so on. So what are the pathophysiological changes that actually happen in the eye? Why are we so interested in dry eye with cataract? Is first of all because there's an elevation of inflammation. Secondly, there is goblet cell loss. And thirdly, there is meibomian gland dysfunction, either which is pre-existing and gets exacerbated, or it gets triggered by your surgery itself. Does it have any impact on cataract surgical outcomes? Preoperative dry eye is the most frequently missed diagnosis before your cataract surgery. And this can literally suck away 1 liter of your blood after the surgery. So your impaired ocular surface can majorly create trouble for a couple of things which you should keep in mind. First of all, your IOL power calculation will get affected. Second of all, your toric IOL axis will change if the ocular surface is not stable. Thirdly, your keratometry and topography values will keep fluctuating, so you won't know what correct power or what correct orientation you should put your lens at. These are the kind of patients, if you have picked up preoperative dry eye, especially those that are not responding to treatment, these are the patients you don't want to put multifocal lenses. Even if you put a regular monofocal lens, there may be fallacies in IOL power calculation which can again land you in trouble. So it's very imperative to treat that dry eye before the surgery. And what about post-operative dry eye? You can have a patient who is absolutely asymptomatic, who underwent an absolutely uneventful cataract surgery, and he's very happy with his vision. Typically 2 to 3 weeks post-surgery, they are very happy because they are also on steroid drops from our end for the post-operative recovery. And the moment those steroids stop is when all their trouble starts. So the impact of post-op dry eye is usually because there is worsening of OSDI, worsening of Schirmer's and all your dry eye scores. It increases your staining of the ocular surface and decreases your mean goblet cell density. And how will you manage these patients? Typically, you would want to avoid NSAIDs. You would want to avoid any BAK-containing eye drop because of the fact that the preservative itself can induce surface toxicity. Apart from that, you have to keep these patients on long-term lubricants. So the more longer the drop is going to go, that toxicity of the preservative is going to worsen the ocular surface. And you need to make sure that these patients are regularly seen and followed up. Now, moving on to our next section, which is dry eye and its impact in refractive surgery. These patients have come in for a refractive surgery. Dr. Ritika is going to help us with this part of the discussion. Dr. Ritika, can you tell us how dry eye impacts refractive surgical outcomes?
Yeah, we welcome Dr. Ritika Dalal, who has done fellowship from Nair Netralaya in cataract surgery, cornea and refractive surgery. She also has won multiple awards and had wonderful multiple publications and presentations. Thank you. And thank you, Dr. Karishma, for enlightening us on the management of dry eye post-operatively. I realize that it is so much multifactorial, especially after trauma. Thank you.
Thank you, Doctor. Yeah, so we were talking about dry eye in surgeries, basically surgical outcomes, and one of the main surgeries that does cause dry eye is definitely refractive surgery. So if one is undergoing a LASIK surgery, when we make the flap, we know that there's a disruption of the intracorneal nerves, which reduces the corneal sensitivity and the blink rate in turn, and which decreases the tear secretion, which, as we know, results in dry eye. Even when we are putting the suction on, there is a damage to the goblet cells, which produces altered mucin, which again causes a lower tear breakup time and a type of dry eye. So the type of refractive surgery is also important because that will tell us how much dry eye is going to be there post-operatively. Because if we're going in for a LASIK, we know that the flap is there and that cuts more corneal nerves. Smile, the incision being smaller, the amount of nerves that are cut are much less. And that's why even post-operatively, the regeneration of corneal nerves is seen much faster in SMILE or a PRK as compared to LASIK, which can take up to 2 years for the total nerve regeneration. The changes in the corneal curvatures are obviously noted post-refractive surgery, which causes alteration and friction between the cornea and the lid, which again results in an unstable tear film, which results in dry eyes. So as we can see that the suction causes altered goblet cells, and even after 1 month, they do not reach its preoperative state. So post-LASIK, almost all patients, it says 95%, but you can take it from me, it's almost all patients will complain of some amount of dry eye. But thankfully, if you counsel them well before, up to 6 months, most of the patients are pretty comfortable and they don't really have too much dry eye. So a very well done refractive surgery where you're really happy with the surgery as well as the outcome will be completely ruined if you haven't counseled the patient about dry eye, because invariably that is the #1 complaint that the patient will have when they walk into your clinic. Even if your refractive surgery is perfect, the patient has 6/6 vision, they will be supremely unhappy because of dry eye. So it's important to not take it lightly and even do a preoperative evaluation of this dry eye, and if need be, first treat the dry eye before going ahead and doing a refractive surgery. So this is treated with kind of artificial tears or lubricants. And all these lubricants basically have polymers. Some of these polymers are like hyaluronic acid and HP guar. And these are important constituents available currently in our eye drops. And we should use them pretty wisely because these bind to the mucin coat of the ocular surface and it facilitates corneal healing. Now in a drop like sustained hydration, HP guar and HA kind of work together and it's present at the same time, so it forms a meshwork over the ocular surface and it attaches to the mucin layer, which then enables corneal reepithelialization much faster. So compared to any drop that only has one of them, there is twice the amount of moisture which is retained, there is twice the amount of reepithelialization and twice the amount of symptom relief. It's much faster. So now we know that we have drops available, but most of our post-operative patients, especially of refractive surgery, kind of have need these lubricant drops for a longer period of time, and they're put much more frequently. So to prevent epithelial toxicity, we should try and use lubricant drops which actually have preservation-free. So in such cases, we do have sustained hydration preservative-free drops, and when we had studied actually HP guar and HA preservative-free drops as compared to a CMC preservative-free drop, we realized that the reepithelialization and the comfort for the patient in a PRK happen much faster. So this is one of the drops that we can use, which also comes in a unique bottle, which is prevents any contamination. So it's important that we use preservative-free drops when needed, because that will help the patient recover also faster and feel much better. So HAHP-based preservative-free drops are much more helpful because they cause moisture retention and symptom relief much faster. Dry eye can have a negative impact on the surgical outcome of any ophthalmic surgery. It's important to pre-test these patients before we do the surgery and manage their expectations. And perioperative management of dry eye is just as important so as to have a happy patient post-surgery. Thank you.
Thank you, Dr. Ritika, for discussing the benefits of various artificial tears with different components. Now we call upon Dr. Dharmeshkar, who is a VR fellow and a practicing VR surgeon, having received Honor Award and Senior Honor Award from the American Society of Retina Specialists. Welcome, Dr. Dharmeshkar.
Good afternoon, ma'am. Thank you for the invitation, and I would like to thank Dr. Natarajan sir for the inviting me. IUFB is it's a very large topic and many things to cover, but we'll just cover the few points which is important for management. My financial disclosure is none. IUFB vitrectomy is always challenging, and it needs a customized approach on case-to-case basis because it's how the foreign body is located. We have to plan our surgery. Investigation and management varies from the different kind of IUFBs what we have there from the histories. Now, history is very important in all such cases because detailed history will give you a type and material of IUFB and the mechanism of injury. So the velocity, how it has happened, so that will guide us where the location of IUFB will be and to plan surgery for the IUFB removal. Now, what important for us is we just go is following till now is Birmingham eye trauma terminologist. That's a bet. It was being coined by the Ferenc Kuhn. He has done excellent work in trauma. He's from Alabama, USA. And for the eyeballs, it's sclera and cornea, closed globe, open globe. So no full thickness or a contusion and lamellar laceration for a closed globe. Or open globe, we have a rupture or a laceration. And in the laceration group, we have a penetrating, IUFB, or perforating injuries. So these pictures, this is very important for we usually, whenever we train any fellows or students, we give these pictures and we tell them to, give the terminology, take a history, make a drawing, so we know what kind of thing we are dealing with and how we will plan our surgery. Now, type of IUFB is very important for managing, so we have a metallic, non-metallic, then magnetic and non-magnetic. In metallic, we have iron foreign bodies, or non-metallic, which is inert, or like silver, gold, or irritative like copper and zinc. And a non-metallic, we have a non-organic, so there is a glass foreign bodies, and then there is a organic where there is a wood, thorn, or any other trauma. Now, localization of IUFB is the prime aspect for the management. So it's ocular adnexal trauma, intraocular, so it's part in the anterior IUFB or posterior part of the segment involved, or it's an intraorbital extraocular foreign bodies. Now, initial days they used to do X-ray, localizing with X-ray, orbit, Walter, Caldwell stray, push to ring on that limbal thing and localize it. USG-B scan is very helpful sometimes, but if it's an open globe, we usually try to avoid it, or we mention that we have to be very gentle. CT scan is a preferred imaging modality, and it will be even help to find sometime orbital fractures along with the IUFBs, and it helps in localizing also. MRI is useful, but not used for the metallic foreign bodies. So there is an anterior approach when there is a without lens involvement or with lens involvement. We differ is the posterior we go external or internal. If the lens is involved, better to do lensectomy in all the cases and remove the foreign body via limbal approach. So armamentarium, we have to keep it ready. For all the IUF cases, must keep all your forceps, all the things you have to keep it ready, because many a time there are many forceps will not able to grip or hold the foreign bodies, or it drops or it just slips down. So there are diamond dusted forceps, there are magnets, there are claw type of forceps, which sir has been named by sir, and we have used for the palate injuries. So there is a surgery will show So this is the glass foreign body which was there and stuck in the anterior segment and which has caused inflammation, and there is a cataract around. So separating it, causing minimal injury to the iris tissue or the trauma, and remove from the clear corneal incision. And then we have used the iris hook and just separated all the adhesions. And then we have, with the help of cutter, we have done lensectomy and remove all the lens matter. It's very important to remove the complete capsular bag. We don't want post-operative hypotonies. And then pupilloplasty was done at the end of surgery. And such cases, we can plan a secondary PCL after some time. This is the second surgery. This is a foreign body in the posterior segment, and always look for a multiple foreign bodies, because if there is a one, we will not be sure about if there is a multiple or many shadows. We should always look for another foreign bodies, because if there is an injury in such a way, the primary corneal suture was done at somewhere else, patient came for it. So after lensectomy, when we went inside, there was a dense vitreous hemorrhage which has surrounded the foreign body. And we have removed the foreign body from the clear corneal incision. Then there was one more foreign body inside. Again, we have lifted, and we can just lift and put it back on the iris surface and then remove the things. Many a time chandelier illumination is very helpful, because if we are explanting or changing the hands, we don't want foreign body to fall it down. So this is the third one from the same case. This is the bigger one, and we have just put it back on the iris and then remove from the clear corneal incision. It's much better than, rather than removing a pars plana, but because of the large retinotomy, we can say the large foreign body, and there was a total retinal detachment. So we have put PFCL, settled the retina, bleeding was stopped, and silicone oil was injected at the end of surgery. Now, the better visual prognosis or the poor visual prognosis. So the two criteria, when initially patient comes, the lens is normal, no other lens injury, decreased wound length was there, only anterior segment foreign bodies, or old age of patient, and pars plana vitrectomy was used, no RD was there or no endophthalmitis was there, the visual prognosis is much better. But in opposite kind of thing, we have a much poorer visual prognosis. There is a RD, endo, PVR, vitreous hemorrhage, hyphema, and posterior segment IOFB, or it's a young age. So there is an orbital trauma score, which was again work done by the Ferenc Kuhn, and he has been given the different terminology. So the significance is for the patient, we can say about the quality of life, anxiety relief, economic decision, because we have to explain such patient that they need multiple surgeries. It never been done all IOFB management in a single surgery. For ophthalmologists, it's better for counseling, triage, management, and research purpose. So he has given score. I don't go in detail, but there is a chart we can follow, and you can just give the numbers accordingly. And then as per that numbers, we can have the prognosis, visual prognosis to explain to the patient. Now complication, the traumatic endophthalmitis is very common, and we have to follow up patient and take care of it. RDs, traumatic cataract, angle recession, glaucoma, corneal scar, traumatic optic neuropathy, and sympathetic ophthalmia are few of the complications we manage. Sure. Thank you. Thank you very much.
Thank you, Dr. Dharmeshkar. Now I invite Dr. Yash Parmar, who is presently an assistant professor in BYL Nair Hospital and a trained VR surgeon, He's taking care of VR fellowship programs in Nair and is very much interested in doing a lot of ROP work and has keen interest in teaching too. So over to you, Yash. Next is
Good morning, everyone. I would like to thank Kamala Sundaram Foundation, Natarajan sir, Naina ma'am for giving me this opportunity. I'll be presenting stepwise approach in the management of intraocular foreign body. So this is a repetition of topic. I was not aware of what sir is going to present. So I'll try not to repeat the slides, and I might skip many of my slides, and I'll give you a more case-based approach. Full screen. Okay. So I'll be discussing intraocular foreign body in these headings. So intraocular foreign body accounts for 40% of the total penetrating ocular injuries. It has already been discussed. Brigham eye trauma score and ocular trauma score is what we use. So whenever foreign body enters the eye, it can be through the cornea, limbus, or sclera. So you always have to look for the entry site. These are the zones, and it might get lodged into your cornea, lens, into your anterovitreous cavity, in the retina or subretinal space or outer coats. These are the type of foreign bodies already discussed. So whenever a patient walks into you, as sir had mentioned, Dharmesh sir, history is of utmost importance. When the patient tells you, I was working with a hammer and chisel on a stone, on the wall, you might think that it is the wall or the stone which would have chipped, but most of the times it is a chisel. The chisel, a fine fragment from the chisel would have flown into the eye. So the history itself will tell you whether there's a foreign body or not and what kind of a foreign body to expect. Always do your medical legal MLC registration and do a thorough examination from pole to pole. 3 things you have to notice when examining. Look for the IOP of the patient, what is the presenting visual acuity, and look for the entry site. So if the patient's IOP is low, you have to suspect that there can be an RRD, there can be a ciliary shutdown or an ocular coat discontinuity. Poor visual acuity tells you that can be a vitreous hemorrhage, there can be RRD, endophthalmitis, submacular or premacular hemorrhage, and a complete PL negative vision will tell you that you might be looking at an optic nerve lesion, optic nerve avulsion. So once you know that the IOP is okay and you've seen your wound, you know whether you are dealing with a self-sealed or a leaking wound. Get a Seedles done. See if the wound is leaking. And if the wound is well sealed, it will tell you what investigations to do. So 2 utmost importance of investigations for an IOFB is to get a CT done and B scan done for every patient. You might be told that B scan should not be done in such eyes. So B scan is not to be done when the coats are discontinued. It's an absolutely hypotenuse eye. But otherwise, I would say B scan is a must for every ocular trauma patient when you are suspecting IOFB. It just does not tell you about whether there is an IOFB or not, but it will also tell you whether there is a retinal detachment or not. And it will help you plan the surgery better. CT will never tell you whether there is a RD or not. So CT will guide you with the foreign bodies. B scan will tell you whether there is a retinal detachment or not. B scan might miss out on some foreign bodies. CT will find out all the foreign bodies. Sometimes there will be multiple 2-3 foreign bodies. Sometimes it will be stuck in the outer coats, which you might not find on B scan. So I'll just jump to the cases now. This is a 41-year-old female presented to us with a dashboard injury and shattering of glasses and a glass particle entering the eye. Her vision was 6/12, IOP was 14. We could see descent fold. She was status post LASIK, cells and traumatic mid-grasses. So on examination, we could see a descent folds. At 1 o'clock, we can see a self-sealed corneal tear, and it was Seidels negative. So it is a penetrating zone 1 injury with suspected IOFB. We could see the fundus clearly, and we could see a glass foreign body inferiorly. The B scan confirmed it. So the patient has good vision, no hypotony, and a glass, which is an inert foreign body in the vitreous cavity. What will be the management? I'll come to the management after the second case. So this is another case with a similar dashboard injury, but the car was next to him. It was hit by a truck, and the windshield glass particles entered his eye. This patient came with a PL plus PR inaccurate vision, V-shaped self-sealed corneal tear, hyphema, shallow AC, no view of the retina. CT scan was done, foreign body was found, and the B scan showed a retinal detachment. So now I know that what I am dealing with. When I enter, what am I expecting? So once you enter, so whenever a glass foreign body comes to you, it is an inert foreign body. When do we intervene? Immediately, when there is a retinal detachment, end of non-resolving VH, or an incarcerated wound with the vitreous leaking. So vitrectomy was done for this patient. Patient maintained a vision of 6 counting finger half meter. There was a lot of scarring post-op, but did well. The eye got saved. The first case, which was a clean wound with a glass foreign body, we actually waited for a few months, and the patient maintained a vision of 6/6. Eventually, we removed the foreign body, but we just wanted to see what we can do, what happens if we keep the foreign body in the eye. So an inert foreign body did not do anything for months together. This is the third case. A 46-year-old male presented to us with trauma while working in hammer and chisel. His vision in the left eye was hand movements, IOP was 16. And we could see streak hypopia on VH, and we suspected an intraocular foreign body. B scan was done, IOFB confirmed. Patient was not affording, we did an X-ray instead of CT, could see the foreign body. And vitrectomy was done. So a lensectomy was done, primary wound repair was done first, followed by lensectomy. I'll just jump the slide. And the foreign body was removed. It's not going forward. Patient maintained a vision of 6/75. This is the fourth case. Similar, a girl was passing by a factory when somebody working next to her with a hammer and chisel, and she got an eye injury. She presented to us with hand movements, vision, IOP of 10, SCH, vitreous hemorrhage, and we suspected a foreign body. So here we did a B scan. We did not do a CT. We could see a foreign body. We did the vitrectomy for her. So this core vitrectomy is being done. So the principle of any vitrectomy for IOFB is first do a primary closure, followed by core vitrectomy. Free your IOFB of all the vitreous around it. Don't try and pull the foreign body when the vitreous is still there. Once the IOFB is free of all the vitreous, if possible, do a PVD induction, complete your vitrectomy, let the peripheral frill be there, then take out your foreign body, and then you can complete the vitrectomy. So in this case, what exactly happened is we did the vitrectomy, and till the end, we could not find the foreign body. On the B scan, we could find it. And then eventually, superior to the disc, we found an impact site. And probably the foreign body was in the outer coats. So we just had to laser the impact site and we came out. So the post-op patient is doing well. Subsequently, she underwent cataract surgery and maintaining a vision of 6/8. But we did a CT scan eventually, and we found that the foreign body was sitting in the orbital cavity. Nothing is done. I have similar 2 more cases. It stays there, but yeah, long-term chances of sidrosis are always there. So investigations have already been spoken about. CT scan and B scan. So B scan, air is a mimicker of IOFB, but it will move with your eye, and it will get absorbed over time. So you have to differentiate between air and IOFB on B scan. CT scan, depending on the Hounsfield unit, will tell you what kind of a foreign body it is. So a glass will be a lower Hounsfield unit, a metal will be a higher Hounsfield unit. So you keep your instruments ready when you enter. You know that I am dealing with this kind of foreign body. I'll just show you the principles of vitrectomy. So any IOFB vitrectomy, basic principles are this. You do the primary repair. Make the media clear. Keep your side for tunnel ready. Do a lensectomy. Patient had a cataract. Do a complete good lensectomy. Then we go and do the core vitrectomy.
It is not moving on the screen. It's okay.
Sorry for that.
Yeah.
So we did, this is the primary repair. You suture the wound. Put your ports in, do a lensectomy, lens was cataractus. Do a core vitrectomy. Here we could already see the foreign body. Release all the vitreous around the foreign body. IVT is injected. Do a PVD induction. Better to do a complete vitrectomy and then chase the foreign body. Similar goes for your intraocular lens drop. So a PVD induction is done. Vitrectomy, peripheral vitrectomy is done. And then I enter with a so the wound entry is made, the sclerotomy port is enlarged to put the magnet in, and then I go in with the magnet. Make your entry wound, and it can be taken out from the limbal root. And the ports are closed. Yeah, these are some examples. This is a large metallic IOFB.
Yash, any more videos you have to show?
That's
Your
it, ma'am.
time
Finished.
is up.
This is a glass IOFB. And finally, an old encapsulated metallic foreign body. I just wanted to show you a large nail. This is Bapai's forceps devised by Dr. Manish Bapai and Natarajan sir. So for large foreign body, it comes very handy.
Oh. How did it go in the first place?
Okay, that is all. Thank you.
Yeah, thank you, Dr. Yash, for those beautiful videos. Now I hand over the mic to Dr. Dharmesh.
Sure. Yeah. Good morning, everyone. Thank you, Yash, for the excellent presentation. It's an honor to introduce Dr. Gangadhar Sundar. He is a senior consultant and head of Orbit Oculofacial from NUH Singapore. And he actually don't need any introductions, but he has done excellent work in the trauma and oculofacial surgeries, and he has numerous awards from many societies. He has leadership roles in many societies, including Asia Pacific Ophthalmic Trauma Society. So I would like to welcome Dr. Gangadhar Sundar.
Dear chairpersons, friends, good morning. Thanks a lot for coming. I spoke a few words about how passionate we should be about ophthalmic trauma, and very pleasing to see that the theme of the symposium here, it's over there, right? On ocular and adnexal trauma. You don't hear that phrase very often in ophthalmology meetings. In ophthalmology meetings, they just keep talking about ocular trauma, ocular trauma, ocular trauma. And we always say that you and I are not ocular specialists. We are ophthalmologists. And in ophthalmology, in anatomy, physiology, pathology, we learn about the eyelids, we learn about the lacrimal system, and we learn about the orbit, and we learn about the eyeball. But sadly, for decades, all of the trauma focus has been on the globe, which is beautiful justice done by our previous speakers. But adnexa has always been left behind. And I can tell you confidently that for every single corneal laceration or open globe injuries you encounter, you probably see 10 eyelid lacerations. Am I correct? And then we forget to get a CT scan on some of these severe trauma patients. And the moment there is a fracture, who do? You either ignore it or send it to your maxillofacial surgeon and leave them manage it while you manage your eyeball, which is good because eyeball is a seeing structure. But that's where we as ophthalmologists should take charge of the adjacent adnexal tissues. And that's why I think Dr. Natarajan has given me this talk on ocular adnexal trauma. Just show of hands, how many of you are postgraduates here? Good, so, and I'll put my hand up also because I'm also learning all the time. So I'll probably make it a little bit more interactive if the chairperson allows me. Can I ask questions to the postgraduates? Yeah, absolutely. Yeah, very good. So the first question was, what is the difference between ocular and ophthalmic? I've already answered that. Okay. So let's go further and see what it's all about. So we heard about ocular trauma, corneal lacerations, chemical injuries. Dr. Chavanas today is talking about Stevens-Johnson syndrome. Is that trauma? It is trauma. Trauma related to an inflammation, which is related to a drug or viral infection or whatever it is. So it's a continuum between chemical injuries, Stevens-Johnson's, and so on and so forth. And in the past, we used to talk about the lid, lacrimal, and orbital system, but we now know the orbit is part of the midfacial skeleton, and that's part of the whole face. So we now are, believe it or not, oculoplastic surgeons are now called oculofacial surgeons. So those of us who do functional work, we repair the whole face. And those of them who are doing aesthetic work, they're doing Botox and fillers and blepharoplasties and brow lifts and facelifts and so on and so forth. So from using this eye as a center, we are now addressing and responsible for the whole face. So whether Dr. Chavan does prosthetic work and stuff like that, we are rejuvenating the entire face. And by rehabilitating the same face and the vision, we are serving the patient and changing their lives, not just changing their vision. So when you look at regional trauma beyond the orbit, we're talking about facial. And when you're dealing with traumatic optic neuropathy and visual loss beyond globe injuries, we are even dealing with intracranial pathology. For example, pediatric ophthalmologists, there used to be a phrase called CVI, right? I know you're not a postgraduate, but you can educate the postgraduates. What is CVI? What is CVI? Cortical? So cortical visual impairment from brain ischemia and so on and so forth. Now we know that it's no longer cortical pathology. It's multiple levels in the brain. It's now called brain-based visual impairment. And all the injuries that happen from all the soccer, for example, rugby, for example, where we're doing headbutting the ball, so much so that UK now has banned heading the ball of children playing soccer because of the repetitive injuries that happen in the brain, which affects the brain and subsequently the visual pathways and so on and so forth. UK is the first country to do that. Even the US has not done that. And we see kids who are all playing like Ronaldos and Messis and who's our Indian Mohan Bagan player? I forget his name, who won an award. I mean, so even that causes a lot of trauma, which we fail to realize. And the same ball, which is bigger, soccer ball on the head, it becomes smaller, becomes a tennis ball, for example, or a squash ball hitting the eye, causes trauma. So we should not see trauma of the eyeball in isolation from trauma to the rest of the face and the head and the rest of the body, and there was a mention today about polytrauma itself. So when you look at the clinical aspect of it, the eyelid, eyeball, and the face, we as clinicians and surgeons are looking at the socket and the brain underneath, so forth, which all has to be assessed. The next point I wanted to talk about is this particular classification. I think our previous speakers talked about it. Do you know who drew this graphic? Go back and look at it. It's Dr. Andres Rosello from Argentina, who happens to be our APOTS member, Asia Pacific Ophthalmic Trauma Society member. And he is the one who is instrumental in contributing to the eye gates, which was talked about in the morning classification. International Globe and Adnexal Trauma Epidemiological Studies. It's no longer about globe eye study, globe injury study. It is now globe and adnexal trauma study, because 90% of the patients who have globe injuries have some form of lid contusions to lid lacerations, fractures, orbital foreign bodies, and so on and so forth. But what is missing, and that was written by, do you know who came up with the BET classification system? Who used it? Postgraduates? It was mentioned several times before. This slide has come several times today's talk. Ferenc Kuhn. So I call him the modern grandfather of modern ophthalmic trauma. When he came up with the classification, he classified them in closed globe injuries and open globe injuries and stopped right there. But I don't know how many of you have seen. I've even seen globe avulsions. Injury so bad, the whole eyeball prolapses out of the eye, transected in the muscle and the nerve as well. So there are any classifications will have a limitation. You should not criticize it. Utilize it to your best advantage, but then think beyond it and realize that the classification of any globe injury is now open globe injury, closed globe injuries, and globe avulsions. And then you can talk about penetrating, perforating, so on and so forth. So being familiar with terminology is very important. The other reason why the terminology is very important is because by default, residents and postgraduates are guilty of calling any open globe injury as globe rupture. Is that correct? But what is the definition of a globe rupture? Can you point to one of your postgraduates? What is the definition of a globe rupture? And about 2 minutes before my time is end, I'll stop, if you don't mind, chairpersons. Yeah, pick on our postgraduate. Yeah, what is the definition of a globe rupture? Go ahead. Speak up. I thought Indians are the most vocal people. On social media only, or? So globe rupture is any open globe injury secondary to a blunt trauma. Okay, so if a knife went in, pencil went in, I think we saw some cases today, they are not by definition globe ruptures. Okay, they're either penetrating injury, which means just a point of wound and that's about it, or the same pencil has gone through and through the cornea and the posterior exit also has happened, is called a perforating injury. So if a resident or fellow of mine says, I have a patient with globe rupture, by default, I'm assuming it's from a blunt trauma. Because the consequences of blunt trauma to the internal architecture of the globe is very different from the consequences of a fine penetrating injury. In fact, far more trauma is done with blunt injuries than penetrating injuries. So this is where we should get our terminologies right, and that's the message behind this particular slide itself. So what do you look at? And you look at adnexal trauma. We all know this from textbooks. There's lid trauma, lacrimal trauma, and orbital trauma. Even contusions of the orbit causes consequences. For example, a closed globe injury with hyphema has consequences like angle changes, secondary glaucoma down the road and so on. Likewise, I have residents who come and tell me, he's just got a periorbital bruising. It is never just, because to cause that bruising, there was so much impact to the face and the adnexa and the globe that the consequences have to be kept behind. And don't forget avulsions, which are different from standard cut lacerations. Kitchen knife, pen knife, and knife injuries are different from avulsions, which happens in the past. Women used to wear clothes with hooks on them. Mothers used to feed. Does it still happen in India or not really? Still does. Baby's eyelids being caught. And dog bites. I always say dogs are called canalicophiles. They love the canalicus. They love the lower canalicus, I think. They just go for it, yeah? And usually it's not a neighbor's dog, a street dog, although India has a lot of problems with dog bites and stuff like that. It's your own dog. Children playing with their own dog at the when the dog is feeding, play with them, and the dog goes for the face, and typically on the face, they go for the eyelids. And of course, once in a while, the eyeball itself. Then we talk about lacrimal trauma. We'll talk a little bit about it, which even starts from the punctum. Remember, lacrimal system is not all canalicus. And don't forget the lower end nasolacrimal duct, and we'll talk a little bit about it. And finally, orbital fractures. So next question is number 1, is ophthalmic trauma preventable? All these injuries, are they preventable? Yes. Truth is yes. But it's like, are all complications from cataract surgery preventable? Yes, but you do enough, you will have them at all. That's where the term of risks and complications comes in. Complications is what you can minimize and prevent with expert techniques. Endophthalmitis, wound leaks, and so on and so forth. But the risk is something that happens even if you do your best job. So even to take a lot of prevention to prevent trauma, invariably when a child goes out to play cricket and sports, fights with a friend in school, which is part of growing up, you will have some trauma. Yes, it is mostly preventable. We wish it was 100% preventable, but about 90% of it is preventable, okay? So second question, which canalicus is more important, upper or lower? How many say lower? How many say upper? So they are both equally important. So never ever neglect the upper canalicus and say, no, the lower is a more important one. It's like a marriage relationship. Who's more important? Actually, I have preference. I know who's more important, and most of you know already, okay? So which type of fracture, now going beyond the eyeball, the adnexa, if you do a CT scan of the face, remember, I have ophthalmologists who come and tell me, my cousin has got a zygomatic fracture, but no orbital involvement. Which anatomy textbook tells you zygoma is not part of the orbit? The lateral wall, the lateral part of the floor of the orbit is all formed with zygoma, okay? So which of these two fractures is more likely to involve the lacrimal system? Anybody? Sorry? Naso-orbitoethmoidal fractures. These are midline fractures, involve the medial wall and the lacrimal system is right there. And finally, we're going a cutting edge and talk about implants itself. So quick take-home messages. For example, if you look at the child over here, I know the contrast is not there. If the laser pointer really works, which it does, see? That's a wound of entry. You were asking the previous case, how does such a large foreign body go inside? And these are children who actually get into fights, play at school. They get injured. They're already traumatized. They come back and tell the father and the mother, and they give them more trauma. Beat the child up. So a lot of children hide the history of trauma, the fights, and that's the reason why sometimes it's picked up either incidentally or picked up as a late finding when a child is in a fight, punched in the face, keeps the eyes closed. We don't know whether the globe is injured or not. That's because the muscle is entrapped. Then they are forced to open the eye 2-3 days later. The entrapment causes nausea and vomiting. Then when you have a blunt injury and nausea and vomiting, they get admitted, get a CT scan of the brain, thinking it's brain injury, brain is fine. And only then somebody realizes, oops, the eyeball is not moving up. And we're guilty of picking up these entrapment and pediatric white-eyed blower fractures late, when actually you should be picking them earlier. So remember, history is not always reliable in pediatric injuries. And of course, bystander injuries, you never know what's really happening to as well. So the principles of management, number 1, it was a clean cut. Everything that was talked about, antibiotics, tetanus toxoid, cleansing, primary repair, layer to layer. But one take-home message is any lid margin laceration medial to the punctum involves a canalicus until proven otherwise. And both upper and lower canaliculi are equally important. And all canalicular lacerations should be intubated and primary repair done. The difference is you can do it within 24, 42 hours. You don't have to go in the middle of the night and do it. So we'll talk a little bit, yeah. Why are we going back with this slide? Or is it supposed to be this way? Okay, and of course this child had a pencil lead inside as well, okay? So we already talked about textbook versus applied anatomy. So when you look at any structure, corneal laceration, corneoscleral laceration, lid laceration, whatever it is, there are important anatomical landmarks you need to identify. Once you identify, even if you have tissues like these, you can easily reconstruct them together. The landmarks are the canthal tendons, The lateral canthal tendon has an upper and lower crux which goes to inside of the orbit. The medial canthal tendon has an upper and lower crux. There's even a posterior limb and a superior crux. But the difference is the medial has the canalicus. Once you identify the ends, then the rest of the tissues kind of fall into place. So you should be able to follow the principal rules and do it as well. And you can read this from textbooks. Oppose the lid margin, then oppose the posterior lamella, which is the conjunctiva and the tarsus. Once you approach the posterior lamella, then you do the anterior lamella. The principles are very good as well. So this is a patient who was robbed at a bank, ATM, when he was withdrawing his machine. It looks very, very jagged lacerations, tissues all over the place. You can see the fat which is present right over there. That by default should tell you that the globe can be injured even behind, the levator can be injured behind. But you rule out the globe injury after exploring this patient, usually under general anesthesia, but if necessary under local anesthesia. Put the structures back together, you can see the post-op outcome of this patient itself. Yeah. Here's a child. This is a Singapore story. The child was taken along with the bigger sister to a park in Singapore, in Jurong West Side. A monkey came along, literally picked up the baby from the pram and ran away with the baby, and the mother went after it. And looked like a simple laceration. Literally, this child is 1 month old. It looks like a simple little laceration. But only when you explore, you realize it's a through and through laceration. Thankfully spared the globe. There are implications related to monkey bites and rabies and herpetic infections and so on and so forth. But implications for us ophthalmologists, once you rule out the globe injury, you will counsel the patient guarded visual prognosis. We talked about it. Prepare the worst, give it to the junior-most person. But if you do a meticulous job, look at the same outcome, all from the original primary repair. Layered closure, conjunctival, subconjunctival closure. Obviously, the levator is transected, right? The upper lid you can see. You put the levator back, even absorbable sutures is fine. Then you can go back and suture the anterior lamella. You get as good a result, all with a simple primary repair. So the take-home message for us is the first time is the best time. Every time in life, I think, usually, right? I mean, the first time is the best time. This is the same child grown up, all from that 1.5 hour surgery, done as he was on a 1.5-year-old. The mother's only complaint was he didn't do a double eyelid surgery for the right side. This is an East Asian child. I said, when his girlfriend complains, I will fix it. I will create a double eyelid for you. Here's another patient, motorcycle accident. I get a call Monday morning. I'm in the clinic. My fellow is with me. And they say, patient with lid laceration. I send my junior-most fellow there. He calls up and says, Dr. Ganga, all the eyelid is missing. We have to do a flap and a graft. But I told him, explore. And if you look at the tissues right over here, there's a whole bunch of mangled tissue right over here. He explores and literally finds every single piece of tissue. So unless it's a bite injury, almost always the tissue is present. You should be able to identify the landmarks, same principles, lid margin to lid margin. This is a lateral laceration, not a medial laceration. Levator, put it all back together. This is all from a primary injury. He's got a little notching and the irregularity of the lateral part. Patient didn't have any lag of ophthalmos and exposure. We left it at that. How many more minutes do I have? Sorry? 12 minutes. Okay, good. I'll try to finish on time. So, lid lacerations, anatomical landmarks, unless there's avulsion and loss of tissue, we now know that the worst case injury I've seen is a couple who was so madly in love, she bit his eyelid off and brought the eyelid with me, and we did a primary grafting. So, barring which most cases will have residual tissues as well. So coming to lacrimal trauma, don't ignore the lacrimal system, just as how the secretory system, dry eye talk was there, the drainage system is just as important. Those of you who don't know, when you're driving a car on a rainy day, if your windshield wiper doesn't work, the windscreen is wet, can you really drive with a lot of confidence? No. But we ophthalmologists are guilty of abusing our patients who are complaining of tearing eyes. And guess what treatment do we all give? More drops. Already they're wet and teary and they're wiping their eyes. Are we all guilty of that? Yes, right? So I think a tearing patient needs a lot of respect, and that's why evaluating the lacrimal system is very important. And don't think about it purely as lid canalicular lacerations. Even mid-facial fractures involve the nasolacrimal duct. And that's why we ophthalmologists and oculoplastic surgeons should be our patient's advocate, and anytime there's a mid-facial trauma, there's an NOE fracture, don't ignore the lacrimal system. We talked about the repair of the canaliculus, intubation, monocanalicular, bicanalicular. Here's a patient who had a lower lid laceration under local anesthesia. You can do it. You do a pericanalicular repair after intubation. Usually you do with long-standing sutures. Usually I use nylon or PDS or something like that and do a lid margin suture repair. So in the interest of time, I'll skip on the videos, but I'll try to talk about, we can always play it again later on as well. So this can be done under local anesthesia. So how about nasolacrimal duct? If the nasolacrimal duct is involved, we now prophylactically intubate the nasolacrimal duct. And it's very similar as a pediatric ophthalmologist would do syringing and probing for congenital NLD obstruction. We don't do adult probing and syringing for NLD obstructions. We do. The new realm of lacrimal drainage surgery is no longer external endoscopic DCRs. We do a lot of endoluminal recanalizations, minimally invasive procedures. How vitrectomy, there's a lot of endoscopy inside the eye. Here's a patient where we are trying to, should be done, the intubation should be done before the maxillofacial surgeon moves all the bone of the midface. Because once they move the midface, they transect the nasolacrimal duct, or they put so many hardware, plates and screws there, going back and doing a DCR becomes a nightmare. So very similar to the probing and syringing we do into children. Of course, adults are not just grown-up children. The anatomy is very different. You should be very familiar with it. Then you do a prophylactic bicanalicular intubation as atraumatically as possible. Yes, the lower end part inside the nasal cavity can be done by touch and feel, or if you have an endoscope, you can do that, but in a trauma situation, there's a lot of bleeding. So become a proponent or work with an oculoplastic surgeon who's comfortable with working with the nasolacrimal duct in patients. And once the system is intubated, then the fracture surgeon can do the opening, the reduction, plating, so on and so forth. So you can avoid doing a late DCR for these patients. So in midfacial fractures with fractures of the nasolacrimal duct, this is something in the cutting edge that you should be talking about. So last few minutes, I'll touch a little about orbital fractures. Remember, orbital trauma, not all of them are just fractures. Contusions are also very important, and an important vision-threatening measure is compartment syndrome, orbital compartment syndrome. This can happen usually after falls, but those of you who do blocks for cataract surgery, glaucoma surgery, I don't know how many of you have the occasional bleed in the orbit so bad, you can have visual loss. And this is a medical and a medico-legal issue as well. This is a lady who fell down, came to the emergency room with a laceration, which was heroically repaired by an emergency room physician, thought the eyeball was okay, but after closing the laceration, the orbit became so hard and tense, she completely lost her vision, and what she had was a retrobulbar hematoma, orbital compartment syndrome. And you can see the scan over here, which shows tenting and stretching of the nerve, and once you see that tenting, you know the optic nerve has been compromised, even if the patient is not awake and alert to tell you. Of course, the RAPD is a good as well. And the orbit is rich with vasculature, and you should remember that orbital compartment syndrome visual loss is not from central retinal artery occlusion, which is what we all teach our residents. They are from closure of the smaller PL vessels which supply the optic nerve. And how much pressure, what is the mean arterial pressure of the central retinal artery versus the mean arterial pressure of a ciliary plexus? Small. Sometimes even an orbital pressure of 30 to 40 to 50, sudden rise in a compromised patient, elderly patient with diabetes, hypertension, is enough to cause ischemia, causing visual loss. Because people look at the fundus and say, no cherry red spot, no CRAO, but there's an RAPD. But optic neuropathy, ischemic optic neuropathy has already happened. So these are patients, you have a lower threshold for doing canthotomy, canthalysis, septalysis. Textbooks will talk about all these features which we examiners ask of residents, but take home message. A rock hard orbit with an RAPD visual loss and a tense orbit is orbital compartment syndrome until proven otherwise. So the management is consent. Sometimes you don't have time for a written consent, a verbal consent. Whether you do local or GA is up to you, but if you're giving local, give a lot of local anesthesia, be generous local anesthesia. It is not only lateral canthotomy and canthalysis, it's canthalysis and septolysis. Until you release the orbital septum, the blood is not going to come forward or cause decompression itself. And then with an artery forceps, you have to evacuate the pockets of hematoma. This is the same patient where they came to us, we reopened the laceration, evacuated the compartment syndrome, but it was 3 hours by the time she was sent to us. Her visual loss remained permanent, unfortunately, but you still have to do it. Finally, touching a little bit about orbital fractures. Again, as examiners, we only talk about blowout fractures and white-eyed blowout fractures in children. Remember, it's not orbital. I think one of the vitreoretinal surgeon is I think you talk about orbitofacial fractures, orbitofacial trauma. I'm very happy to see that. Now people are starting to use orbitofacial rather than pure orbital itself. So they can be pure simple fractures like these that you can see, which we ophthalmologists manage. See the tissue there, musculus inferior rectus is prolapsed in tissue. Remember, entrapment is not a radiological diagnosis, it's a clinical diagnosis. Patient has limitation of movement without pain, then usually talk about entrapment. Here's another patient who's got a combined floor and medial wall fracture. But we wanted to go beyond that. So we classified, we wrote this in our book, which was launched by Professor Natarajan, Dr. Badrinath, and all that in 2018 in the Chennai trauma meeting. We classified fractures into pure, simple fractures, which are linear fractures, blowout fractures, very rarely the blow-in fractures. And of course, the rest of the orbital fractures on the right side are complex fractures, zygomaticomaxillary complex fractures, naso-orbital ethmoidal fractures, cranio-orbital fractures, and even panfacial fractures. The reason why you need to come up with a good classification system is you should know when you should be intervening in these patients, what role you play as an ophthalmologist in a patient with a bad facial trauma when the craniomaxillofacial surgeons and neurosurgeons there. You should tell the surgeons where to go, where not to go. You take responsibility of the orbit so that you can give the globe a good platform for good rehabilitation, and then you also prevent harm for these patients itself. We also came up with this A, B, C, D, E, F, G, H algorithm, where based on the age, the threshold for intervention changes. The younger the patient, the lower the threshold for intervention. Whereas an 80-year-old came, you're not going to operate on these patients. Whether it's a bilateral fracture or unilateral fractures, the times you set aside for the fracture repair, and whether the asymmetry is going to be obvious or not is very important. C stands for complexity. The more complex a panfacial fracture you have to be involved in multiple teams. That's why I think eye institutions have done themselves a lot of disservice by being a pure ophthalmic institution. They cut themselves from the maxillofacial surgeons, the neurosurgeons, and ENT surgeons. That's why you should have your ophthalmologist who visits some multi-specialty hospitals and be part of the team and leaving the ego aside. D stands for displacement. The more displaced the fracture is, the more enophthalmos you're going to get. But that doesn't mean that the minimally displaced fracture will not have consequences. The smaller the fracture, tissues get entrapped, then the earlier the intervention should be there. So D is the displacement. E is entrapment. We talked about the clinical features. F, foreign bodies, 2 good talks on intraocular foreign body. Likewise, there can be intraorbital foreign body. Sometimes there can be a through and through intraocular and intraorbital foreign body. A foreign body went through the globe, rested on the outer surface of the sclera. Is actually a confluence between intraocular and orbital foreign body, knowing how to manage it. G stands for globe injuries, and that's where you ophthalmologists will come in and say, tell the fracture surgeons, do not touch the orbit. The globe is compromised. We need an early vitrectomy. Tell them not to do heroic transconjunctival incisions because the conjunctiva is necessary for the ophthalmologist and the patient. And only when the globe is stable, then you go about doing repair. And finally, whether the patient is a high-risk patient or not. So if you use a combination of the practical classification we came up with, simple and complex fractures, and come up with the ABCDH patient-specific modifiers, you can define the threshold for intervention. You can define whether you're going to do it yourself or not, whether you're going to involve the neurosurgeon, the plastic surgeon, maxillofacial surgeon, or you can define when you're not going to intervene these patients as well. So I think in the interest of time, and this is a little complex talk for orbital surgeons, I'm not sure how many of you are there, but just to take home message is that not all fractures have to be fixed, but if it's a child who's got limitation of movement, younger the child, the earlier you go in as well. Remember, not just because it's a small fracture doesn't mean it does not have consequences. This is a CT scan of a patient where the radiologist reported as no fracture. But actually, if you look at it, you can see the inferior rectus, which is a flat belly here, is incarcerated there, and there's a little bit of tissue as well. So be the ophthalmologist who reads the scans yourself and do not read the reports yourself. And when finally in complex fractures, be part of the multidisciplinary team which manages it as well. And finally, implants. This is where, again, similar to globe injuries and stuff like that, do you leave a permanent implant or a bioresorbable implant? Now, about 60% of the fractures we do, we use a lot of bioresorbable implants because by the time the implant absorbs in 12 to 15 months, the orbital bones are healed so well, you do not have to deal with implant-related complications. The same as silicone oil, I think, post-vitrectomy. I don't know, you VR surgeons, Dr. Natarajan, Dr. Carr, do you leave your silicone oil in forever? Or is there a time period within which you go back and take it out?
It's a varies from case to case, but we keep it for some longer time because they have the detachment and the PVR in such cases. But we need to remove at some time, some
Yeah, so
point
if
of
it's
time.
no longer necessary, you take it out. Correct?
Yeah.
So similar to that, yeah. So even the silicone oil is not a permanent fixture in the eye. When it's no longer necessary, you take it out. So obviously in orbital fracture, you cannot put a big implant inside and say, okay, I've done its job, I'm going to take it out. Put a bioresorbable implant, then you don't need to take it out and the patient is healed very well. So it's a surgical video, and these are examples of patients, for example, complex fractures with titanium implants. We fixed it so that you have a happy patient. And these are examples of bioresorbable fractures. Just start, I'll end with this particular slide. You look at the CT scan above, large floor fracture. Where is the implant of the same patient? This is the same patient, 1.5 years later. CT scan shows the bone is completely healed. There's no implant inside. Now the patient doesn't have to worry about the long-term complications of implants that orthopedic patients face. So in summary, I think ocular adnexal trauma requires the same respect, if not more respect, anytime you're managing globe injuries. Remember, ocular trauma is not equal to ophthalmic trauma. Yeah, and proper evaluation is very important. Be the ophthalmologist who serves the patient, protects the patients from other teams which are violating the orbit. At the same time, you become part of the team so that you offer the best outcome for the patient. Thank you very much.
Yeah, thank you, Dr. Sundar, for the excellent presentation and the wonderful outcome, cosmetic result of the repair you have done. And so, Rajan sir. Sure. I would like to invite Padma Shri Professor S. Natarajan sir, who don't need any introductions.
So, Dr. Naina, I told, what's her name, Neeta will bring the dean. As soon as the dean comes, my last slide. So, whenever you are calling. You can call, yeah, no problem. We have given him 12:30, no? No? No, we have given sir 12:30 to 1. So, accordingly, yeah, no problem, I'll start. But what I'm saying, as soon as the dean comes, I can stop, no problem. So I'm actually starting my talk on principles of repair of scleral injury, and that's my entire reason I'm doing this program, because I see, as Gangadhar said, as a postgraduate, I was handling the wound repairs in Government Ophthalmic Hospital where me and Gangadhar studied, and later in Shankaranethala, even though I was a vitreoretinal fellow, on all my duties, at night, 1 o'clock, I'll get a sclerocorneal tear, and I was repairing in the midnight, and that's the greatness of Dr. Badrinath to give us. So for that, we prepared ourselves by doing scleral suturing in the, we had a OT fight that time. It was a infected OT, small OT. So we used to take the eyeball on the Saturday evenings and have a scleral tear or a corneal tear and practice suturing, because in 1982, when I did my post-graduation, nobody was allowed to use microscope in the medical college. Shankaranethala had, but they were doing it only for vitreous surgery. So I went and told Dr. Badrinath, I want to learn vitreous surgery, and that's how I landed up in fellowship in vitreoretinal surgery. So I think now every postgraduate is exposed to both slit lamp biomicroscopy and vitreoretinal surgery, ophthalmic microsurgery. So I think we should do a meticulous repair wherever we are in India, however remote village. So the sclera is responsible for the globe strength and integrity, and repair of scleral wound poses challenge. And ordinary, regular anatomy, if you don't know, and during the trauma, after the trauma, everything is changed. Even a lens capsule stained with blood will look like retina. So that's why I learned from Dr. Badrinath that whatever I remove from the injured eye, I send for histopathology. And I'm glad Twinkle mentioned about you should send the material for culture and sensitivity. And nowadays I send for PCR also, because we don't know what we will miss. Better to do that, because if you have removed the retina, you know that you have removed the retina. But if you just leave it, you don't know what's happening. So proper wound alignment, adequate closure, and tissue incarceration has to be taken care on the first repair. So I always remember And this is a publication from our own Maharashtra Ophthalmic in the central Maharashtra, what they did. So this is one I like it, the Bale Spikes protocol to counseling the patient's relatives eye trauma. S is for, the spikes is, S is for setting, arranging for privacy, involve significant others, sit down, establish rapport, manage interruptions. And actually, I do that, but I did not do it in the organized way because I spent a lot of time before doing the trauma repair. And P is perception, determine what the patient knows already, listen and offer information to the patient's level of comprehension. I was just telling Ganga yesterday, I'm managing a 7-year-old student who's studying in American school, and when they were playing a game called tag, the boy and the girl dashed each other, and the fiber optic glass broke into 4 pieces and cut the eye so badly, there was a loss of iris tissue, iris prolapse, corneal tear, vitreous hemorrhage, suprachoroidal hemorrhage, and retinal detachment. And I have spent almost 20 man-hours, and today evening we are going to spend 1 hour with the chief of cornea from LV Prasad, Dr. Gangadhar, and also our endoscope specialist, Dr. Rajiv, and Rajiv Reddy from LVP, the head of retina. And because I don't do it, but I did that surgery. But because he's a nice person and a family, I am spending time. So I have a counseling team, that means a nurse, optometrist to do that. For this patient, I am doing it personally. So determine what the patient knows already, listen and offer information. An invitation from patient to give information. Ask the patient if they want to know details about their condition, accept patient's right not to know, and offer to answer question. K is for knowledge, use intelligible language, and parcel the information, check for understanding, respond to reaction, give positive facts first, and give accurate information. The reason is, many times the patient wants to listen what they want to listen. That means whatever you are explaining, that this is what I'm facing this family. I am telling about sympathetic ophthalmia. I am telling about we may abandon the surgery. I am telling that cornea may get worsen. I have to put intraocular lens. Retina will get PVR. Everything they listen. Next day, Uday is also part of it. I'm happy Smith is here. So we all talk to this family again and again, same questions daily. But I think as a doctor, to avoid any medical legal, we have to talk. And second, I put myself in the patient and the patient's son, and I'm answering. So I think it's very difficult for particularly people working in municipal hospital and government, where we have hundreds of patients waiting, and even in busy OPD, but we have to have a dedicated team who need not be doctors. That's why I got Khalsa College volunteers here to be helpful to assist our medical care. And E is for explore emotions, empathize, and that's what is important. You should not sympathize, you should empathize, and that's why Dr. Kalam gave me a book called Compassion and Medicine, where it's about 200 pages by Dr. Schlim and first Dalai Lama Rinpoche, how to be compassionate to a patient, which is very, very, 200 pages are there, and it's worth learning. And allow the patient to express their feelings, because many times we tell the patient, no, we know what's going through, but he will tell the optometrist, he will tell somebody in the reception, again he'll come and tell the same. Better to listen, because he's suffering. And by telling again and again, I have a lot of patients who have not got vision. And the recent one is, I can tell the name, I hope tomorrow he'll come, is a Master Jaiswal. He was, I think the video is there, maybe when I show that I'll tell you. He's a sad story, but I sent him to a psychologist, and now he's a happy child. But he didn't get vision. The strategy and summary, close the interview. This is what Malcolm Gladwell said. In the US, if any doctor spends 15 minutes, he has the highest medical legal cases, and he spends 3 more minutes, and the last question, he asks the patient, do you have anything to ask? And if the patient says, no doctor, I'm satisfied, and if he goes, the medical legal case drops to 0. So I think I followed that for the last 40 years. And close the interview and ask if they want any clarification, offer agenda for next meeting. And this I learned from this guy, chairman of the ACG. He has got a dry AMD, and he wants to meet. So every time he pays my consulting fee, He says 15 minutes is this much charges. I want 30 minutes and he takes my time. And his brother's son is a grandson who got the injury, so we are spending time on all that. So all this has been covered. So this is the most important I want to tell all the postgraduates who are watching, and even the experienced surgeon who are watching in the YouTube, history, mode of injury, and I really spend a lot of time asking history. So I have trained all my optometrists to make a line diagram. If there's a cricket ball injury, how the injury happened. Was he a batsman, bowler, or a fielder, or somebody was throwing, and something like a bystander in a cracker injury. So then the mode of injury, because it's very important, if it's a foreign body, you should know whether it's iron, magnetizable, non-magnetizable, to plan the surgery. Baseline vision, which is very important. And many times, the child will not tell that light perception is there because he's already in mental shock, and maybe there's a shock to the optic nerve also. That's why you have to start the steroids. And history of ocular disease, surgery, medical history, visual acuity testing, pupillary examination, very important. Every postgraduate should know that. An extraocular movement examination and non-contact tonometry, scleral acceleration extent, vitreous loss, choroidal exposure, expulsion of UVL content, status of lens, and no scleral indentation during indirect ophthalmoscopy, or even while you should, Dr. Badrinath used to teach me that you should touch the eye like an angel, not like a devil, because if you press the eye, the intraocular contents can come out. And diagnosing the scleral wound, and then first start with a diffuse torchlight examination. I use the indirect light, slit lamp, then rest of the investigations. The goal, that's what, once upon a time, I remember when I was a postgraduate, is only restoration of the integrity of the globe and also only removal of the foreign body. Neither the doctor, eye surgeon, or the patient was not bothered about vision. Foreign body nikala na, I am happy. So now our idea is to repair the globe, remove the foreign body, repair the bones around, make sure he looks good, and also restoration of vision. And that's what we are working on. So to avoid constant hypertony, to lessen risk of intraocular infection. So the primary objective will be complete airtight, watertight closure of the globe with restoration of structural integrity. And every postgraduate, I request, either you take a tomato, crush it, and ask every patient, you are cooking or your mother is cooking, if a crushed tomato, can you suture the two leaves with the needle and thread, what you do in the taste? They said no. And that's what we are specialized, I tell them. So for that only you are paying the professional fee. And in a medical college like this, you are doing it free. And then you also should know about the secondary objective is the main restoration of normal anatomic relationship, avoidance of UVL tissue, because retinal S antigen will circulate, and that's what causes the sympathetic ophthalmia, because we don't have any of the UVL tissue in the wound, as well as steroid given, almost the sympathetic ophthalmia is gone. But I take consent even today for a on-the-table evisceration, enucleation, and sympathetic ophthalmia. Fortunately, I have not faced. But following 5 vitreoretinal surgeries for a young girl, 16-year-old, I remember the Parsons description. Any postgraduate here? Can you put your hand up? I want a volunteer. Any postgraduate in ophthalmology? Then I'll ask the professor there. No? Purva, you remember what is written about sympathetic ophthalmia, the first symptom in Parsons? Very good. And everybody should clap here, because everybody forgets that. This girl came and told me, I can't read, and this was only eye. And then I diagnosed sympathetic ophthalmia, and we saw the few spots and sent to Bishwas, and he said, don't worry, we'll treat it as a bilateral uveitis, and he saved the patient. So removal of necrotic tissue, removal of foreign bodies, and this is a surgical principle. I'll show you the videos, and this depth of sutures, I'm not going into the detail because you have to learn, and this is not the, and then main thing is to close as you go technique. Pardon? Which one? And then defining the wound, all this I'll be showing in the my videos which will come. And this is if there's a prolapsed an extruded vitreous, an intrascleral foreign body, and thin or necrotic sclera. So the do's and don'ts for scleral tear. So I believe in two-step approach, which I will tell in the next presentation. And this is a patient, this is the same patient which I told, Master Jaiswal, who had a bought a Swiss knife without telling his mother, and then he opened it in the tuition, and somebody pushed, he was having the Swiss knife like this, and somebody pushed his head, and the Swiss knife went in and out and came, and part of the eye was in this handkerchief, and he was totally, and the whole thing was swollen with because of the injury, hematoma all around the eye. CT scan showed that the eye was displaced, and in Fortis Hospital, the ophthalmologist told you have to remove the eye, and I was very angry because I am promoting as a president of Asia Pacific Ophthalmic Trauma and representing the International Society of Ocular Trauma, no primary enucleation, no primary reviseration unless it is a panophthalmitis. Rest of the condition, we have to suture the globe. And you can imagine this eye, after giving steroid, even though my first surgery should be done immediately, we did it about 6 days later because I could not be opened, full of hematoma all around. So now you can see the meticulous dissection happening, and I identified the corneal wound and suturing the cornea. And you can imagine this was a clean cut with that Swiss knife, and this eye could have been removed. You can imagine the psychological damage that child and the parents had. And one minister, I can tell his name, he is part of the, I think the BMC, that Mr. Sanjeev Rawat called and said that somebody has told to remove the eye. What will you do, doctor? I said, you send the patient, let us see. So the hospital refused to discharge him, saying that we have advised enucleation and you are going, so go against medical advice. I told the patient, take against medical advice. You can see I am doing a meticulous repair. I spent 3 hours repairing. And I remember my friend, senior man, late Klaus Hyman. That was the first talk I attended in '92, the second International Society. And there are post-operative complications for vitreous surgery, which I list it out because injury also can produce problem. And then post-vitrectomy also can produce problem. So this is a 40-year male with a history of assault by 8 people. He was a taxi driver. I don't know why he picked up a fight. And he was injured with a bamboo stick. And he had a nasal bleed, supraorbital laceration, for which primary suturing was done only on the lid. And then the patient was told, you have to remove the eye. And then he went to one hospital to another hospital. Then finally taxi driver told, he was a taxi driver. The taxi driver told, Arey, why are you going to hospital? I know one hospital, come to Aditya Jyot, they will do something. So he came, he had no light perception, lid ecchymosis like this, conjunctival congestion. I got a CT scan done, and this is what the CT scan, I did a diagrammatic. You see a distorted globe with a markedly propped optic eye with 10 to 15 millimeter, and then vitreous bleed. B scan showed dense vitreous hemorrhage, large scleral tear, posterior dislocation of the lens, and then he was advised evisceration. And then when he came, the dilemma for the patient, family and me, whether to eviscerate or reconstruct. So as I told, I wanted to reconstruct. So I did that. It took 3.5 hours to open the eye and go to find out this. It looks like a small scleral rupture, but it was parallel to the limbus. But the rupture was here, and the eye was swollen. I couldn't open the lid, and I didn't have time to give him steroid and reduce the swelling. And there's no way to reduce the swelling. So you have to physically pull, and did this. And this is what I did. And you can see exposing the wound. So it took 3 hours to go to this area, then identify. It looks like a small tear, but a very bad. So 15 days after surgery, what next? So I planned for a surgery, and this is what I did. I made thanks to Dr. Blumenthal. He was my good friend. And he gave me the idea of using the AC maintainer for cataract surgery. Even though I'm a retina surgeon, I did the first phaco workshop in 91 with Abhay Vasavada, Keki Mehta, and Inderjit Singh from Australia. And then 2001, I did a small incision cataract surgery in my foundation in Shanmugananda Hospital. That's why I learned to use the AC maintainer. And I started using AC maintainer, all my trauma patients, because you don't know where is the port to put. And some patients I do 3-port even through the AC antechamber. So here you can see I'm clearing the vitreous hemorrhage in the methodically going deeper, clearing, and then you can see the dislocated lens being removed, and you can see subretinal hemorrhage, suprachoroidal hemorrhage, and I think till the dean comes I'm going to talk here. Well, how many minutes you gave me here? Kitna minute? Huh? 30 minutes ho gaya. Very good. But where is dean and Naina madam? Okay, till the time dean comes I'm going to talk. Sujata madam, okay, no? Okay. So you can see under the PFCL, I drained the suprachoroidal hemorrhage externally, drained the subretinal bleeding, and then doing a 360-degree laser. And then finally using the silicone oil. Now you can see I'm making sure I'm clearing the anterior chamber so that there is no peripheral anterior synechia. And you can see the eye is filled with the PFCL, and there is a dusty vitreous hemorrhage over the PFCL. So I do a PFCL air exchange and air oil exchange and leave the eye. So you can see the corneal folds there. Madam, Dean is there? Whenever he comes, immediately I'm stopped. Yeah. Whenever he comes, we'll start the inauguration. So this was the conclusion. Kept the anterior chamber with the air, and then had the silicone oil in the back. So the idea is I want the silicone oil only to be behind the iris. And this is a 76-year-old male in the Ganga. This guy didn't want to disturb his wife, and his son was the principal secretary of government of Maharashtra. And then he was in Lucknow. He didn't want to disturb his wife, so he didn't put the lights on. He went in the dark to the toilet, and something was hanging, and I went through and through. And then initial repair was done in Lucknow. And next day he came, and then this was the picture. Anyway, I think the video is not here. Okay, so the video is not here. Maybe when somewhere it will be there. So this was the picture where he had when I was doing vitrectomy, expulsive happened. So as soon as I came out, the chief secretary told we should call the professor of ophthalmology in JJ. That time it was Dr. Lahane. And I called Lahane and told, expulsive happened, I managed. He says, how the hell expulsive hemorrhage? I said, the expulsive hemorrhage does not know the dean or JJ hospital is there and the expel should not happen. It happened. I said, I managed. And then after that, this was the picture. Macular hole was there. I did a laser around macular hole, retina and retina attached. And that is Mr. Manu Srivastav. He's retired now. And madam's husband is an IAS officer. And then this is another eye where a post-cataract, the patient had a trauma, and you can see the cataract wound, and some part of the lens matter was like this. And then I do through the, this is what I said. I use the AC maintainer, I go through the AC, remove the remnant of the cataract, and then here you see subretinal hemorrhage, vitreous hemorrhage. So I clear the vitreous hemorrhage and then use the, you can see there's no PVD. So it's a challenge. That's what I was there in, even in Kashmir. So trauma, that's why somehow 90% of my work is trauma. Now I'm using perfluorocarbon liquid and then reagent and forming the chamber with the air, and then using the PFCl oil exchange, and under oil I do the laser. And this was the picture with the disc temporal pallor and retina attached with a suprachoroidal hemorrhage. Patient had 624, but I think we didn't remove the oil because the other eye also she lost with a traumatic expulsive hemorrhage some 20 years before. And this is a 34-year-old woman presented with axial injury by a toy gun which was used to scare away the langurs in Agra. And you can see I did, so we can now put sutureless transscleral through so many ports. Sometimes I use 5, 6, 7, 8 also. You can see that was the pellet which went through and through. You can see the bare sclera in the center, total retinal detachment, subretinal hemorrhage, and then so I repair the retina. You can see I did an endodrainage, and you can see the under air, the retina is beautifully attached, and the injury is next to the optic nerve. Oh yes, sir has come. Welcome, sir. Thank you very much, and I think I'll conclude my talk by showing this complicated case. So whatever bad happens, my suggestion is please repair the eye as though the eye will be seen. Thank you very much. Welcome, sir. Dr. Naina. Where is Naina? You can take over, no? Come, Neeta.
म्यूजिक बंद कर Good afternoon all. Thank you so much for taking time and attending the CME. I would request Dr. Uday Tekchandani to please come on the stage and welcome our chief guest for the day. Handing over to Dr. Uday.
Thank you, Neeta, and thank you for giving me the opportunity to welcome Sir, Dr. Sudhi Medkar, Sir, Dean of Nair Hospital. Sir has a very lovely history in the medical career. He did his MBBS from GS Medical College in 1993. Following which, Sir completed his MD Dermatology from the same institute, and he was first in the said subject. Following completing his dermatology, Sir joined the state government services in 97 and initially served in GMC Dhule. Subsequent to that, Sir was the professor and head of GMC Aurangabad for 11 years. Sir has started the first advanced phototherapy unit for GT hospitals under JJ Group of Hospitals. Sir has a special interest in dermatosurgery and cosmetology and clinical research and softwares in healthcare system. Apart from that, Sir has published more than 12 articles in peer-reviewed journals. So thank you so much, Sir, for removing time and joining us today. And I'd like to hand the mic back over to Neeta to take over the inauguration. Thank you.
Thank you, sir. Sir, I would request Dr. Sudhir Medkar, our chief guest, to please come on the stage. I'll request Dr. Gangadhar, Dr. Uday, Dr. Smith, yeah, Dr. Naina, Dr. Sujata. No one is here. Dr. Natarajan, Dr. Karishma, thank you so much, all the doctors. I would thank all the attendees also who have made an attempt to come today and give their time for the study. We will soon be starting with our lamp lighting ceremony, as Professor Dr. Natarajan has given us an opportunity to have a insight and a knowledge about this trauma cases. Sir has been briefed us that what actually the trauma means and what do we have to do whenever any person comes into trauma. It is an insightful session, I would say. Although the session is not come to an end, we will still be continuing it after this short inauguration program. Would not take much of the time and will request everyone around here to have a lamp lighting session and then with the rest of the program to be started. So requesting everyone to please come near the lamp so that we can start with the program. Thank you so much, everyone. With this lamp lighting, I would say that as we have lit this lamp, let everyone's eyes be bright enough so that we don't come across with any of our trauma in rest of our life, I would say. I would request Professor Dr. S.N. Natarajan to please come and have throw some insight on this trauma session. So requesting sir to please have a few words on this session.
Respected Dean sir and professors, teachers and students, thanks for allowing us to do this CME under Maharashtra Ophthalmological Society at Nair Medical College. Thanks to Professor Naina for arranging everything. I think my team worked, but under the leadership of Dr. Naina. The idea is Dr. Gangadhar Sundar and me, we started the Asia-Pacific Ophthalmic Trauma Society. We discussed in 2007 and we started in 2011. and we are now 13 years old. And that time, Dr. Gangadhar said, ocular trauma was the term that time. Oculus means eyeball, and he said he's an oculoplastic surgeon, and they have been excluded in trauma, where trauma affects the eyeball and the structures around. So we are the first one to coin ophthalmic trauma, and now thanks to Ganga, we did a meeting 4 years back in an American academy, and they have started American Society of Ophthalmic Trauma, ASOT, and still International Society of Ocular Trauma and Ocular Trauma Society of India have to change. And I think the change means, as Gandhiji said, we have to be the change, so we are doing that. The idea of the symposium CME is for all the beginners in ophthalmology, including postgraduates, and who have completed postgrad just now, to do a best repair possible, primary, and sent to a referral hospital. I think I saw when I entered, the first department is trauma, which is generally for the entire body and not for the eye. So my request to the Dean, sir, we can have a separate board for the ophthalmic trauma, because they already have a duty doctors available. But generally when they think trauma and accident means only body. And during that time, when the patient is in coma following a road traffic accident, the eye is the most neglected organ. And I always tell, any trauma that in a hospital like Nair, San, JJ, they should call the ophthalmologist on duty to examine the eye, even though the patient is under coma. Because I have seen patients, after 1 month they will come, they'll have no perception of light because of optic atrophy or whatever. So best is when a bodily trauma or face trauma happens, and Dr. Gangadhar works with the facial-maxillary surgeons and craniofacial surgeons and with ophthalmology in NUH. So the idea is, don't give up. When they are operating on the brain, somebody can operate on the eye also, and we have technology in all the municipal medical colleges. I know that, and I am a emeritus professor in Sion Medical College, thanks to BMC commissioner who has appointed me, thanks to Dr. Chaya Shinde. So my dream is to come and teach all the students, because whatever knowledge I have, I want to give, and I know when I give, I get more. Thank you.
Thank you so much, sir. Sir, I would also request you to please honor our chairman for the day, chief guest for the day. I request Dr. Smith to please honor Dr. Naina Poddar, who is a gold medalist for FACO, and her special interest is pediatric ophthalmology. I request Dr. Jaideep to please come on the stage and welcome and honor Dr. Sujata.
Dr. Sujata is professor and head of JJ Group of Hospitals, and we are really happy to have her here amongst us.
And Dr. Sujata has agreed to do a big CME with our foundation as a part of 180th year of JJ Medical College.
I request Dr. Uday to please honor Dr. Karishma Wadia, who is the Medical Director and Chief Surgeon at Jehan Eye Clinic.
And she's
representing
also
Bombay Ophthalmology Association.
secretary,
And-
dynamic secretary.
And replacing the president today.
Yes, yes. Very dynamic.
Thanks to Maharashtra Ophthalmic Society and Bombay Ophthalmology Association for allowing us to do the CME to continue the education, because that's what is my dream of coming from Chennai to Mumbai. And so happened in '88 I did a pharmacology conference here, sir. Sir, in 1988 I did a I forgot, a pharmacology conference, and one more I did a conference in Nair Medical College. Suddenly I remember that.
I request Dr. Naina to please honor our guest, Dr. Gangadhar Sundar, who is a senior consultant in Department of Ophthalmology for National University Hospital, also an assistant professor for Department of Ophthalmology in Young Lolin School Medicine at Singapore.
And he's also one of the pioneers in doing thyroid ophthalmopathy surgeries, which very few surgeons in the world do. And I happened to see his patient in Singapore, I forgot the name of the place. He operated him and he welcomed us. And me and him are same alumni, sir, from Chennai.
Thank you so much. With this, I would like to invite Dr. Sudhir Medkar in case if he could speak on few words about this session.
Good afternoon, everybody. Dr. Sujata Chahande, Professor, Head of Department of Grand Government Medical College. Dr. Karishma Wadia, the Honorable Secretary of Bombay Ophthalmic Society. Dr. Natarajan, and the esteemed guest speaker, Dr. Gangadhar, and all esteemed guest speaker, Dr. Chaya Shinde, Head of Department of LTMC, Dr. Twinkle Choksi, Dr. Gharat, and all my esteemed colleagues and esteemed surgeons of this Mumbai. It is my first experience, and I would say I like to express my immense pleasure to inaugurate this symposium. 2 days back, I think 2 or 3 days back, we have an eye donation social campaign. And I said to the public how much eye is an important organ. And impairment of eye is like an impairment of its quality of life. And looking at this, not only at the personal level, the government also understands how much eye disease give an important aspect in a citizen's life. So they devised one program in 1976, which is called as National Control or National Program for Control of Blindness and Visual Impairment. I'm a dermatologist, but my knowledge may be some limited. To my best knowledge, in this country, the important diseases which can cause blindness are cataract, glaucoma, diabetic retinopathy, age-related macular degeneration, and corneal opacities. But this segment, a trauma, which really requires some attention. Just now, I think the esteemed international speaker told me that trauma is really neglected subject or neglected area. Trauma, how much grievous injury not is only on the organ, but it is life. Look at that. And you are a true healers, I would say. Okay, it will give a very important aspect in terms of his quality of life, not only for the citizens, for this country also, because you give a very productive life to him, then the productive lives lead to healthy nations also. So it is required to have such an area, to have such a special attention, or we can say innovative attention, or I would like to say, okay, in a affordable and quality health care. In 76, this program was devised. To my best knowledge, in 1983, government has published the data, okay, how much prevalence of the blindness is there. The prevalence was about 1.4. And in 2019, against said the data, it's only the 0.39%. And 1976, when this program was devised, the target was 0.3%. So ultimately, we are closer to that, about the prevention of blindness. But trauma is very important. Trauma really requires something, innovative aspect, a policymaker has to take, all stakeholders to do, or all your clinician has to take. Our Nair is very, very important. We'll have an immense pleasure, or I think we will have a proactive step in this segment, not only to take a lectures, but have a quality healthcare, which is important to community. Our target is only the poor and needy patients are there. A poor and needy patient should get a quality healthcare. And we are bound by the very alert rights and responsibilities to give a quality care by the innovative instruments and the well-trained and experienced surgeons or the teachers, I would like to say. Young generations, because this country of youngs are there, I think. You remember, in the entire world, 60% are young people in this Indias are there. So I expect from there that these young surgeons, ophthalmic surgeons, can devise a new technologies, new methodologies, or new instruments, which will really cater this poor needy of this country in terms of I have two objectives, affordable and evidence-based quality healthcare. And in that aspect, let us, we have a sincere and bona fide pledge to cultivate and cherish the knowledge which will benefit the all patients which have ophthalmic disability. So thank you very much. Jai Hind, Jai Maharashtra.
Thank you, sir. And actually, whatever the whole meeting is being watched on live by YouTube. So thanks for your words for the proactive status for ophthalmic trauma.
Thank you, sir. I will now like to request and call Dr. Dharmesh and Dr. Yash Parmar for the certificate session and the photography session, please. Dr. Dharmesh. Requesting Dr. SN sir to please hand over the certificate to the speakers of session 2. Dr. Dharmesh. Dr. Yash. Yes, yes. Yeah. Yeah. So we are done with the certificate distribution for session 2. We'll have a small photo session over the stage, and with constraint to sir's timing and due respect to his availability and time, I thank sir for making it possible and coming here for his and allowing us to speak to him. Thank you so much. We'll continue with the photo session and then we could wrap up this session, sir. Thank you so much. Yeah. And the lunch will be served very soon. So once the photo session is done, we all can proceed for lunch.
Hello. 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 हेलो कोई आया नहीं क्या Hello everyone. Can I get everyone's attention please? Hello everyone. I would like to start the session 3. I would like to welcome our chairman for session 3, Dr. Sunil Morekar sir. He is coming. Then our co-chairman, Dr. Ashwini Karansgaonkar ma'am. And moderator for the session, Dr. Purva Valvekar Date ma'am. And co-moderator for the session, Dr. Uday Tekchandani sir. There is a kind of reshuffling in the session due to some inconveniences. We'll let you know during the session when going on. Sunil sir. Sunil sir. We can wait for a few minutes for Sunil sir to arrive. Yes, okay. So I like to invite Dr. Uday Tekchandani sir for his talk on aflibercept in ARMD.
So good afternoon, everyone. Welcome back to the post-lunch session, which is not a siesta. So just to take this session forward, we're going to have a small discussion about anti-VEGFs and ARMD. And why are we having this session in this trauma symposium? As the talk goes on, you all will realize. So there are several molecular factors which determine how a drug interacts with the body, starting with the binding affinity, its elimination half-life, potency, clinical targets, and its molar dose. So let's go one by one. Let's start with the binding affinity. So the binding affinity determines how strongly a drug interacts with its target. So as we know, all our anti-VEGF agents have a binding affinity for the VEGF receptor. Now, of the 3 available molecules whose data is available, ranibizumab has the highest dissociation constant of 21.8, followed by brolucizumab and aflibercept being the least of less than 1. So it's actually been found to have statistically a much higher VEGF binding affinity than brolucizumab and ranibizumab in a head-to-head study. Coming to the potency. So the potency determines the required concentration of a drug that is needed to provide a defined effect. And as we know from the dosage given for each drug, we know that ranibizumab is actually the highest dose and aflibercept is the lowest. So ranibizumab has a IC50 of 10.8 versus aflibercept being a 2.4. So this not only means that it's significantly much more potent than brolucizumab and ranibizumab in vitro, but it also has less systemic absorption, and it also has lesser systemic side effects like nephrotoxicity, etc., which has been seen in larger molecules like ranibizumab and bevacizumab. So coming to the half-life. The half-life obviously provides insight into the drug concentration in the body over time. And available data shows that aflibercept has the largest longest half-life. So it stays longer, it acts longer, so the inter-injection interval is also much longer as compared to the other available injections. And while it comes to the binding target, both brolucizumab and ranibizumab have a single target of VEGF-A. And while faricimab is a new molecule working at VEGF-A and angiotensin II, aflibercept works against VEGF-A, placental growth factor, VEGF-B, and galectin-1. So having multiple targets makes it much more effective. So as we know, there are two receptors, the VEGF-R1 and the VEGF receptor 2. The VEGF-A binds to VEGF receptor 2, and it's placental growth factor and VEGF-B, which acts on VEGF receptor 1. So while most anti-VEGF molecules work only on VEGF-A, aflibercept has the added advantage of working on VEGF-B and placental growth factor and effectively reducing neovascularization as well as retinal edema. So aflibercept targets both VEGF-A, VEGF-B, and placental growth factor, reduces inflammation, neovascularization, vascular leakage, and edema, thereby making it more effective in both neovascular diseases like neovascular AMD, proliferative diabetic retinopathy, as well as against diabetic macular edema, branch retinal vein occlusion, etc. So which is why even the protocols which came up with the DRCR network looking at anti-VEGFs versus laser in proliferative diabetic retinopathy targeted predominantly aflibercept. So aflibercept significantly decreases both the intraocular VEGF and placental growth factor levels from a baseline to 2 months in patients with DME. So as we know that in patients with diabetic macular edema, the VEGF levels are about 61 times higher and the placental growth factor levels are 19 times higher than normal population. So the dual action that aflibercept has is effective in bringing the edema down faster and better in such patients. So why are we discussing this in a trauma symposium? Because while anti-VEGFs are predominantly used in wet AMD and in diabetic macular edema, one very important cause of choroidal neovascular membranes are actually choroidal ruptures, which are a very common complication following blunt trauma. The counter-coup mechanism of the injury causes these linear peripapillary lesions, which you can be seen very clearly on the OCT as well, where you can see this choroidal rupture. Now these lesions are seen in up to 90% patients with macular changes following blunt trauma, and 16% of them actually develop choroidal neovascular membrane initially within the first year. So when you see a patient with a blunt trauma and you just see this choroidal scar, don't send the patient home just on an SOS basis. It's very important to explain to them what is metamorphopsia, what is home AMSLA monitoring. So if they ever discover any symptoms, they can come in earlier, and if they develop a choroidal neovascular membrane, these membranes can be tackled with simple anti-VEGF injections. And as compared to your routine garden variety cases like neovascular AMD and diabetic macular edema, where you need to keep loading them, in neovascular AMD with 3 injections, in diabetic macular edema, if you're giving ranibizumab or bevacizumab, you have to give 3. If aflibercept, it's 5 loading injections. In other causes of neovascular membranes like choroidal ruptures, angioid streaks, myopic CNVMs, idiopathic CNVMs, uveitic inflammatory CNVMs, usually you give 1 injection and then you keep them on a pro rata or a SOS basis moving forward. So I'm coming to a representative case. It's not exactly a choroidal rupture, but it's the same pathogenesis. So this was a male, 47-year-old male who just came to us about 6 weeks back with a central scotoma since 2 days. And had a sudden drop in vision from 6/6 to 6/24. So this was his fundus photo. So this patient was actually referred to me as a case of a suspected BRVO. So you can very clearly see that there is this subretinal bleed here. But actually the remarkable findings are not here, but it's everywhere else. So if you can actually see these nasal lesions here and this peripapillary lesion, this is a very classical case of an angioid streak. So this patient has a subretinal bleed secondary to angioid streaks. So we've referred him for a rheumatological evaluation to rule out the usual PEPSI acronym for angioid streaks, which is Paget's disease, Ehlers-Danlos, pseudoxanthoma elasticum, sickle cell, and idiopathic lesions. We did an OCT through this lesion, and lo and behold, we can see the subretinal as well as the sub-RPE bleed, and the OCT angio showed a very beautiful network which showed up, and there was also flow present on the flow map. So every patient with a subretinal bleed in angioid streaks, in trauma, in a myope, does not necessarily mean that they have a choroidal neovascular membrane. Sometimes the lacquer crack can just give way and this patient can develop a bleed, and these bleeds will respond spontaneously. But OCT angio actually helps us localize these networks, document them, and give us a higher indication to give them an intervention. So this patient came into us, we gave him an ILIA the very next day, and lo and behold, 1 month later, he was 6/6. His bleeding resolved almost completely. You can see that the Shrem is also gone, and this patient is absolutely fine. So I don't plan on giving him any injections right now. He will be on a monthly follow-up. And the reason I chose aflibercept for this patient is because we know that the inter-injection interval is much better, and it works beautifully well for patients with post-traumatic and other causes of CNVM. So just to summarize, with aflibercept 2 milligram already targeting most ligands, key ligands of the master regulation of the VEGF pathway, there may be limited potential for improvements in functional outcomes of other patients with new molecules coming in. While there is a lot of international data available of other molecules which are targeting multiple pathways, Indian data is yet to be proven. So aflibercept for me has always been the way to go for patients with especially choroidal neovascular membranes, and it's given me beautiful outcomes. So thank you for patient hearing.
Now I would like to call Dr. Jaideep for his talk. He has done his DNB from Aditya Jyot and Retina Fellowship from Shankar Netralaya. Currently he is working in Ramakrishna Hospital.
Good afternoon, everyone. So I'll be speaking to you about the timing of vitrectomy in patients with ocular trauma. So this is a very important aspect of management of posterior segment ocular trauma. So I will not be actually showing you any fancy videos or cases, because this is purely regarding the timing, correct timing of vitrectomy for a patient of ocular trauma whenever it is indicated. So as we know, ocular trauma can vary from mild injuries, which are only regional, to sight-threatening ocular trauma, which may require prompt surgical intervention. One of the most common causes of unilateral blindness is trauma, and it accounts for bilateral blindness for more than 1 million people around the world. So blindness is generally caused by posterior segment trauma, most commonly because with the advancements in management of ocular injuries, the anterior segment trauma is quite well managed. So it's the posterior segment which actually leads to blindness when not treated appropriately. So ocular trauma surgical management, when it comes to that, fortunately with the introduction of the development of advanced vitrectomy techniques and surgical reconstruction, it has substantially improved the prognosis of these patients. However, unfortunately, there are some entities where you develop what we call traumatic proliferative vitreoretinopathy, or TPVR, in the posterior segment, which is still a crucial limiting factor for the rehabilitation of these severely injured eyes. Ocular trauma surgical management, involves primary step called vitrectomy, because this is something which is a basic surgical procedure when you want to approach posterior segment traumatic injuries. So with the advancement in techniques, we have 23, 25 gauge and now 27 gauge minimally invasive vitrectomy techniques, and has brought light to the treatment of severe mechanical ocular trauma, greatly reducing the rate of eyeball enucleation. So vitrectomy could restore certain visual acuity by restoring the transparency of the refractive media, repositioning the retina, and saving the injured eye. The optimal timing of vitrectomy still is something debatable, and we need to really find the right golden spot where we can intervene in these eyes. So there are patients who require immediate vitrectomy, like patients with traumatic endophthalmitis and intraocular foreign bodies with high risk of infection. Other than that, severe mechanical trauma, the ideal time for intervening with vitrectomy is between the 8 and 14 days. The second best is somewhere between 1 and 7 days. Anything about 2 weeks is found to have worse prognosis. So what are the advantages of delaying a vitreoretinal surgery in cases of posterior segment trauma? Leaking wounds, anterior segment wounds may cause a hypotony during the surgery and may require again suturing or closure. before we proceed. Wound healing, if it is appropriate, can give strength to the wound, and VR surgery is much more easier with a non-leaking wound. So if you delay the surgery after primary repair, you may have a watertight chamber or the posterior segment to operate upon. Another thing is a spontaneous PVD, which happens after 10 to 14 days. So that also aids in the easy vitrectomy, because PVD induction is a very crucial step when you are managing posterior segment injuries. Uveal congestion also decreases after a while. So, and after we give generally topical and oral steroids. So that also reduces the risk of intraocular hemorrhage when we are going inside after, say, a week or two. So what are the differences between a single stage versus two-stage surgery in patients with severe injury? An open globe injury should be repaired within 24 hours. That's the thumb rule, we all know, because of the risk of traumatic endophthalmitis. And IOFB ideally has to be removed during a primary surgery. However, if you don't have the means or the surgical expertise to do so, then a primary repair and followed by a referral to a vitreoretinal surgeon is the ideal way to go. The goal of the initial surgery is to have watertight closure of wounds in a manner that will allow you to complete the secondary vitrectomy if necessary. So many of the eye injuries require secondary repair, and along with the vitrectomy, we know that, to avoid posterior segment complications, long-term complications. So indications for this secondary vitrectomy includes persistent media opacity, progressive vitreoretinal traction, retinal detachments, endophthalmitis, retained intraocular foreign bodies, and so on and so forth. So favorable outcomes have been associated with recovery of light perception after initial closure of the secondary vitrectomy in 1 or 2 weeks. So surgery within these golden period of 7 to 14 days allows adequate time for the healing of primary wounds, decreases the chance of encountering significant membrane proliferation on the retina, and also during the secondary surgery aid in the easy dissection of these membranes. So in a single stage versus two-stage surgery, if we compare, in the first stage, attempting a single stage VR surgery in a post-traumatic cases can lead to a high risk of intraocular complications, intraoperative complications. A two-stage surgery, when you do, you have a better opportunity to, you have already closed all the wounds, and there is PVD induction, the eye is less congested, the media clarity is better. So PVD gets induced. So all these are in favor of two-stage surgeries. Also, if you have choroidal detachment associated, that also can be reduced significantly, and that can lead to less intraocular or intraoperative complications. So that is the advantage of doing a two-step surgery. However, in cases of endophthalmitis and IOFB post-trauma, you need to go in immediately. So what is new here is we have this vitrectomy timing individualization system for ocular trauma. So that is VTISOT. So again, I think Dr. Natarajan also emphasized on individualized approach for managing ocular trauma, especially the posterior segment trauma, and the vitrectomy timing in this is very important to individualize according to the case. A timing of vitrectomy for ocular trauma is mainly based on the PVR formation and the risk of PVR formation. So individualized adjustments are based on the score for the PVR and vitrectomy associated characteristics in these injured eyes. The following principles we can apply when there is a non-endophthalmitis or a non-IOFB related ocular trauma involving the posterior segment. So the 4 main TPVR risks here are zone 3 injury, zone 3R laceration, massive vitreous hemorrhage, any retinal disorder associated with the trauma. So these are the 4 main traumatic PVR risk factors. The high traumatic PVR risk case is some case where it includes 1 or more of the above 4 main risk factors. And a low risk case is where none of the above are present, none of the 4 above are present. In high risk TPVR cases, you need to operate within 2 to 4 days of the injury. You can't wait for those 8 to 14 days, because by that time you may have significant PVR already developed and the retina contracted to an extent where you won't be able to salvage the retina or the vision. In low TPVR cases, you can go for the rule where you go into the second week golden period, where it is between the 8 and 14 days after the injury. So adjust the surgical timing by characteristics of the injured eye. Here you see for the corneal edema. If the corneal edema is, you have cleared cornea enough, then you can go in. Otherwise, you may need an endoscopic vitrectomy or a temporary keratoprosthesis. Now, both of these are very, very difficult to find or master, and generally are available in institutes, and many of us may not have access to them, or you will need a cornea surgeon along with it. Suprachoroidal hemorrhage is something which we need to assess before we go into these eyes. So you may need to delay your surgery so that the suprachoroidal hemorrhage has liquefied sufficiently enough where it can be drained. Unsutured wounds, which are too posterior to reach, generally require some time or delay to heal. So sometimes you may not be able to suture all the scleral tears. It may extend too posterior, and you may want to wait for some time for it to heal before you want to go in with a vitrectomy. Otherwise, it might open up intraoperatively. Lens injury is something which you need to consider before you plan this vitrectomy as well. Secondary glaucoma is also something which you need to be aware about. Vitreous hemorrhage, which is there, may need to be removed, because the longer you keep a traumatic vitreous hemorrhage, the risk of retinal detachment progressively goes on increasing. Lower IOP, that is a hypotony, also indicates an early vitrectomy, because there is a high risk of the eye going into phthisis, especially after severe traumas. These eyes go into very early phthisis bulbi, so you need to intervene early if you have a very low IOP. Prognosis-wise, serious eye injury is primarily determined by the initial injury, the quality and timing of surgical intervention, and the biological reaction of the body, that is the PVR changes, inflammation. Among these factors, there is obviously no way of reducing the damage done by the initial injury, because that is a one-time event and you can't reverse that. So what you can do is you can select the appropriate timing for intervening, like that is vitrectomy at the correct timing, and it not only reduces the incidence of TPVR but also significantly improves the efficacy and prognosis. An individual plan must be fashioned in each case based on the specifics of the injured eye, and the patient, the capability, experience, and expertise of the surgeon is very important when it comes to managing these cases. So time isn't the main thing, it's the only thing. That's what Miles Davis says. Thank you.
Thank you so much, thank you. He just does bring to the table a very important point. So by and large, most of us follow a certain set of rules and all. But the era has come where we talk about tailored treatment for each patient. So that is a take-home message which I think even the timing is to be tailored, and we need not say that do this early or do that late, and always I do late, always I do early. There is nothing called always in research and in progress. So thanks a lot for putting that across so nicely. Thank you so much.
Thank you.
Thank you, Dr. Jaideep, for your lovely talk. I'd now like to invite Dr. Purva Valvekar Date for her talk on pole-to-pole trauma. Ma'am is a double gold medalist in both her MBBS and her DNB, and she has done her VR fellowship with Aditya Jyot Eye Hospital. Following that, she has done multiple fellowships in Hamburg and Italy, and is currently an assistant professor in the VR services department of JJ Group of Hospitals.
Thank you so much. Very good afternoon to everyone, post-lunch session. So I'll be keeping my presentation very crisp with the videos. And I thank MOS and Aditya Jyot Hospital, Dr. Natarajan sir, for giving me the platform. It's not moving. I have no financial disclosures. Coming to the introduction, ocular trauma is a major cause of visual morbidity and the most common cause of unilateral blindness. Worldwide, every year, around 1.6 million people are getting blind from the ocular injuries. Pole-to-pole trauma involves anterior as well as posterior segment of the eye. Coming to the first case, he was a 43-year-old male. He had a history of blunt trauma with a ball 6 months ago. His vision was PL plus PR accurate. IOP was 13 mmHg. Anterior segment showed traumatic cataract, inferior pupillary defect with posterior synechia. B-scan showed vitreous hemorrhage and attached retina. Patient was posted for the right eye cataract extraction, vitrectomy with pupilloplasty and CMT flex secondary oil implantation under local anesthesia. Audio.
0 and 180 degrees were marked at the limbus, and 2 partial thickness scleral flaps were made. An SICS tunnel was made and the nucleus was delivered by viscoexpression. Pars plana vitrectomy was done and the vitreous hemorrhage was cleared.
So luckily
360-degree endolaser was done and suspicious areas of the retina were also lasered. Two sclerotomy sites were made 1.5 mm behind the limbus under the scleral flaps. The foldable hydrophilic CMT flex lens was then loaded into the injector. Using the Praniv and Nishi forceps, the T junction of the CMT flex was externalized onto the sclera under the scleral flaps. A fourth row pupilloplasty was done using a 9-0 straight blade polypropylene suture. Inferiorly, a defect in the iris tissue was also noted. Post-operatively on day 1, the vision was 660, which improved to 618 after 1 month of surgery.
Coming to the second case, a 37-year-old male, he had a history of trauma with a stone 2 months ago. His vision was finger counting close to face, PL plus and PR accurate. IOP was 12 mm of Hg. Anterior segment showed traumatic cataract with iridolalysis, which was extending from 12 o'clock to 5 o'clock. He had a VH and retina was on. Patient was posted for pars plana vitrectomy, lensectomy, iridolalysis repair with sewing machine technique, CMT flex implantation under local anesthesia.
A 270-degree conjunctival peritomy was done superiorly. 0 and 180 degrees were marked with a marker. 2 partial thickness scleral flaps were made with a crescent blade. A curvy linear incision was taken from 12 to 5 o'clock, 1.5 mm behind the limbus. A pars plana lensectomy was performed, and adhesions from the iris and the anterior capsule were freed. One end of the 9-0 polypropylene straight blade suture was inserted into a 26 number needle. This apparatus was passed through the iris and brought out of the incision. Similarly, this process was done at 3 points on the iris at the iridodialysis, and loops of the suture were externalized. The cut ends of the loops were then tied to each other, and the iridodialysis repair was complete by the sewing machine technique. The CMT flex IOL was then loaded and injected, and the T junction of the haptics were externalized carefully using the Praniv and Nishi forceps. Post-operatively, on day 1, the vision was finger counting 2 meters with a normal IOP of 10 millimeters of mercury, which improved to 612 at 1 month.
Coming to the third case, a 46-year-old male had an ocular trauma with a stone 5 months ago. History of corneoscleral tear repair extending from 6 o'clock to 10 o'clock was done 1 month back with a uveal tissue and lens prolapse. His BCVA was PL plus PR inaccurate. IOP was 9 mm of Hg. Anterior segment showed inferior limbal sutures extending from 6 o'clock to 9 o'clock with aniridia and aphakia. On B-scan, he had a dense VH with total RD. Patient was posted for right eye pars plana vitrectomy, membrane dissection, endolaser, silicone oil implantation with silicone oil retention sutures under LA.
A 3-port pars plana vitrectomy was done and the dense vitreous hemorrhage was cleared from the anterior and posterior chamber. Once the hemorrhage was cleared, an inferior RD with PVR changes and an ERM was also noted. The ILM was stained with brilliant blue dye and arcade to arcade ILM peeling was done. Two partial thickness scleral incisions were marked 2 mm behind the limbus. A 90 polypropylene straight blade needle was introduced through one incision and by the handshake technique was externalized 180 degrees apart from the other incision. This was repeated to form a rectangle and the ends of the sutures were then tied. Similarly, another oil retention suture was then passed from 10 to 5 o'clock. The conventional 3 and 9 o'clock site for the hashtag oil retention suture was avoided due to the pre-existing sclerocorneal tear. A nasal drainage retinotomy was done and subretinal fluid was drained from there. 360-degree endolaser was then performed. Fluid air exchange was done and laser was augmented. Silicone oil was injected until the meniscus reached the oil retention sutures anteriorly. Post-operatively on day 1, the vision was finger counting at half meter and the patient is still in our follow-up.
Coming to the discussion part, the concept of pole-to-pole trauma was introduced by Dr. Cesare Forlini. A single loss surgery performed by one surgeon is better than multiple partial surgeries done by a different specialist. A surgeon must be trained with a global approach and should have all-round the surgical skills. In an ideal procedure, surgical steps should be minimum, with the surgeon should obtain the best result with most economic and efficient strategy. Link with the eye bank must be established so that the corneal graft for the transplant can be provided quickly when needed. Coming to the conclusion, ocular trauma is most common under-recognized cause for the vision loss in the world. Trauma victim bears a large and potentially preventable burden. Strategies for prevention of ocular trauma require knowledge of mechanism of injury and targeting the resources towards the preventing such injuries. Close follow-up after inciting event can prevent sequelae of trauma. Use of eye protection is critical in preventing ocular injuries in a different fields of work. Thank you.
Thank you so much, Dr. Purva. It was an amazing set of videos and truly pole-to-pole trauma covered. So the next talk will be by Dr. Sunil Morikar, sir. Sir is an associate professor at MGM and is a visiting consultant at Leelavati, SL Raheja, Fortis, Hiranandani, Apollo and Reliance Hospital. If there are any hospitals left, please let sir know. I'm sure sir would go there as well. Over to you, sir.
Thank you so much. I'm going to slightly rush through the presentation because my whole intention here is to introduce some concepts to many of the youngsters that I see here who are probably going to end up following this up a little more better than what we are doing right now. And the whole idea is that...
Dr. Sunil, please take the mic closer to, yeah.
Is it audible now? Yeah. So there are some things that I'm going to do because you have to answer these questions in the exams. So what are the traditional indications for an optic canal decompression? So I'm going to straight an optic nerve injury and what is it that is said so far and what is it that you're going to do in the future. So the optic canal decompression is indicated if the visual acuity does not improve to 2400 or better despite 24 to 48 hours of steroid therapy. So that actually means that you're going to give IVMP, so you're going to give IV methylprednisolone. And the visual acuity is 2200 or better but deteriorates during or after completion of a steroid therapy. So this is the standard indication. But then came the crash study. And the crash study or the corticosteroid randomization after significant head injury, you have to understand that we then started going forward from a specialist who looks only at the eye to a specialist who looks at the eye, which comes as a whole body. So not just the car's headlight comes to you, the whole car comes to you. So you're not supposed to look only at the headlight, but you're supposed to look at the whole car. So the role of corticosteroids in the treatment of became more and more limited. And in select cases of traumatic, surgeons may opt to bypass the use of steroid and proceed to the optic canalicular decompression. Now, the reason this was done was because we saw some patients of head injury who had head injury in addition to the optic nerve injury had worsening after the steroid or had a potential of worsening after the steroid, and so you would not be able to give the steroid and directly go to this thing. So the use of corticosteroids would be judicious in patients who would not be judicious. You would probably do a surgery if it is diabetes or gastric ulcer or osteoporosis, something like that. There are multiple factors that you will look at. In addition, corticosteroid research said the crash study found higher risk of death in the steroid group. So the steroid group, there were a large number of deaths. So we said we will probably bypass steroid in select cases. Now this is a list of this thing. Anybody wants it, I can give you this list. This is a list of researches which is done on the use of steroid and how steroids will be useful. There are lots of them. But then there came a Cochrane study which started questioning steroids. So whenever you're doing something, it has to be evidence-based and that evidence has to be balanced. So there will be some papers which will say that steroid works, some papers say that steroid does not work. So you'll combine all those papers and do a meta-analysis. And you do a Cochrane review, it's a little different from a systemic review. Then there was a study which talked about surgery versus no surgery in optic neuropathy. And even there they questioned that there is a questionable role or there is no evidence that surgery may work. So there were two Cochrane studies which said that don't do anything. But then there came another recent systematic review which talked about harm being done if you do something. Whether you do a steroid or you do a surgery, you will end up causing harm, more with steroids, less likely with surgery. So the first principle of medical education is primum non nocere. First, to do no harm. So then what do we do? So would you, if you see me lying on the road with a knife in my heart, not remove the knife? You would say no, there is no evidence of anything that, or in fact there is an evidence that if I remove the knife from this fellow's carotid artery or from his heart and there is a probability of loss. Yes, there is a probability of worsening. Yes, there is a probability of harm if it is being removed by some layman. But if it comes to a hospital and somebody who's trained in doing it, he does it. So most of these researches which are written in literature are done at multiple centers, at various centers. We do not know the level of expertise of the people who are doing it. And so we come to the next step. We do what is called a systematic review versus meta-analysis. So the meta-analysis has got arms, box plots. So you see weight of a study versus weight of another study. So you look at what did they consider and what all is there. And now we are talking about rethinking medical evidence, and we go to absence of evidence does not mean evidence of absence. Now, just because there is no evidence of God, that there is no God is something that many of us would say. Just because I can't see air here, there is no air here, I don't see anything flapping here. So absence of evidence is not evidence of absence. We take that further, and then we start going to network meta-analysis. So we say corticosteroids versus nothing done, surgery versus nothing done. Now we do corticosteroid surgery, nothing done in multiple variables, and this is something that we were talking. And now Cochrane has gone onward to two approaches, what should be used, what approach should be used, on what is called as the grade process or what is called as the cinema, when indirect comparisons are built on pair-wise meta-analysis, right? So you do pair-wise meta-analysis. I will drop this further, and then look for bias in each of the studies and give weightage to the bias. Now when we do all that and look at possible modifiers, I do realize I'll come to the case that I'm talking about here. Network meta-analysis will form the way forward to studies. So there will be no just two studies, no randomized control trials. It will be network analysis, all right? And anybody who's interested in go on to Cochrane and do that study of how to do. And now even for IOL powers and other things, we are talking about Bayesian network analysis. So there are advances which are occurring even in statistics. So I'll come to multiple factors that come in. So there are multiple things that we have incorporated now when you look at an evaluation of a patient with optic neuropathy. You look at color vision, you look at other ways of measuring color, and you use artificial intelligence in the acquired color vision deficiency score. So what has happened, and you use predictive AI to figure out if this particular patient is going to do better with an intervention, whether it is a steroid or a surgery. And this is one of our patients in which the color abnormality changed after a steroid. It got better. Now what exactly do you do? And if you see here, can you see the arrow there? Yeah. So you are looking at the chip here. This is the optic nerve, and this is being done endoscopically. You can do it externally also. And you are pushing that chip away. You're pushing that chip away from the optic nerve. So if there is something within the optic nerve, it will continue. So it's like leaving a foreign body inside. So literature says that nothing will work. Can I leave a foreign body in Dr. Sunil Murikar's heart or brain? I will definitely not do so. And I will not leave it in the optic nerve also. So you have to evaluate, like Dr. Jaideep said, you have to evaluate each patient according to what is there. But will I remove it if there is a traumatic brain injury, or will I give a steroid where there is a brain injury? So what you do is you do imaging, and you do the DT MRIs. You look at prognostic imaging, you look at VEPs and look at the prognosis which is going to be there, the documentation in terms of OCT, and then you come to the newer tools, which is you're looking at ultrasonography. And in ultrasonography, you're looking at particularly the Doppler. Now, when you look at Doppler, you use a closed protocol. So I'm giving you words which I want you to go back home and read, and maybe contact me, and if you can't find something, we can discuss it further. The ultrasound factors which are associated with poor prognosis is the reduction of the peak systolic velocity, the end diastolic volume, and the average time mean velocity. When you see this, you do not want to operate, even if you think that this may do good, but you look at the Doppler factors. Now, we further looked at orbital auscultation. So many people said कि सुनील को तो stethoscope किधर रखना वो भी मालूम नहीं है. All right. So when we looked at that, we looked at the electronic stethoscope, and we look at the pre-op phonogram. So this is the kind of the phonogram. You get a noise there, as if Sunil Murikar is talking from very far away. And when you do the surgery and post-op, you see. All right. So that is an indication. This is an indication that you need a surgery, even when that is happening with a compression. Now, surgical correction, the reviews, there are many of them, and we now have started using AI in traumatic brain injury. So you have a traumatic brain injury and your visual loss might be because of an occipital lobe abnormality and not because of your optic nerve. So you use AI and the AI tools to put in the MRI into the AI, the optic nerve into the AI, the sonography Doppler image into the AI. And when we have been using that, we have been able to get predictive AI to tell us in 89% of the cases that this will work or this will not work. The Wolfram algorithm is a further refinement. You combine it with neuro interventions when the AI tells you this will not work unless you have neuro. And then there are times like this particular case in which you can see that there is hypoglobus. So there is no trauma, you cannot see a piece of bone inside, you cannot see a compression there. But this is a shearing injury. So the eyeball has been pulled down. It is a stretch injury. And you get those 3D images and do a segmentation and put it into AI, and you'll realize that this is a stretched nerve. And we have taken cartilage and we have put it there, and that is the result. When there are multiple, that is the result, your eyeball comes up and your optic neuropathy and your color and everything, VP and everything starts improving just by lifting the globe up. So AI now tells you, then you can use AI algorithms for multiple injuries. And AI now tells you, I'm done, sorry. So AI now tells you, so there is anybody who's interested in the use of this AI, this thing, we have won the national award for the AI in papilledema, in optic nerve schizotomies, whether they should be done or not should be done. I mean, I also train people to become editors, and we also do conduct a lot of training on how to review papers. So please go into all of these, and any doubts you have, the bonsai study, I have introduced certain words, the grade, the cinema. I mean, my whole purpose was to let you know that there is a lot of things happening. You will have a lot of people coming and telling you, mat karo, karo, nahi karo. Each patient is different. Some may have a brain injury, some may have an eye injury. You're supposed to put all of this into AI. It is humanly impossible for me, even after 30 years of doing optic nerve surgeries or treatment, to pick out one single factor like that stretch injury. In my case, I will add here something which is personal. I was diagnosed with a long QT. My QT interval in my ECG was 670. I was told to get a pacemaker put in by 5 or 6 different doctors from different hospitals. And I put my own ECG into AI. And surprisingly, AI tells me check for lead levels in your water supply. And I check for lead levels, and the lead levels are 10 times more. I change my pipelines and my long QT is back to normal. So this is the value of AI. It is just a car. It is a Ferrari. It cannot work without the driver. So don't get afraid that it will replace your jobs, but try to get the new things incorporated. You're all youngsters. I know that 10 years down the line, you will be teaching me this again. Thank you.
Thank you so much, sir, on putting light to AI. I think it was a very important term you used there, that the AI is a Ferrari and not a Tesla. So it's not a self-driven car, it is to be driven on your own. So use AI, but use AI with caution, and use your own sense and sensibility also. So next we have 2 recorded talks by Dr. Akshay Nair, who is an oculoplastic or ophthalmic plastic surgeon. He's a member of the Oculoplastic Society of India, American Society of Ophthalmic Plastic and Reconstructive Surgery, as well as a member of the American Academy of Ophthalmology. Unfortunately, Dr. Akshay could not be physically with us over here today, but he has 2 recorded talks, so we'll have a look at them.
And the invitation to speak today on the symposium on orbital and adnexal and ocular trauma. I'll be speaking on challenging scenarios when it comes to eyelid and adnexal trauma. I'm Akshay Nair. I'm an oculoplastic surgeon affiliated with the Agarwal's group of 5 hospitals in Mumbai. Some of the cases I'll be discussing are cases that I've encountered throughout my training at all these institutes, and therefore accordingly I'll be giving the credit to those images that I'll be sharing during this presentation. So the 3 primary complicated scenarios that I'll be talking about are dog bites, canalicular tears, and traumatic ptosis. dog bites are an absolute emergency. The first thing that we need to know is that how to assess the severity, to check the amount of tissues involved, whether it's just the eyelid or whether does it involve the globe or the orbital tissues, meaning the bones as well. Pediatric orbital fractures are fairly common in periocular dog bite injuries. Even though the globe may not itself be involved, by virtue of having avulsion injuries to the eyelids, there could be lag ophthalmos and exposure, which puts the globe integrity at risk. Remember that the eyelids and the lips are the most common site for lacerations due to the nature of the dog bites. Usually, dogs lunge towards the face and the upper canines go into the orbit or the upper eyelids, the lower eyelids, and the lower canines grasp the pouting lips that usually are projected outwards. As a result, we see avulsion of the lids and the lips as well. It is an emergency and we need to first give primary first aid, which is thorough wound toileting. Now, one particularly vulnerable group of patients who are at risk for dog bite related injuries are children. They have a 20-fold increase risk of facial dog bites as compared to the general population or the adult population. Primarily because they have a relatively larger head compared to their size of the body, and because they are shorter, they are more accessible to dogs, and they have slightly sluggish motor skills compared to adults. As a result, when they tend to respond to a dog lunging towards them, they are a little slow in that action, and as a result, they are more vulnerable. Oftentimes, they are more affectionate and willing to bring their face closer to the dog, even hugging them, which can be misinterpreted as a hostile behavior to which the dog would respond. Canalicular involvement is extremely common in dog bites. You can see this paper showed 66% of all patients had canalicular related injury. Also, we have pediatric fractures, which are commonly seen mainly because the bones in the children are relatively smaller and more amenable to fractures. If you look at ophthalmic manifestations of facial dog bites, canalicular injuries are most common, followed by some cases where corneal abrasions were also seen. Isolated globe rupture has also been reported in a child following a facial dog bite injury, whereas in this case, even though there was no orbital trauma, there was a globe rupture. So when we see a patient with a dog bite in the periocular area, obviously life-threatening morbidities would take precedence. So while cursorily you must assess the globe status, check if the patient is immunosuppressed or immunocompetent, and start systemic antibiotics. In the periocular area, a thorough wound toilet is the first thing that needs to be done. Now, it's important to, I'm going to project this question and I want you to come up with your answers in your mind, and then we'll see whether the answer is supported by literature or not. So you have a patient with a periocular dog bite injury. Would you clean the wound primarily and provide immunization as per protocol at presentation, and then plan a suturing later after the immunization is completed? Or would you plan early surgical intervention and suture the wound with concurrent immunization at the same time? So essentially the question is, we've always traditionally been taught dog bites are never to be sutured. So here we're talking about an eyelid dog bite. Would you suture primarily or would you wait? Now, if you were to look at literature, primary suturing of the wounds caused by dog bites really resulted in similar infection rate compared to non-suturing. But primary suturing had better cosmetic appearance, and the time of management appears to be critical as early treatment has resulted in lower infection rate. So you're going to have better cosmetic outcomes and better infection, or rather lower infection rates, the earlier you suture. So therefore, the first things that you need to do is adequate wound cleaning, which can be done with normal saline or with water, and betadine. Tetanus toxoid and rabies prophylaxis need to continue. And remember, immediately the wound must be reconstructed. You have to restore the anatomy and the function as early as you can. The eyelid tissues are extremely amenable to edema, and therefore approximation once edematous may not be as easy in the late phase as it is in the early phase. Immunoglobulin should be given. Remember, the immunoglobulin should be given in a different syringe as compared to the vaccination, as well as the site of immunoglobulin should be distant compared to the site of the vaccination. You do not want both to counteract each other. Coming back to the mode of injury on eyelids, avulsion injury is the most common, and usually you'll see a pedicle hanging. The marginal arcade tends to get disrupted, which is why you would see that there is at the tip of the flap that is hanging, there is darkening. Now remember, there's a 1:4 rule, which means as long as the width of the flap is, or rather, as long as the length of the avulsed flap is 4 times the width of the flap, the blood circulation is likely to remain intact. But longer the avulsed flap, which means if the ratio is more than 1:4, the tip is going to start getting avascular sooner rather than later. And therefore, early closure results in lesser necrosis and results in early restoration of function with no tissue loss. Now, this was another case where there is an avulsion and immediately it was sutured. You can see that it's not a clear-cut line. Part of the tarsus is hanging. The tip is devitalized. You've got the levator that can be seen. The septum is being disrupted, but early suturing done here gave extremely good results. Similarly, this was another periocular dog bite. This was a case that I had operated. Again, immediate surgery with restoration of the anatomy in terms of levator to levator, and then the orbicularis to orbicularis, and trying to make sure that you do not allow the tissue to become necrosed and devitalized. Very often this overlaps with canalicular tears, which is my next topic. When we talk about complicated scenarios, canalicular tears or canalicular trauma is extremely important because it's more than the anatomy, it's the function. Any untreated canalicular tear is going to lead to lifelong epiphora, which is a major quality of life-related issue. Remember, the canalicular injury is the most common form of traumatic injury to the lacrimal apparatus, and there are 3 principles which over decades have remained unchanged. 3 principles for repair of canalicular tear. Identify the 2 cut ends of the lid margin, identify the 2 cut ends of the canaliculi, anastomose them, and put in a splint or a stent in through the canaliculus such that the mucosa around the canaliculus heals, and therefore you have a patent canaliculus once it has healed. So basically you need to identify the ends, put a stent, and approximate them. The purpose of stent is, like I mentioned, to act as an internal splint. Now, why is it that the canaliculus is the most commonest part where you end up having an injury? And this is a landmark paper by Walk and Arbery where they did fresh cadavers were subjected to an avulsion injury on the lower lid. And because of the hollowness of the canaliculus in the canthal region, that remains the weakest point on the lower lid, and 9 out of 10 times the lid would get avulsed at a point where there is a canaliculus present, resulting in a canalicular injury. Early canalicular injuries look fresh. However, older canalicular injuries can be difficult to find. You must identify them. And in children especially, while dog bites remain one cause, children under 5 are extremely susceptible to something known as feeding-associated canalicular tear, FACT, which is extremely commonly seen in the Indian subcontinent, where women tend to wear this kind of a garment, a blouse on the upper body, and most of the children who end up suffering this form of trauma are under 2. This is usually because in this garment, the 2 ends of the clothing are hooked together with this kind of a metal hook, and it is unfastened and the child is breastfed. Usually this hook lies in the vicinity of the eyelid, and this hook can engage in the lower eyelid or the conjunctival cul-de-sac. Any movement of the head causes an avulsion injury, and the canaliculus, as we know, is the commonest point where the lid gives way. So this is something that has been not just anecdotally seen, it's been reported, it's been published. So the main ways that this can be treated is to repair with a canalicular tear. I'll quickly go through the video. The first step, of course, is to identify the proximal end of the punctum, and then to see the proximal end of the canalicular injury. So you can see that the probe is come out through the proximal end. Now you would have to identify the distal end. You can use epinephrine or adrenaline that causes mucosal vasoconstriction such that you see this calamari ring sign. That light colored ring is the mucosal ring of the canaliculus. You can irrigate through that and ask the patient if it is being done under local anesthesia, or put in a suction tube in the nose while you irrigate, such that you know that the fluid has come into the NLD or the nasolacrimal duct, confirming that the distal end through which you are inserting this cannula is indeed the canaliculus itself and not a false passage. The next thing is to put in a mini monoca or a stent. Here I like to cut it, or rather prime it, such that there is a small little angulated tip that allows for easy passage through the punctum and through the proximal and distal cut ends of the canaliculus. Now, it has a self-retaining hammerhead kind of configuration which stays in position once you snugly fit it in. Once this end of the mini monoca is in place, now the mini monoca needs to be passed through the distal cut end of the canaliculus, and there we can pass it. Once this is done, you pass it around so that the proximal tip of the mini monoca now is in the lacrimal sac. Once this is done, pericanalicular anastomosis, which is basically suturing of the orbicularis all around, needs to be done. Proximal sutures are adequate. You do not need to suture the conjunctiva posteriorly because those sutures would rub against the ocular surface. And then the wound is closed in layers with orbicularis and skin in a suture of your choice. Sometimes you may end up seeing a punctal granuloma which can appear like this, but in most cases the stent is removed at 4 to 6 weeks and irrigation is usually done to make sure that it is patent. This is how the self-retaining tip of the mini monoca appears when after surgery. Like I mentioned, it was first reported in 1991 in Indian pediatrics, and subsequently it's been reported multiple times. Now, one important thing is that the duration between trauma and surgery. So in most cases, up to 72 hours, you can safely operate with no major differences in outcome. And of course, early repair gives you better outcomes because you can identify the cut ends more easily. But beyond 72 hours, as I spoke earlier, mucosal edema sets in, especially around the canaliculus, the cut end of the canaliculus, which can also cause early scarring. So it's imperative that you operate these cases earlier. Pediatricians and of course obstetricians and ophthalmologists all need to be sensitized about the etiology, which is feeding related or feeding associated canalicular tear. And finally, the third complicated scenario that I'll speak briefly about is traumatic ptosis. Very often we have patients who've had some sort of trauma to the forehead, to the eyelid, a slap or a punch in the periocular area. The same day or a couple of days later, they end up with partial ptosis or total ptosis, which may be associated with other neurological deficits as well. So how do we go about dealing with these patients? The first thing is to get a thorough, detailed history. We need to get pictures before the trauma, immediately after the trauma, and also to ask the patient to show some earlier photos so you understand whether there was any pre-existing ptosis before the traumatic incident as well. Subsequently, and I know it sounds a little weird to ask a patient with trauma whether did they notice diurnal variation in the amount of drooping, but it's an important point and I'll come to that a little bit later. So when we talk about traumatic ptosis, there are multiple reasons why there could be traumatic ptosis. The first thing is traumatic myogenic ptosis, when there is direct injury to the levator muscle or the Mueller's muscle, as could happen in a dog bite where the levator muscle itself is partially or fully cut and then the lid droops or avulses and hangs down. The second is traumatic aponeurotic ptosis, where the muscle is not directly injured, but there is a dehiscence or thinning out of the levator aponeurosis on the tarsal insertion without any significant injury to the muscle belly itself. There can be traumatic ptosis where there is a tethering or stiffening that causes the eyelid to weigh down in a particular way. There's traumatic neurogenic ptosis, which is injury to the third nerve or the sympathetic fibers causing ptosis. And then there can be a traumatic or a mixed mechanism ptosis where there could be a little bit of a few of all of these. However, the most important and the most common form that is seen is transient traumatic ptosis, which is a form of neuropraxia, which is traumatic neurogenic ptosis. where there is direct or indirect injury to the branch of the third nerve that supplies the levator muscle. And this is most commonly reported after orbital trauma, facial trauma, even after medial wall decompressions or orbitotomies. And the reason for this is the disruption in impulse propagation along the nerve, along the axoplasm, with disruption of axonal flow. However, the important part and the good part for the patient is that this is reversible because it's a form of neuropraxia and not a permanent form of paralysis. So let's see a couple of cases. This is a patient who came with traumatic ptosis. She had a history of domestic violence. She came with blurred vision and some amount of ptosis. In fact, she had total ptosis. An MRI or an MRA was done elsewhere, which was normal, and she was diagnosed as a form of third nerve palsy and given oral steroids. And then she was referred to me. I assessed her. We stopped the oral steroids and asked her to come back in a couple of months. And here she's come back in April 2021 after 2 months. You can see that the ptosis is partially resolved, and a couple of more months later, she's come and the ptosis is nearly completely resolved. She didn't come back for a final follow-up, which only leads me to assume that the eyelid had completely recovered. So traumatic ptosis in this form is neuropraxia and completely reversible. Let's look at another case. This is a 73-year-old male, which underscores the importance of history taking. There is a history of head trauma. He was riding a bike and fell. The side of his head had hit the pavement. He had an undisplaced lateral wall fracture. The right eye had good vision. The left eye had slightly reduced vision. And he complained of diplopia and ptosis. Imaging was performed by a neurologist who diagnosed this as traumatic optic neuropathy, which has led to the vision reduction, and a traumatic third nerve palsy causing this. Now, this is his 9-gaze photos. You can see that there is ptosis, there is a kind of ocular motility pattern which is not consistent with anything that we would see. The only thing that we did was an ice test, where you place an ice pack over the eye or the eyelid for about 2 to 3 minutes. And after ice test, not only did the exotropia recover, the ptosis completely recovered. And this is the 9-gaze photograph after the ice test. So in this case, this was myasthenia, which was masquerading as a third nerve or a traumatic ptosis or a traumatic nerve injury, mainly because of the timing. So to summarize, when you deal with traumatic ptosis, remember, time is your friend. If you have a form of ptosis that you see that's abruptly associated with trauma or injury, wait for 6 months before going in and operating. However, if there is a trivial trauma which is not ideally should be giving you the kind of ptosis that you see, investigate for myasthenia and rule out thyroid eye disease. A lot of patients have speculum-associated mild ptosis following surgery. In these cases too, wait for 6 to 9 months before going in and operating. And in nowadays, these incidence is low, but a lot of these patients we used to see with posterior subtenons injection of steroids, where there used to be transient ptosis, and again, in those patients, we wait for 3 months. So to summarize, we've covered the 3 typically common complicated scenarios that we see in ocular adnexal trauma: dog bites, canalical tears, and traumatic ptosis. Thank you so much for your attention, and I'll summarize this. So when we ever come across these kind of cases where there is eyelid tear repair, eyelid trauma or avulsion or tears, do not forget the basics, which is the first thing before taking any suture is to identify the layers. Identify the skin, the orbicularis, and the levator. Secure the edges of the lids, which is the 2 edges, the medial and the lateral canthus. First thing is that is canthal injury to secure the canthus, and then go posterior to anterior. In that layer, identify the conjunctiva first, the levator subsequently, the orbicularis, and finally the skin. In case you're putting a canaliculus, you keep it for 6 weeks. If there is any devitalized or dead skin, it is best to excise those things and then suture it. You can always locally use flaps and advancement flaps to cover any defect. And if there's a lower lid avulsion and you're unsure of how to recreate or reconstruct, and there is no imminent danger of globe exposure, you can leave it as is, or as they call it, laissez-faire, and decide at 6 weeks what needs to be done. So with that, thank you so much for your time.
So thank you, Dr. Akshay. Now I would like to call upon Dr. Hitesh Sharma. He's a visiting consultant in Aditya Jyoti Hospital.
Thank you, ma'am. So at the outset, I would like to congratulate the organizing team for keeping such a wonderful CME on trauma. So the topic given to me is sympathetic ophthalmia. So what better topic in uveitis in a trauma CME? So sympathetic ophthalmia, by definition, it is bilateral diffuse granulomatous panuveitis following an accidental or surgical trauma injury to one eye. The traumatized eye is called as the exciting eye or the inciting eye, and the non-injured eye is the sympathizing eye. So it is one of the oldest clinical entities known since ages, and it has been documented multiple times. So it has been documented even in animals by some veterinary surgeons. So, but it was William Mackenzie who coined the term sympathetic ophthalmia, and he postulated the spread of inflammation from one eye to the other through the optic nerve and the chiasma. So Pritchard in 1851 he practiced excision as a therapeutic measure. Dallin, as we know, Dallin-Fuchs nodules are present. So Dallin in 1905 described the nodules on the inner surface of the choroid. Ernest Fuchs in 1905 gave the accurate histopathological description, and Elschnick was the first to postulate the role of autoimmunity in the pathogenesis. So onset from the injury, it can be as early as 5 days to even 66 years. So 80% of the cases occur within less than 3 months, 90% within 1 year, but the most critical time is 4th week to 8th week. And it is bimodal peak, common in young adults because of trauma, and in the 6th decade because of intraocular surgeries. So incidence and epidemiology. So earlier it was thought that trauma was the most common precipitating event, and most of the papers were during the World War era. And ocular surgery is now, especially VR surgery, is now considered as the major risk factor. So sympathetic ophthalmia can be seen after pars plana vitrectomy, RD surgery, cyclodialysis. It has even been documented after cataract surgery and YAG capsulotomy. So even with a non-perforating procedure like laser, cryotherapy, proton beam irradiation, even YAG capsulotomy has been documented to present sympathetic ophthalmia in the other eye. So what is the pathogenesis? So exact pathogenesis is still unknown. Multiple theories are there, like genetic predisposition, HLA association, infectious agent, retinal S antigen, and primary immune dysregulation. So genetic predisposition, HLA A20, A11 and HLA DR4 are commonly associated. Then major histocompatibility factors play a very crucial role in these. So there are susceptible patients who are more prone for such an inflammation. So as we know, it is immune privilege which is there in the anterior chamber and the overall eye which is protected. So trauma was thought to be the main factor behind most of the cases. So query infectious agent which is not proved. Pathogenesis, Rao et al. Had postulated that antigens presented to the lymphatic system produce an immune response, and thus results in sympathetic ophthalmia in rabbits. Wu and associates postulated that RP played a critical role in disease mechanism. So immunohistochemistry, it's basically a T cell associated reaction, and later on B cells are also involved. So histopathology, so there is similar in both the eyes. So there is diffuse granulomatous non-necrotizing inflammatory reaction, thickening of the posterior choroid, secondary to infiltration with mononuclear and epithelioid cells. However, choriocapillaries and retina are classically not involved. So Dallen-Fuchs nodules are the histopathological features, but it is seen in 1/3 of the patients, not pathognomic. So coming to clinical features, so symptoms, as we see, it is a granulomatous inflammation. So there will be significant loss of vision, even mild disturbance of vision can present. So most common symptom seen is change in accommodation. There could be redness, pain, and all the features of inflammation. So signs, most common sign, like the first presenting sign is the retrolental cells, and there would be granulomatous inflammation. It's a panuveitis, so entire eyeball will be involved, all the uveal tissues, and IOP can be variable. So it can just present with just a subretinal fluid at the posterior pole, and it can involve the posterior segment to mild to various severe features. It can lead to retinal vasculitis, vitritis, choroiditis, papillitis, and in chronic cases, we see the typical sunset glow fundus. So clinical features, depending upon the extent of inflammation, can be, we can guess the extent upon the severity of the serous retinal detachment and the optic nerve swelling. So differential diagnosis, all the granulomatous panuveitic entities, especially VKH, has to be ruled out. So as Akshay said, there is history taking is very important. Patients might give you a history of previous ocular injury or a knee surgery. So apart from VKH, other causes of granulomatous uveitis like sarcoidosis, tuberculosis, and syphilis should also be ruled out. So commonly confused entities, VKH, which can be seen at various ages. So there would not be any history of trauma or surgery. Skin changes, systemic features like skin changes, CNS features, hearing problem are commonly seen in VKH. So other differential diagnoses are these, but we should also rule out chronic CSCR. So chronic CSCR can also present like similarly. As we know, the diagnosis would be completely opposite. So we don't give steroids in CSCR, and steroids are the main role, have a main role in initial part of managing sympathetic ophthalmia. So if there is history of trauma, it could be sympathetic ophthalmia, lens-induced uveitis, post-traumatic iridocyclitis, or uveal effusion syndrome. No trauma, infectious, autoimmune, or other causes. So diagnostic workup, so history taking is very important. All the ocular scans, fundus fluorescent angiography, OCT, ICG, B-scan are very important. And routine tests to rule out TB, syphilis, and other infections are critical. So just a case example, here there was a history in the right eye, and the left eye presented with a subretinal fluid at the posterior pole. So angiography showed early and mid phase hyperfluorescence, and late phase showed pooling. So B scan had choroidal thickness, choroid was thickened, and there was exudative retinal detachment with shifting fluid. OCT showed subretinal fluid and the bacillary layer detachment. So given IVMP, 3 days of 1 gram intravenous methylprednisolone followed by oral steroids. So we have to start, it's a very severe inflammation, we have to start immunosuppressants also at the first go, because till the immunosuppressants start to act, the steroids will take care of it. So at the presentation, vision was 660. After IVMP, the vision improved to 636. And after around 6 weeks of follow-up, it improved to 69. So these are some other cases. So in chronic cases, we can see there could be hypopigmented fundus and a sunset glow appearance. Similarly, what we see in VKH. So management, So prompt wound closure and enucleation of the injured eye less than 2 weeks is supposed to be preventive. If wound closure not performed within 2 weeks, enucleation should be considered if the injured eye is blind or painful, and remote possibility of injured eye turning out to be one with the better vision if SO is not successfully treated. So enucleation, evisceration is controversial. Only if the injured eye has no vision potential, then that should be considered. So this is how we treat sympathetic ophthalmia. So pulse therapy of methylprednisolone 1 gram per day for 3 days. It can be extended to 5 days or even 7 days. And then shift to oral steroids, maybe 1 to 2 milligram per kg of oral steroids with gradual tapering over the next 3 months. Simultaneously, we should start immunosuppressants also. So mainly azathioprine or mycophenolate mofetil. So should be continued for minimum 9 months to 1 year. At times there are some refractory cases, so which we shift to cyclosporin or cyclophosphamide depending upon the systemic condition of the patient. If it is still not responding, biologics have also been documented to be very beneficial. So this is just the table showing the various dosages of the immunosuppressants and biologics used in sympathetic ophthalmia. So complications, so it can be secondary glaucoma, cataract, maculopathy, rarely choroidal neovascular membrane, and atrophy or phthisis bulbi. So cataract surgery in sympathetic ophthalmia has shown very good response provided the inflammation is controlled thoroughly. So again, prevention of sympathetic ophthalmia, meticulous and prompt primary wound repair is very important in the injured eye. Removal of the injured eye only if there is no vision potential. Prompt control of inflammation. So prognosis, better healthcare facilities, early intervention, superior wound closing techniques, and increased awareness has improved the prognosis of sympathetic ophthalmia. So control of inflammation with newer drugs in immunosuppressants and biologics have furthermore improved the prognosis. So with aggressive treatment, approximately 70% of the patients have visual improvement, and out of it 58.2% achieve visual acuity of more than 20/40 or better. So take home message, thorough history taking, high degree of suspicion, early diagnosis and treatment. Treatment should be very aggressive, but there are chances of recurrences, so careful follow-up and is required. Thank you. So I would like to thank my teachers from my institute, RIVHU and Shankar Nethralaya, Chennai. Thank you.
Thank you. Thank you for a brilliant and succinct presentation. There are two things that I think come out from this presentation and from Dr. Akshay Nair's presentation. Many of the PGs who are here, you might want to look up what is called as Bradford-Hill criteria for causation versus association. So even Akshay was talking about myasthenia gravis being the cause and trauma not being the cause. So one small thing that we talk about is that somebody wanted to sell Pepsi. So they went up and looked up Coca-Cola and said, Coca-Cola ka sales बहुत बढ़ता है जब ants बहुत होती है. So then they said that we should supply a packet of ants with our Pepsi. So this is what goes wrong. So just because something is associated, it is not causative. So the common factor there is heat. So because of the heat, the confounding factor. So you look at confounding factors, you look at biases, you look at whatever things can potentially be different. So you want to look at Bradford-Hill criteria for causation of a disease, or also whether your treatment is working, and that might just be it is just associated. You might have given a medicine, but that's not the thing that caused it. It might have got better on its own also. So please do look up Bradford-Hill criteria and do use them in your practice. Thank you.
Thank you, sir.
So I thank all the speakers for such an informative session. I request Dr. Avinash Ingoli, HOD of KM Hospital, to come on the stage to felicitate the following speakers, please. Welcome, Dr. Avinash. First, we felicitate Dr. Sunil Morekar, sir. पूर्वा मैम और Next, I would like to ask to felicitate Dr. Purva Valvekar Date, ma'am. Yes, yes. Then I would like to ask to felicitate Dr. Hitesh Sarma, sir. One minute, sir. Next, I would ask to all the speakers, chairman, co-chairman, moderator and co-moderator of session 3 to stand for the photo session.
Group photo, come.
Yes, you should be there, sir. कौन है? I request Dr. Jugal Shah to join us on the stage for the photo session, sir. Welcome, sir. Speakers, sir, Dr. Jaideep, sir. Yes. I like to inform everyone for short tea break of 15 minutes and we'll meet after 15 minutes now.
Presenter view na. Good evening, everyone. We would proceed with our last session. I would like to call upon stage for this session. The chairman is Dr. Prateek Gogri. Our co-chairman is Dr. Smith Bavaria. Moderator, Dr. Uday Jain. Co-moderator, Dr. Iti Jain. Please come upon the stage, everybody.
So without much ado, I think we'll start the last session of the day. So the first talk is by Dr. Prateek himself. He is a cornea, cataract and refractive surgeon at Dr. Agarwal's Eye Hospitals in Mumbai. He's been trained at LV Prasad Hospital in Hyderabad and Wills Eye Hospital in USA. He has more than 50 publications to his name and himself is a very keen surgical trainer. Over to you, Dr. Prateek.
A very good afternoon, everyone. So my talk for today is I'll be talking about the various aspects of corneal lacerations or corneal tear, to talk in simple terms. So I am a cornea, cataract and refractive surgeon at Dr. Agarwal's Eye Institute at the Vashi branch. I have no financial disclosures to be made for my talk over here. So my talk will be divided in 5 parts. First, I will be taking up the introduction, the preoperative assessment of an open globe injury in general, emphasizing mainly on the corneal tear aspect, the basics of corneal suturing. This I will be talking a little bit more in detail for our postgraduate friends. The techniques to repair different types of corneal tear repair. In this, I will be just concentrating on the simple corneal tear repairs in the interest of time, and the post-operative management. So coming to the introduction part, ocular trauma is a leading cause of monoocular blindness worldwide, and it is one of the most common cause of corneal blindness, especially in children. In developing countries, it is more common and is also more severe as compared to the developed countries, and it is more common in the younger age group, I mean children, as well as it is more common in males as compared to females. A successful surgical repair of an open globe injury and the subsequent visual rehabilitation is a topic of great significance both for any practitioner as well as the residents, so, because it helps a lot in the challenging situations which we face in our clinical practice. So coming to the preoperative assessment of the corneal tear, so a proper source, the mechanism as well as the duration of the injury is very important from the medico-legal aspect point of view also. Apart from that, we have to take the normal visual acuity, the adnexal as well as the conjunctival aspect. So coming to the corneal aspect, so there are 4 important things which have to be documented in every case of ocular trauma involving the cornea. Number 1, whether the corneal tear, whether it is full thickness or a lamellar laceration, the size, the shape and the extent of the tear has to be documented. Number 2, whether there is any uveal prolapse or any lenticular involvement, I mean the lens involvement in the corneal tear along with the corneal tear, and is there any suspicion or the presence of foreign body with the tear. Number 3, if it's a seal tear, then you have to do a Seidl's test to see if there's any active leak, either frank or forced. And number 4, last but not the least, has to be seen if there's any presence of infection or if there's any possibility of secondary infection. Apart from the corneal aspect, the lens aspect is also important to be documented in the anterior segment of the eye. So we have to see whether there's any breach in the lens capsule, whether there's involvement of the cataractus formation in the lens. Also, dilated retina fundus evaluation in cases where it is possible has to be done. So apart from that, I mean apart from examining the eye which has had trauma, it's always better and it's always important to document and examine the other eye status also. Coming to the investigations part, apart from a good slit lamp examination, in most of the cases in which there is a lenticular involvement, we may have to do a B scan for 2 things. Number 1, posterior segment involvement, and number 2, to rule out any foreign body in the eye. A CT scan in the orbit is important, especially if there is a slightest of doubt or suspicion of any iron foreign body inside the eye based on the history of the trauma. And in very rare cases, we have to consider doing an MRI. So once the preoperative assessment is done, it's better to shield the eye, start topical antibiotic medications. Along with that, if there's any posterior segment involvement, also start oral antibiotics. TT immunization status has to be documented. Apart from that, we have to start our preparations for the repair of the tear under local or general anesthesia based on the extent. So now coming to the main part of my talk, which is the basics of corneal suturing. So there are 5 components of any corneal suture. Coming to the first component, the compression factor. So if you see in the picture over here, my pointer is not seen, okay. So if you see the A zone which is there, so that is the length of the suture. So that the length of the suture has a zone of compression. Apart from that, the distance between the 2 sutures forms a zone of compression between the sutures. So the length of the suture as well as the distance between the two sutures, the zone of compression should overlap so that there is a watertight closure of the wound, corneal wound. Coming to the other 2 factors, the tissue eversion and the tissue inversion. So the tissue eversion is basically formed by the part of the suture which is there on the surface of the cornea. And the eversion force, I mean the force from besides or from beneath the cornea, is because of the bite which passes through the cornea. So in an ideal suture, both these forces, I mean the bite which is passing through the cornea as well as the corneal suture which is outside, should be equal, which this will give you a watertight closure. Coming to the next aspect, the torquing as well as the splinting effect. This is generally seen in continuous corneal sutures. These are not seen in interrupted corneal sutures. So the part of the suture in a continuous corneal suture which is on the outside part of the cornea gives the torquing effect, as well as the part of the suture which is through the corneal stroma gives a splinting effect. In a watertight suture or a suture which is adequately tight, the torquing effect as well as the splinting effect has to be equal. If at all there's any folds, if whenever you are tightening the suture, I mean the folds in the corneal stroma, that indicates that the splinting effect is more than the torque effect, and in this case you have to loosen the suture a bit. This is especially important in continuous corneal sutures. So coming to the techniques of repairing different corneal tears. So for a simple corneal tear in which the tear is sealed, the simple corneal tears can be either sealed tears, they can be flaps, there can be linear corneal tears, curvilinear tears, or triangular flaps. Complex tears will not be discussing today. So if it's a sealed simple corneal tear, so we can just put a BCL if it's sealed and there's no active ooze from the wound, and if the cut of the wound is clear cut and its partial thickness not going through and through to the cornea. But in this case, it's very important. I'll be coming to that part later. If there's a flap, if it's not a full thickness wound and a flap, and if it's in correct anatomical position and the flap is well opposed, just putting a BCL is sufficient. If the suture in these cases may actually induce additional astigmatism. If at all the flap is not well opposed, then it will require suturing. And if it's not a partial thickness and if it's a full thickness flap, then it has to be, there should be repositioning of flap, and suturing has to be done in all cases. I'll just skip this video. So this is an interesting case. This is the same patient which I had shown. There was a partial thickness, there was a self-sealed full thickness corneal tear, but when the same patient was seen on retinal illumination, it was seen that the patient has a traumatic cataract. So there were seeing a traumatic cataract and a sealed corneal tear. There was a high suspicion of corneal foreign body, any intraocular foreign body in this patient. So after doing the ultrasound sonography, a foreign body was seen in the just adjacent to the optic nerve on the B scan. And when the patient was taken up for a surgery, a corneal foreign body, an iron corneal foreign body rather, was found in the retina. I'll just skip this part. So for full thickness wounds, if the size of the wound is more than 2 mm, then definitive surgery is needed. If the size of the wound is less than 2 mm, and if it's self-sealing and non-displaced, you can just put a BCL. If it's a children or a non-cooperative patient, then in that case, better to put a suture or two. If it's a linear corneal tear, if it's a full thickness linear corneal tear, there can be either a vertical laceration, a perpendicular cut in the cornea, or it can be an oblique cut. If it's a vertical cut in the cornea, then the suture bites on either side of the cut have to be equidistant from the outside of the cornea. But if it's an oblique cut, then the suture bite should be centered on the cut which is there on the inside of the cornea. It should not be centered on the cut which is there on the outside part of the cornea. This is a very important point. Let's skip this. Also, if it's a long tear, a simple tear, but if it's a long tear which involves more than 6 or 7 clock hours in the cornea, then the sutures which are away from the center of the cornea have to be longer as compared to sutures which are involving in the central visual axis 4 mm of the cornea. This helps in better rehabilitation visually of the patient once the sutures are healed and removed. Curvilinear corneal tears are a bit tricky. In these cases, any turn in the corneal tear has to be sutured first. So in this example, suture number 1 and 2 are the sutures which are actually there at the turn of the tears. Those should be taken first and the bite should be larger. Once those edges are opposed, then we can take the later sutures, and the sutures which are near the center of the cornea has to be taken first in such cases. Triangular flaps again are very tricky. In triangular flaps, always the apex of the triangle has to be sutured first, and after that the sides of the triangles can be sutured. So in post-operative management, it is very important to take a best corrected visual acuity at each and every visit, and the normal eye also has to be screened for systemic ophthalmia. The take-home message are necessary pre-operative assessment, investigations and counseling play an important role in the management of any corneal tear. The goal of surgery should always be kept in mind, whether it is appositional, the anatomical as well as the functional goal. We should aim to achieve watertight closure at the end with minimal astigmatism, and it should not be just an air bubble closure, but it should be a watertight closure. And proper surgical techniques helps us to achieve most of these goals in the primary treatment. Thank you everyone for your patient listening.
Thank you, Dr. Pratik, for your comprehensive talk on corneal tear. Next, we'll have Dr. Iti Jain, who's a second-year resident at KEM Hospital, to discuss about keratoconus fistula.
Good afternoon, everyone. I'm Dr. Iti Jain from KEM Hospital, and I'll be presenting a case of delayed presentation of keratoconus fistula under the guidance of Dr. Avinash Ingole. So we'll be discussing about a unique case presentation, what is cavernous sinus and what is keratoconus fistula. So let's begin our case discussion. We have a 23-year-old male patient who came to us with chief complaints of left-sided painful and diminution of vision with bulging of eyeball, periorbital edema and congestion since last 15 days. He had past history of road traffic accident 3 months back, which led to para-aortic hematoma, aortic transaction and splenic laceration, which was managed conservatively. On systemic examination, CNS and RS examination were completely within normal limit. So he underwent CT scan outside, which was suggestive of orbital cellulitis, for which injection steroids and antibiotics were given. But it did not improve at all. So he came to our center, where ophthalmic evaluation was done, and on an examination, his vision in left eye was finger counting 3 meter with axial proptosis, periorbital edema, pulsations were felt over the superior medial aspect of the eye, chemosis, circumcorneal congestion with corkscrew vessels, extraocular movements were restricted in all the gazes, and intraocular pressure were raised to 24 millimeters of mercury. On proptosis evaluation, exophthalmometry of left eye suggestive of 35 mm in size. The swelling was compressible but not reducible, and bruit was heard over the superior orbital notch. Valsalva was not done since the bruit was heard. His pupils were fixed and dilated. Rest anterior and posterior examinations were completely within the normal limit. So we did the CT scan again for the patient. Did you notice anything? Okay, let me point it out for you. Here we can see dilated superior ophthalmic vein, which is going from medial aspect to the lateral aspect. Hence, the DSA was done, which was suggestive of direct drainage from internal carotid artery to cavernous sinus. Hence, the diagnosis of delayed onset direct type of keratoco-cavernous fistula was made. Ophthalmologically, patient was managed for exposure keratitis and raised intraocular pressure, and definitive management by transvenous balloon-assisted endocoiling was done. So we have a post-op day 2 presentation of patient where bruit was reduced and the IOP was managed. So what happened exactly? What was CCF? What is cavernous sinus? We need to study them one by one. So cavernous sinus is a dural venous sinus lying in the middle cranial fossa, having important structures like internal carotid arteries, cranial nerve 3rd, 4th, 6th, V1 and V2. Along with it, from orbit, superior and inferior ophthalmic vein drains directly into the cavernous sinus. Hence, what is CCF? It's a dural AV fistula where high pressure arterial blood flows to the low pressure venous area and having engorged ophthalmic vein. So based on the communication, it can be of two types, direct type and indirect type. Direct type has a direct communication from internal carotid artery to the cavernous sinus, while indirect have communication via meningeal branches of the carotid artery to the cavernous sinus. Barrow has also classified into type A, B, C, and D. Type A is a direct type, while type B, C, and D are indirect type. In type B, meningeal branches of internal carotid artery drains into cavernous sinus, and in type C, meningeal branches of external carotid artery drains into the cavernous sinus. Direct can be mostly seen in trauma cases. Along with it can also be seen in ruptured aneurysms, arterial dissection, while indirect is mostly seen in spontaneous cases, pregnancy, hypercoagulable states. Other than the communication, we can also classify it on the basis of etiology, which can be traumatic or spontaneous, or on the basis of flow, which can be high flow or the low flow. Clinically, it classically present as a Dandy's triad, which includes pulsatile exophthalmos, bruit, and chemosis. Along with it, as in our case, patient can also present with ophthalmoplegia due to the involvement of cranial nerve 3rd, 4th, and 6th. So what are we going to do for that patient? We have to do CT scan. CT angiogram suggestive of dilated superior ophthalmic vein and proptosis, while DSA suggestive of drainage from carotid artery to the cavernous sinus, and MR angiogram is suggestive of enlarged superior ophthalmic vein. So how do we approach the patient? Direct cases needs to be managed on emergency basis by endocoiling, while indirect cases type B, C, and D can be managed on the basis of severity. If it is not that severe, we have to wait and watch. Spontaneously, 60% of the cases resolve, and 30% of the cases, we just have to do carotid massage and it resolves on its own. But if it's severe or in type A cases, we have to do endocoiling. It can be done transarterial, transvenous, or transorbital. So what did we learn from our case? If we would have examined the patient properly and if we would have taken the proper history, we wouldn't have missed the case of keratoco-cavernous fistula. It's because it is basically a clinical entity. We can diagnose it on our examination only. We don't need to do any evaluation or CT examinations. So for take-home message from my PPT is to take proper history and examine patient properly. Thank you.
Excellent talk, Dr. Iti. Now, we'll ask Dr. Uday to deliver a lecture on vitreous hemorrhage, traumatic vitreous hemorrhage.
Hi, good evening, everyone. So again, I'll have a short presentation with 2 short surgical videos in the interest of time to explain the, 2 challenges, one simple and one not so simple case of vitreous hemorrhage. So vitreous hemorrhage can occur both in open and closed lobe injuries, and the source of the hemorrhage is variable. It can occur from any part of the body, from the eye, from whether it's the root of the iris, the ciliary body, the retina, or the choroid. Rarely, even a complete optic nerve head avulsion can present as a vitreous hemorrhage with no light perception vision. As we know, a fresh vitreous hemorrhage is bright red in color, and as it becomes old, it turns gray because of changes in the hemosiderin levels. And traumatic vitreous hemorrhage without any visible open lobe injury, you have to always suspect an occult scleral tear, which can be seen if there is any hypotony on a digital examination. If the anterior chamber depth is asymmetrical, it can be shallow or deep. Or if there's any subconjunctival hemorrhage with the posterior extent not visible. These are some signs which can make you suspect that yes, there could be an occult scleral tear. So you need to do a globe exploration and try to look for a scleral tear. So the timing of intervention is actually quite controversial. Like we had a previous talk which recommends taking up the case within the first 14 days. The indications of an early intervention are usually hyphema with corneal blood staining or high IOP, an associated detachment, or an associated intraocular foreign body. In the absence of these, in the pre-MIVS era, there used to be a concept of wait and watch for up to 3 months for the hemorrhage to resolve. But in today, with 23 and 25 gauge vitrectomy available, the trend is to go in for an early intervention. So the most important investigation is actually a USG B scan, which is an OPD based thing, which is very important for the operating surgeon to do himself. You have to rule out a retinal detachment in all quadrants. You have to look for hemorrhagic choroidal detachments, and if they're present, are they liquefied, are they still solid, which is the highest point of the hemorrhagic CD is very important. If there is no light perception, look for optic disc avulsion on B scan, look for a retained foreign body, and look if there is presence of posterior vitreous detachment on the B scan or not. If there is PVD, it makes the surgery much easier. Radiology, either an X-ray or a CT nowadays, is important to look for a radiopaque foreign body. But if all of this, if there's one thing I want you all to take from this slide is please do the B scans yourself. The prognosis, however, is usually poor due to macular scarring, choroidal ruptures, a retinal detachment, intraop, or in children because of dense amblyopia that can occur because of a vitreous hemorrhage. And less than 50% patients get a vision of better than 6/60. And you always have to be prepared for intraoperative surprises. So whenever you go in for a patient of a patient with trauma, be prepared for intraoperative dialysis, intraoperative macular holes, so you can prognosticate the patient realistically, and so that he has more realistic outcomes. Can I have my videos, please? Samir, videos. So I'll be showing 2 cases. The first case is a relatively simple, straightforward case of a VH. So this patient actually came to us 3 months after an open lobe injury with the sutures removed. You can actually see the vitreous stands and the hemorrhage completely pulled up towards the site of the injury nasally. Standard 3-port pars plana vitrectomy was done. We went in with a pars plana infusion port because we could visualize the infusion cannula since the vitreous hemorrhage was gray. After doing some amount of anterior vitrectomy, we could see that the retina was well attached, but there was a lot of premacular fibrosis and scarring which was seen. So the prognosis was guarded. The patient was already told that while the retina seems attached, we'll clear the hemorrhage, and whatever visual outcome comes will be his luck. So this patient ultimately did not gain much. He was only counting fingers vision at the end of surgery. And after confirming PVD, doing some amount of a base dissection to look for any retinal dialysis, the case was closed and all the ports were sutured. So this is a relatively straightforward case of vitreous hemorrhage. This was actually a more challenging case because this patient presented to us only 2 weeks following trauma with a well-sealed corneal laceration, and he was taken up this early because his IOP was persistently high. Now, I did the B scan myself, and I was very sure that there is a complete posterior vitreous detachment with a vitreous hemorrhage. But as the case goes on, I'll tell you what happened and what my mentor kept telling me. So as you can see, the media is very bad. Go in with an anterior chamber maintainer, make a limbal entry, clear the hemorrhage in the anterior chamber, dissect whatever membranes are there. Then we decided to make 2 pars plana ports. My non-dominant hand was being blocked by a lot of vitreous hemorrhage, so the entire view behind was red, not making the vitrectomy with my dominant hand possible. As you can see, it was completely blood red inside. So decided to change hands. Very important as surgeons to use your non-dominant hand as well during surgery. So went in, did some amount of anterior vitrectomy. So these eyes with traumatic bleeds, the hemorrhage is usually consolidated, very stormy, fluffy. The entire anatomy is distorted. Very often you don't know what you're cutting. There will be times when, if you're a VR surgeon, you think you're going in for a vitreous hemorrhage and you'll end up cutting the retina. But thankfully that didn't happen in this case, contrary to what my senior felt. So this membrane which was there behind, my senior kept telling me, you're cutting the retina, you're cutting the retina. But I was very confident that I had done the B scan myself. So you have to go slow, go layer by layer, keep cutting the vitreous, and make an opening, preferably in the upper nasal quadrant, so you can visualize the retina behind. So once you can see the optic disc and some semblance of the retinal vessels behind, that gives you a little more confidence that, okay, you're actually not cutting the retina. And then you go layer by layer, slowly, keep dissecting the bleed. View is always compromised in these cases because of the corneal staining, because of the central corneal scar, but it's a patient game. So as you can see, the hemorrhage is consolidated in layers, and slowly as the hemorrhage is clearing, you can see the retina behind. The retina is very healthy and very well attached. So cut as much vitreous as you can. Don't chase the peripheral vitreous to a huge extent. If there's no retinal detachment, don't cause it, don't create it. If you can't see a break, don't go searching for it. It's fine. Just do a good vitrectomy, some amount of base dissection, because the purpose of this is to clear the media and to get his IOP down, because he had some amount of ghost cell glaucoma as well. And once you've done with a good amount of vitrectomy and you know that the retina is attached, then you just need to close the case under air and suture the ports. Okay. So most important thing, if I want anyone to learn from any case of a traumatic VH, is please do your B scan yourself, so you know what you're going into and you know what to be prepared for to a good extent. And still, in spite of everything, you might still end up with something odd on table. So just always be prepared. Thank you.
Excellent talk, Dr. Uday. Now I would like to request Dr. Apurva for her next talk on corneal laceration with traumatic cataract.
Good afternoon, everyone. I am Dr. Apurva Ranjalkar, a third-year junior resident at LTMMC Sion. I am here to present a case of corneal laceration with traumatic cataract that we recently operated at our center. This is a case of a 19-year-old male resident of Kurla, welder by profession, who came with a history of accidental trauma to right eye with a metal piece while working 1 day ago. Patient was first went to a private hospital, from where he was referred to Sion Hospital for further management. Patient had no history of similar complaints in other eye, no history of spectacle use, any systemic illness or ocular trauma or surgery in past. On systemic examination, the patient was conscious, cooperative, and well-oriented to time, place, and person, and vitally stable. On ophthalmic examination, in right eye, the best corrected visual acuity was PL positive and PR accurate. Lids were normal. Conjunctiva showed congestion. In the cornea, there was a full thickness corneal tear of 5 to 6 mm, extending from the limbus obliquely upwards towards the pupil with iris tissue plugging. The AC was shallow with hyphema. The pupil was peaked inferotemporally. The lens showed traumatic cataract and the tension was digitally low. The anterior segment findings in the left eye were within normal limits. On fundus examination, no view was there in the right eye, and the fundus were normal in the left eye. This is a clinical photograph showing conjunctival congestion. In the cornea, we can see a corneal laceration extending from the limbus superiotemporally, a 5 to 6 mm tear with iris tissue plugging and peaked pupil. And the anterior chamber shows hyphema. The blood investigations of the patients were within normal limits. We performed a CT scan, a plain axial CT, which showed soft tissue edema in the periorbital region, but no evidence of any fracture or foreign body. In the management, we first gave IV antibiotics to the patient for 5 days. And locally, the patient was started on eye drop moxie for 4 times a day and atropine for 2 times a day. In surgical management, we went with a corneal tear repair with 6 interrupted sutures with 10-0 nylon with hyphema wash and lens aspiration under local anesthesia the same day. This is the post-operative picture of the patient. Traumatic cataract is a clouding of the lens that may occur after either blunt or penetrating ocular trauma that disrupts the lens fibers. Cataracts may form immediately after trauma or months to years later. Rapid cataract formation is typically a result of lens capsule rupture with seepage of aqueous humor into the lens fibers. If there is no capsule rupture, it is suspected that the traumatic forces damage lens fibers, leading to cataract formation. In case of trauma to lens, there are 2 sequelae that can occur. First, the lens can get dislocated or there can be a cataract formation. In dislocation, if the lens comes out of the patellar fossa, it is known as luxation. And if it is dislocated within the patellar fossa, it is known as subluxation, which can be either anterior or posterior. And cataract formation can be partial or total. In partial, it can again be stationary or progressive in nature. Types of traumatic cataract according to morphology can be total, membranous, in which both the capsules fuse with little or no cortical material. It can be wide, soft, or a rosette cataract. The causes of ocular traumatic cataract can be penetrating, blunt trauma, in which we can see a typical sunflower-shaped opacity, or electric shock, which is rare, showing multiple snowflake-like opacities, or stellate subcapsular distribution. Infrared radiation can also lead to cataract formation, which is typically described as a glassblower's cataract. Or ionizing radiation will lead to posterior subcapsular opacities or a chemical burn. The examination signs in Birmingham eye trauma terminology, it was developed as a standardized method for documenting ocular trauma. The visual acuity, preoperative visual acuity helps predict the best corrected visual acuity after removal of the traumatic cataract. The third is intraocular pressure should be examined. It is low in cases of open globe injury or a cyclodialysis cleft. And IOP can be elevated in cases of lens-associated glaucoma, which can be a phacomorphic, which is the most common, or lens particle or phacoantigenic glaucoma, or hyphema, in which the blood particles will lead to obstruction of the trabecular meshwork and hence increased IOP, or angle recession glaucoma, which is seen in chronic post-traumatic setting. In case of the examination of cornea, severe corneal damage and haze may limit the preoperative assessment of cataract. A sealed anterior chamber is necessary to avoid fluid leakage during cataract surgery. And anterior lens subluxation may also lead to corneal decompensation as a result of lens endothelial touch. Coming to the management of the lens, it can be done as a primary procedure or a secondary procedure. A primary procedure in which it is performed immediately following open globe trauma, or a secondary procedure in which the management of lens is deferred weeks to months after the trauma. In this, the removal of the traumatic cataract should be performed immediately in cases of capsule rupture, if there is lens material in the anterior chamber, or in a case of phacomorphic glaucoma or any other conditions which place the patient at high risk for developing inflammation and raised IOP. The benefits of primary extraction are that it will lower the cost and time of a single surgery or hospital admission, minimize the risk of developing elevated IOP and synechia, and decrease visual rehabilitation time and risk of amblyopia. Whereas the benefits of secondary extraction are that the potential for more accurate intraocular lens calculation and improved visualization during surgery. The integrity of the anterior capsule is seen using trypan blue dye intraoperatively, which will help us identify tears in the anterior capsule. We should always keep a high suspicion for capsule rupture in case of traumatic cataract. If the anterior capsule is intact, we should normally go for a continuous curvilinear capsular access like we do in normal cataract surgeries. And if the anterior capsule is already ruptured, we can cut with Vanna's scissors and then go ahead with phacoemulsification or irrigation aspiration. In case of zonular weakness or dialysis, the surgeon can place iris or capsular bag hooks to secure the bag for cataract extraction. CTRs, that is capsular tension rings, are indicated if zonular dialysis is present in for 30 to 90 degrees of zonular fibers. The surgical treatment type of surgeries can be divided into standard phacoemulsification with IOL, which is done in case of intact posterior capsule with good zonular support. Intracapsular cataract extraction can be done in cases of anterior dislocation or extreme zonular instability. And pars plana lensectomy and vitrectomy can be done in cases of posterior capsular rupture with posterior dislocation. Coming to the cataract morphology and extent of damage of other ocular tissues help determine the surgical planning and technique. If there is a cataract with hard nucleus, we typically go ahead with phacoemulsification, while in case of white, soft or rosette cataracts, we typically use unimanual or bimanual aspiration of the lens. The complications that can occur with traumatic cataract are vitreous prolapse. In this case, the vitreous should be removed with a second instrument through a lateral incision, and anterior vitrectomy should be performed. The hyphema, if blood is present in the anterior chamber, it should be washed thoroughly and removed as soon as possible because to reduce the risk of hematocornea, that is corneal blood staining. Then coming to the IOL placement, the type and optimum placement of the IOL depends on the clinical context. If visualization is poor, consider placing the IOL in a later secondary procedure. If the capsular bag is complete and intact with a good zonular support, we can go ahead with placing a one-piece acrylic IOL in the bag. And if the capsule is ruptured or we do not have a good support, we can go ahead with placing three-piece IOL in the ciliary sulcus. The prognosis, several factors have been identified to predict visual outcome in patients with traumatic cataracts. A good prognostication tool is the Ocular Trauma Score, which was developed in the early 2000s to predict the visual outcomes after ocular trauma. It includes factors such as visual acuity, presence of globe rupture, endophthalmitis, perforating injury, retinal detachment, and an afferent pupillary defect. In my case, the ocular trauma score was, the raw score was 53 and the OTS grade was 2 of the patient. Thank you.
Thank you so much, Dr. Purva. So next we have Dr. Smith, who's a consultant at Agarwal's Eye Hospitals, to give us talk about pupilloplasty and single pass fourth row technique.
Good afternoon, everybody. I know it's been an exhausting session, post-lunch, post-tea break, but still, I won't take much time. Most of our audience now are resident doctors, so I would like to know how many of you have thought of doing pupilloplasty in residency? Because our days when we are doing residency, our days will get satisfied whenever we get to touch the cataract, pterygium, or any tear or any trauma patient. We will never thought of doing pupilloplasty during residency. We will never get a chance to do it, but what I would like to suggest through this lecture is, as an anterior segment surgeon, it is one of the most important surgery, at least we should have in our pocket. You know, it will take some time to get used to it because iris is most friable tissue inside the eye. So the purpose of this talk is to just give you little bit of encouragement to start learning this iris suturing thing in a enucleated eye, so that when you start doing your further fellowships or further practice, you will understand the importance of the knowing any of the suturing technique inside the eye. So the single pass fourth row pupilloplasty, SFT, the term was coined by our chairman, Dr. Amar Agarwal, and he is the one who has pioneered this technique since many years now. The significance of pupilloplasty in our eyes are such as like we need to give a proper anatomical and functional support by maintaining the AC depth. It also prevents the glare photophobia in the fixed dilated pupil, because most of the traumatic cases, though it's a blunt trauma, whenever they come for the cataract surgery, they have mild or severe dilated eyes. In such cases, if we just remove the cataract, it will never satisfy the patient. We need to make sure that we give them proper rehabilitation of the issues like glare and photophobia. It also allows the graft unrolling and adherence. When you pursue your cornea fellowship, this is going to be important for you to do endothelial keratoplasty, because it gives you the proper diaphragm so that your graft will never roll down. It helps to repair the iris defect. When we are learning the cataract surgery, I'm sure everybody will have one bad day and you will end up eating some tissue with the probe, or there are some unexpected complications which will end up in iris damage during the surgery. Either it is iris tissue prolapse, positive pressure because of the positive pressure, or something else. In such cases, we should understand the basic concept of iris defect repair. It also helps to release the peripheral anterior synechiae responsible for the primary angle closure and secondary angle closure cases. We'll not go much in detail about this, but it also, whenever we pull there is a syndrome called Uret-Zavalia syndrome. I will show you some picture about this, and then you will understand the importance of iris repair or SFT in certain secondary or primary angle closure glaucoma. As I said, where we need to modify or repair the iris, the most common is the functional difficulties such as glare, photophobia or diplopia. Second is the condition where the restoration of the iris diaphragm of a multifaceted surgical reconstruction. A large iris defect might require a closure to support an anterior chamber intraocular lens. Otherwise, the lens will always be popping up, and whenever we have a certain cases like iris coloboma or lens coloboma, in such cases also we always suggest that the suturing of the iris will provide a proper support to the lens, and the ELP will be maintained throughout a longer period of time whenever we have any kind of pupilloplasty done in that area. The corneal transplant surgeons will surgically tighten the fixed dilated pupil during the penetrating keratoplasty to restore the iris diaphragm, reducing the risk of iris shifting forward, adhering to the endothelial surface, so that it will also help them to maintain the endothelial count for a longer period of time during the surgery and post-surgery as well. It will also make sure that the peripheral anterior synechiae will get released, so that chances of secondary glaucoma post-PK will be also reduced. The third clinical situation, by far very rare, but some patient comes with the cosmetic purpose also. If someone has done any surgery where the iris has been destroyed, or some patient have a congenital defect, they might come to you because their photographs will show a different red glow. So there were different techniques before, mechanal techniques, where we pass the suture from the one end and then take the suture out from the opposite part of the iris and try to hook it out in the front, in the superior aspect of the eye, and then take a note there and slip the note inside. That was the mechanal technique. The Sheen modified that technique with the help of a cannula. Rather than passing a direct suture inside the iris, he used the cannula and then apply the same technique to take a suture inside. Sipser note, sliding note is also one of the technique. Today I want to talk about more of a SFT, single pass 4-throw pupilloplasty, because this is most easiest way to take a suture, because we are not going inside the eye to take suture. We are taking a suture outside the eye and then sliding it inside. So I would like to show the video first. Sorry. So that one can have the idea how the SFT works. This video is created by our AV team at Agarwal's Eye Hospital.
Let's mark the iris before we begin. To any iris defect, there is a proximal iris where you enter and a distal iris where you exit. Step 1. Make a stab incision on one side of the iris defect. This can be the distal incision. Step 2. A 10-0 proline suture is passed from the opposite side. This can be the proximal incision through the proximal iris and left in situ. Step 3. A 26-gauge needle is then passed through the distal iris. Step 4. The needle of the 10-0 proline is passed into the lumen of the 26-gauge needle and railroaded to the distal incision and pulled through to the suture end. It's now important to understand the suture trail as it traverses the iris. The trail consists of 5 parts. Part 1. External to the proximal incision. Part 2. Proximal incision to the proximal iris. Part 3. Proximal iris to the distal iris. Part 4. Distal iris to the distal incision. Part 5. External to the distal incision. A loop of suture as depicted is taken from the part 2 of the suture, pulled out through the distal incision and made to lie on the conjunctiva. The part 5 of the suture is now cut, and the cut end is thrown into the loop of part 2 4 times, hence showcasing the 4th row of this pupilloplasty. Now, to tie the iris defect together, we take part 1 and part 5 of the suture pass and pull them away from each other externally. This pull brings about a helical pattern to the 4th row knot. Now, as the knot approaches the iris defect intracamerally, it brings the 2 sides of the iris defect closer. Finally, when the helix of the knot comes in contact with both the proximal and distal iris, it intertwines it all together to complete the knot. Now a micro scissor is taken and the suture cut close to the knot, thereby completing the single pass 4th row pupilloplasty.
So technically this is very easy to perform once you have a practice on the enucleated eye. It will take at least 3-4 times once you pass, because when you pass the suture through the iris, you will get more and more cheese wire initially, but once you have that control on your hand, it will become easier for you to perform SFT. The Urate-Zavalia syndrome, what I was mentioning before, that angle closure glaucoma. So if you see, because of this anterior synechiae, the angles are completely closed and the patient have a very high IOP. In such cases, we can also release this synechiae manually. It may bleed little bit, but then once you release these synechiae and once you do a SFT or a pupilloplasty, the angles will be open forever. And just a short video on that. You can see the angles are getting open after synechiae break and taking a single pass 4th row pupilloplasty in that particular cases. So the most of the Urate-Zavalia syndrome cases now, we are treating with the SFT only. This is again a last video I wanted to show. So the railroad technique is very important. By that way, you will have a control of the needle when it is inside the eye. And once you take the loop out, what you all have to do is to just pass the thread 4 times. That's why we call it 4th row. And actually it is not a knot, it's just the helical, it's just the circling of the suture. So the knot related complications are also very less in such cases. It will be important when you have a endothelial keratoplasty, because there is no knot inside. Now we are planning to do the reverse also. Will not show here, but the whatever the helical we are creating, it will be on in a posterior part of the iris. And the last thing is the refractive outcome. The SFT can be used as a pinhole pupilloplasty. Again, that we can create a pupil in such a small size, 1.5 to 1.8 millimeter, that will act as a pinhole in front of the eye. So higher order abrasion, very severe astigmatism, keratoconus patients, corneal scar patient, post-PK patients, where the clarity of the vision is not there because of higher order abrasion, we can always use SFT to create a pupil in a pinhole size, and that will work as a pinhole pupilloplasty. And definitely there is no change in the field defect when we create a pupil small. We know that our retina colleagues will never like to have this small pupil in the eye, but as a cornea or anterior segment surgeon, we will always prefer 6/6 vision, N6 vision without disturbing the cornea. So this is one technique we can always. So once you expertise the pupilloplasty or SFT in an initial period, you will always have this weapon in your hand to create pinhole pupilloplasty in certain demanding cases as well. Thank you.
Thank you, Dr. Smith. Now we have a short video from Dr. Natarajan on his gift of sight.
Welcome to the world of sight, to the world of color and beauty. A single misfortune, and this gift is lost forever. It takes passion for work, passion in life, passion in passion to attempt to salvage this precious gift. Here's a little peek into our journey in this field at Aditya Jyot Eye Hospital. future holds a lot of promise. With advancing technology and millions of dollars being spent on research, the dream of an artificial retina is not far away. Restoration of sight, and not just structure, is a distinct possibility.
Now we'll request Dr. Shreyal for the last talk of the day and the evening.
Good evening, everyone. I'm Dr. Shreyal Kori. I'm third year junior resident from Lokman Municipal Medical College and General Hospital, Sion. I'll be presenting a talk on risk factors and outcomes of canalicular tear repair with stent placement in pediatric patients. This is a study that we did in our hospital. Eyelid injuries are a common and frequent manifestation of ocular trauma which require a thorough examination, including examining canalicular patency and other ocular adnexal structures to ensure proper functioning and cosmetic recovery. An abrupt physical injury that damages the canaliculus, part of the lacrimal drainage system, is referred to as canalicular trauma. The medial aspect of the eyelid contains the lacrimal canaliculi. This area lacks a tarsal substructure which distinguishes it from the rest of the eyelid. A force that pulls the eyelid away from its strong attachment at the lacrimal maxillary bone and medial canthal tendon would therefore likely result in an avulsion in the medial aspect of eyelid. We did a retrospective study at our center for pediatric patients less than 12 years of age who underwent monocanalicular tear repair with silicone oro stent placement between Jan of 2023 to December 2023. Data including demographic details, mode and time of injury, associated ocular injuries, surgical interventions, intra and post-operative complications were collected from hospital records. Preoperative plain axial CT scan of orbit was done for all patients to look for fractures and foreign body in wound. Detailed anterior and posterior segment examination was done for all patients, pre and interoperatively under general anesthesia for uncooperative cases. All children underwent canalicular tear repair with silicone stent placement. We used the trade name Oro stent, which is 40 millimeters in length and 0.64 millimeters in diameter, under general anesthesia within 24 hours of injury and under intravenous antibiotic cover. 4 cases had associated lid tears which were repaired with primary suturing, while 1 had an anterior lamellar defect that needed a full thickness skin graft placement to repair the lid defect. All patients were prescribed topical steroid and antibiotic drops 4 times a day, and all parents were advised about post-operative eye care. Patients were kept on follow-up for post-operative day 1, 3, week 1, week 3, and then monthly. Stents were removed on elective basis after 6 months, and canalicular patency was ensured by syringing. These are a few pictures. The first picture shows a canalicular tear in the lower lid. The second picture shows the localization of the distal end of the tear. The third picture shows the passage of a stent from the proximal end. And the fourth picture is a case that we had to do a full thickness skin grafting where we harvested skin from the postauricular region. The mean age of the patients was 5.6 years with a male to female ratio of 3:2. 3 patients had come directly to casualty while 2 were referred from other hospitals. 4 cases involved the lower canaliculus while 1 was an upper canalicular tear. 3 were due to accidental injury while playing, 1 was due to injury with metal hanger, and 1 was due to blouse hook injury, which was previously described by Akshay Nair sir as FACT, feeding associated canalicular trauma. Most commonly associated ocular comorbidity was subconjunctival hemorrhage, found in 2 out of 5 patients. 1 patient returned after 2 months with a prolapsed stent, which was reposited manually as an OPD procedure. All stents were removed at 6 months post-operatively. Canalicular patency was maintained in all the cases. None of the patients reported with complications like epiphora or punctal granuloma. This is a tabular form of our results where there was a male to female ratio of 3:2. 80% tears involved the lower canaliculus. Right side was affected in 80% of patients. Blunt trauma caused only 20% of tears, while the interval between injury and repair was less than 24 hours for almost all patients. These are a few intraoperative pictures. The first picture shows an upper lid canalicular tear repair. The second picture shows a canalicular tear repair with a full thickness skin graft because there was an anterior lamellar defect and we harvested skin from the post-auricular region. This is a lower lid canalicular tear repair with stent placement. In all the cases, distal end was identified either by instilling local adrenaline drops which caused blanching of the mucosa or instilling dye in the upper canaliculus in cases of lower canaliculus tear where the lower canalicular distal opening would be stained. Our findings were corroborated by a similar study done by Wang J et al. In 2023. The goals of eyelid repair were to re-establish anatomical configuration, restore physiological function, and provide a better cosmetic outcome. Meticulous eyelid Martian closure is important. Inadequate closure can lead to notching, lag of ophthalmos, and external exposure keratopathy. Eyelid tear repair without maintaining proper canalicular patency may lead to stricture and stenosis of the lacrimal drainage system, leading to epiphora. Canalicular tears should be carefully looked for in an injury involving medial canthus, and canalicular patency should be re-established before undertaking eyelid tear repair. A silicone stent or a 22-gauge intravenous cannula or a yellow intravenous cannula after removing the sharp stellate can be used for canalicular tear repair. Whenever required, a multidisciplinary approach in management of large eyelid tear repairs should be considered. In conclusion, males were more commonly affected than females, mainly at the lower canaliculus, most commonly due to a sharp object injury. Sharp trauma involving eyelid, metal hanger, and blouse hook were risk factors for canalicular trauma. Timely diagnosis of canalicular tear in all cases of lid trauma was essential to preserve anatomical, functional, and cosmetic function of eyelids. Early repair within 24 hours of such cases with a silicone stent gave an excellent outcome. Routine postoperative follow-up of such patients is mandated to look for postoperative complications like stent exclusion as well as to plan timely stent removal. These are my references and acknowledgements. Thank you.
I would like to thank all our speakers for this session. Now I would like to call upon the stage Dr. Jaideep to honor our speakers. Dr. Prateek. Dr. Iti Jain. Dr. Apurva. Dr. Smith Bavaria. And Dr. Shreya. I would request our speakers to please gather for a photo session. I would request Dr. Jaideep to please give a vote of thanks.
So we come to the end of this very intriguing and interesting session on ocular trauma and adnexal trauma. So to wind up today's proceedings, I will just give a brief vote of thanks quickly. So at the outset, I would like to thank Dr. Natarajan for giving us this opportunity, and it was a great pleasure to be a part of organizing this CME. Even after I'm not a part of Aditya Jyot anymore, but it was a great pleasure to be up here again. And I'm sure we have new faces who have taken over, and Joseph sir is always here. So to start with, I would like to have express my pleasure and heartfelt gratitude and thanks on behalf of the entire organizing committee to each and everyone who has made this meeting a remarkable success. First and foremost, I would like to express a deep gratitude to the Honorable Dean of Nair Hospital, Professor Dr. Sudhir Medkar, sir, for his unwavering support and guidance throughout this event and for gracing this occasion. Also, our special thanks to our keynote speaker, Professor Gangadhar Sundar, who has come all the way from Singapore and given his valuable insights on adnexal trauma and given encouraging words to all our speakers. As usual, we are truly indebted to our chairman, organizing chairman, Padma Shri Professor Dr. S. Natarajan, for conceptualizing and guiding us in organizing this event. His support and encouragement has always been truly inspirational for all of us, and those who have worked with him know about his enthusiasm, and we are really delighted to work with him. Also, our special thanks goes to our co-organizing chairman, Professor Dr. Nayana Poddar, who is the head of Department of Ophthalmology at Nair Hospital, and for her efforts and invaluable insights, and for providing us the platform to having this CME in this premises. I extend my heartfelt gratitude to our guests of honor, Professor Dr. Sujata Chandade, HOD of Ophthalmology, Sir JJ Group of Hospitals, Dr. Karishma Wadia, who is Honorary Secretary of BOA, and Professor Chaya Shinde, Head of Department of Ophthalmology at Sion Hospital, who have all graced the occasion and given us an opportunity to learn from them. I would also like to extend our sincere appreciation to our organizing secretaries, Dr. Smith and Dr. Uday, who are sitting right here in the front, and your planning and coordination, as well as the execution of this event, has made it a grand success. I'd like to extend my thanks to our chairman, co-chairman, and moderators from each sessions who have, all of them who have attended, and everybody has been there on time and moderated the sessions excellently with good discussions. I also thank all the speakers for their valuable and excellent presentations with good insights into this not so common topic on ocular trauma and adnexal trauma. Our special thanks to Dr. Jugal Shah for agreeing to be the MMC observer for this CME, because without that we cannot get the CME credit points, which are now mandatory. So thanks to Dr. Jugal Shah for coming here and giving his valuable time. We are also grateful to the entire office bearers of MOS for their support and kind permission for holding the CME under their aegis, because we always look to have these big events under the aegis of the umbrella societies, and MOS being one of the oldest societies in Maharashtra. Special thanks to our sponsors, of course, without whom we cannot hold such events. So I'm not sure if anybody is there around. We could have felicitated them, from His Highness, Alcon, Entod, Bayer, Ajanta Pharma. I don't think anyone is there, but we would like to extend our heartfelt gratitude and thanks for sponsoring this event. Finally, I would like to thank all the participants, attendees, and everyone who has contributed in any way for making this event a grand success. Your presence and participation has made this event truly special. And last but not the least, I would extend my sincere thanks to the entire staff of Kamala Sundaram Foundation and Aditya Jyot Eye Hospital. With special mention, I think here, Joseph sir, who's always been our guiding star. Big round of applause to him. Mr. Pradeep, Mansi, Prathamesh, from Aditya Jyot, Ms. Shubha, Meena, Ms. Neeta, Samir, who's always been our backbone of our IT team, Sanjali, Jyoti, Manasvi, Ashri, Vinay, and if I've forgotten to mention anybody, please excuse me. Also, I would like to thank our IT team who has been here throughout the day, and really a round of applause to them. They have really made this event quite seamless without any glitches. Of course. And our photographer here, Mr. Stephen John, who's done an excellent job throughout the day and has never been tired for clicking any of the photographs. He's always excited more than the people who are getting clicked. So thank you for being there and making this event special, and your entire team. Lastly, also we thank people who have come from Khalsa College, the Leo Club of GN Khalsa College, President Mr. Leo Pritam Patel, who has kindly allowed his students to come here and help us out. The entire YouTube team who has been streaming this content live on the YouTube, and everyone else who has been working in the background. Thank you, everyone. And we thank you once again and look forward for many more successful collaborations in the future. And with that, I'll sign off for today. Thank you. And if I've missed anybody, please excuse me.
I would like to thank Dr. Jaideep sir for his support throughout the program and his consistency for us. Thank you so much, Jaideep sir. So the students from Khalsa College, Leo Club of GN Khalsa College, kindly come on the stage for the photograph. And all the doctors and reporters.